Ending Child Sexual Abuse and Exploitation, a review of the evidence 99. Trial of EHS with data from child protection records found that EHS may reduce child maltreatment in this target group. In particular, there was evidence that incidence of physical and sexual abuse was reduced for children on the programs. Green et al., 2014. Parents as Protectors, Parent Education Programs that address child sexual abuse and gender-based violence, such as the Parents /Families Matters program, have been implemented in the United States and 8 sub-Saharan African countries. Families Matter, 2014. Forehand et al. 2007, Guillermo Ramos et al. 2004, Miller et al. 2010, Miller et al. 2011, Miller et al. 2013, and as part of the package of PEPFAR's DREAMS interventions, aiming to prevent HIV/AIDS among adolescent girls. These are community-based, group-level interventions for parents and caregivers of 9-12 years olds that promote positive parenting practices and effective parent-child communication around issues such as sex, sexuality, sexual risk reduction, HIV prevention, violence and sexual abuse. Pre- and post-test results show that parents significantly increased their knowledge, skills, comfort and confidence in communicating with their adolescents about sexuality and sexual risk reduction. Armistead et al., 2006. Miller et al. 2010, Van de Hout et al., 2010, Widman et al. 2016. However, the impact of parent communication on actual levels of sexual violence against girls has not been directly assessed. Primary prevention in humanitarian contexts. Primary prevention is one of the key strategies recommended in Humanitarian Action Against Gender-Based Violence in Emergencies, UNICEF, 2019. Recommended primary prevention strategies include addressing the underlying risks and drivers of gender-based violence and violence against children, empowering women and girls economically and socially, and building safety and resilience. In humanitarian contexts, this has also included establishing safe spaces for women and children, distributing dignity kits, conducting safety audits and involving girls and women in community safety planning, UNICEF, 2019. Research evidence on effective primary prevention strategies remains rather low. A systematic review of sexual violence prevention in conflict zones found only 2 out of 40 research papers focusing on preventing sexual violence among young people in conflict zones. Spangaro et al. 2013 and 2013b. Gender-based violence prevention. There are some limited evaluation findings for gender-based violence prevention programs in humanitarian contexts such as camps for displaced people, the Zero Tolerance Village Alliance intervention was evaluated for the population council in refugee camps in Uganda, Undi et al., 2016. The program aimed to reduce levels of gender-based contents. Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 5. Ending Child Sexual Abuse and Exploitation, a review of the evidence 100. and sexual violence in the camps, working with men, women and the wider camp community. The evaluation used a simple pre- and post design and had no comparison group, so further research is needed to test the findings. The program was found to be effective in moderating negative attitudes and beliefs related to gender-based and sexual violence, and results indicated positive change in norms, rates of intimate partner violence and non-partner sexual violence were reduced, and there was an increase in knowledge about rape and sources of help and support. The program was less effective in changing negative male attitudes to women's autonomy as sexual partners, and less effective at reducing sexual violence from partners. Challenges to implementation identified from the program were low levels of literacy in camps, which made evaluation and information sharing difficult, the need to target women, to address rape-related pregnancy, to stimulate demand for post-rape care. The International Rescue Committee has supported evaluations of the Compass program, a gender-based violence program for adolescent girls, in refugee camps in the Democratic Republic of Congo, Pakistan and Ethiopia. This program includes primary prevention and response activities, and to avoid repetition is discussed in the next section. IRC 2017 Codes of Conduct, allegations of sexual violence by peacekeepers and aid workers emerged and attracted media interest from 2001 onwards, following reports into sexual abuse and exploitation in refugee communities in Guinea, Liberia and Sierra Leone, and abuse by peacekeepers in the Congo, Ndulo, 2009. A code of conduct was established in response to the revelation of extensive sexual exploitation perpetrated by peacekeepers in the Congo, MONUC, 2003. It aims to prevent sexual abuse and exploitation by setting standards for the ethical behavior of humanitarian workers and adopting a zero tolerance policy towards any form of abuse or violence. The code applies to all workers, including staff, volunteers, casual laborers, guards and senior managers, and lays out expectations for humanitarian workers and consequences for breaching the code. Levine and Bowden, 2002. One project was identified that sought to evaluate a code of conduct for humanitarian workers in Kenya that was developed in 2003. Over a 3-year period beginning in 2004, the project, funded by Bureau of Population, Refugee Migration and led by the International Rescue Committee, IRC, Kenya, sought to raise awareness of sexual abuse and exploitation of refugees and to implement an agreed process for investigations of abuse and exploitation. The evaluation found success in the project's aim to deter abuse and exploitation by humanitarian workers, teachers and police, based on evidence of increased confidence among the refugee population in their ability to report incidents and on their increased knowledge of their rights. At the camp level, a reduction in reported cases of sexual abuse and exploitation was found after the campaign. There was also evidence of ownership of the project by refugees, who formed committees of youth, women and community leaders, and who continued to Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 5 Ending Child Sexual Abuse and Exploitation, a review of the evidence 101. Promote messages of prevention after the project ended. Zfina Consulting 2007. This evaluation provides some promising findings regarding the effectiveness of the code, but importantly highlights the fact that drafting a code in and of itself is not enough. People must be aware of their rights, and there must be pathways for complaints and reports to be made for a code to be effective. Further, projects and associated evaluations will be important to build the evidence base further. Situational prevention. There have been significant efforts to implement situational prevention measures in humanitarian settings to make sexual abuse and exploitation more difficult for perpetrators to achieve. Attention to camp design, layout, security and lighting, for instance, has been found to contribute to a safer environment for women and children in conflict settings. For displaced women and girls in some conflict-affected contexts, collecting firewood or water and visits to marketplaces /trade routes puts them at particular risk of rape, abduction and murder. Field-tested prevention tactics include, for example, firewood patrols, Anderson 2010. These were set up in Darfur by the Civilian Police and Ceasefire Committee, CFC, the African Union Protection Force to protect women collecting firewood. Generally, the patrols consisted of 2 or 3 large pickup trucks that followed approximately 100-200 meters behind a group of women along a predetermined route to a firewood collection location. The trucks carried a patrol force comprising 3 to 5 civilian police personnel up front and 6 to 8 noticeably heavily armed CFC soldiers riding open air in the back of the vehicle. The Women's Commission for Refugee Women and Children reported that the firewood patrols proved highly effective. Base Ticket AL 2010, and this strategy has been noted by the United Nations as recommended for keeping women and girls safe, Anderson 2010. A review of effective field practice has highlighted, however, that these strategies may displace rather than prevent sexual violence, Anderson, 2010. Having good communication and trust between patrollers and camp members can increase effective prevention. The development of firewood committees that include both patrols and camp members allow the discussion of timing, frequency, route forward/location selection and how the patrols will be carried out, thus managing expectations and increasing the likelihood of effective prevention. Coordination, such as the establishment of joint protection teams that are teams of military and civilian personnel carrying out patrolling tasks, is recommended as crucial in sharing information about patterns of sexual violence in areas of conflict and crisis. A review of peacekeeping activities has also identified deterrent tasks as effective, which include visible presence of patrols, for example, keeping headlights of vehicles on all night, and the establishment of an alarm system among camp members, for example, banging on pots, to alert forces to intruders, Anderson, 2010. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 5 Ending Child Sexual Abuse and Exploitation, a review of the evidence 102. Review Question 2. What is known about effective primary prevention approaches to child sexual abuse and exploitation, online and offline? There has been a welcome widening of focus of primary prevention from strategies that target individual child risks to include the wider community and contextual factors. 3 types of primary prevention strategies to tackle sexual abuse and exploitation were found: a. Those aimed at mobilization or education to raise awareness and change social norms, attitudes and behavior; b. Situational prevention; and c. Prevention combining empowerment with reducing risks and vulnerabilities. It is likely that all 3 approaches are needed for an effective prevention approach. Many primary prevention responses do not primarily address child sexual abuse and exploitation but focus instead on parenting, gender-based violence/violence against women and girls, interpersonal/dating violence or HIV and AIDS prevention. Primary prevention programs specifically addressing child sexual abuse for pre-adolescent children are predominantly education-based, teaching children about safe and unsafe touches and encouraging them to protect themselves by telling a trusted adult. There are promising findings from research in high and low resource contexts that children's knowledge about safe and unsafe touches and about who to tell improves, although there is less evidence that these programs enable children to disclose or find help or that they are able to use the knowledge to prevent abuse. Teaching self-defense and empowerment skills may be more appropriate for adolescent girls at risk of sexual assaults from peers and boyfriends. Although plenty of prevention programs on online safety for children exist, no robust studies were found to show effectiveness and impact. Evaluations of child sexual exploitation primary prevention strategies also appear to be limited. The distinction between online and offline child sexual abuse and exploitation is increasingly blurred, although the online world can provide a safe environment for disinhibited opportunistic offenders. The private sector could play a greater part in the regulation of demand for CSAM and in creating a safe online environment for children and adolescents. More research and action is needed on the primary prevention of perpetration and on regulating demand. In general, more effective primary prevention strategies tend to be good quality, involve men and boys or the whole family, have clearly defined outcomes, adopt a holistic theory-driven approach that addresses not just individual risks but the socio-ecological context and environment, communities and organizational contexts in which children spend their time. School-based sexual violence prevention programs could be integrated with broader violence prevention and empowerment programs. More research is needed on high-quality programs that address children's vulnerabilities to victimization and sexually harmful behavior across the whole of childhood. Changing attitudes and behaviors. There are some positive impacts from primary prevention responses on attitudes, knowledge and behavior. For children, young people, parents, men and boys and practitioners, evidence of reduced victimization and perpetration relates mostly to preventing dating violence towards adolescent girls. Effective programs include School-based IPV prevention programs, impact on self-reported perpetration, physically and sexually aggressive behaviors, was found in HICs for safe dates, 4 years later. A recent multi-site longitudinal RCT in the US found the multi-stage, multi-component program Dating Matters, which includes safe dates at grade 8, to be more effective in reducing victimization and perpetration than safe dates alone. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 5. Ending Child Sexual Abuse and Exploitation, a review of the evidence 103. Promising programs include Stepping Stones, IPV and HIV prevention and life skills education for adults and adolescents. Inomics found lower rates of physical and sexual IPV among men 12 and 24 months after intervention, reduction in self-reported transactional sex at 12 months but no change in partner victimization. Experiences of women and girls, suggesting that additional strategies are needed to support this approach. School-based child sexual abuse prevention programs, for preschool and elementary / primary school-aged children that teach self-protection skills show improved knowledge and protective behaviors among some preschool and school-aged children in HICs and LMICs, but there is little evidence of impact on victimization rates. Positive outcomes are more likely for high-quality programs. Whole school violence prevention programs, such as the Good School Toolkit, show positive changes in teacher attitudes towards gender inequality and reductions in overall violence for boys and girls, but no significant changes for sexual violence by teachers or peers. Situational prevention. Promising programs. Situational prevention in schools. In the US, evaluation of shifting boundaries found reduced reports from peers of perpetration of sexual violence and reduced reports from girls of sexual victimization by peers and partners at 6 months follow-up for the building-only safety program. Reducing risks and vulnerabilities. Effective programs. Home visitation and parenting support can reduce the associated risks of child abuse and neglect. Impact measured by child protection reports to child welfare agencies. Parent self-reported perceptions about harsh physical punishment. Primary caregiver / mother's warmth towards child. Early Head Start in the US shows an impact on reduced reports of child sexual abuse. Promising programs. Improving parent-child communication about sexual safety. Parents Matter in US and Families Matter in LMICs were found to improve parent knowledge and willingness to discuss sexual abuse with children, but there were no reports from parents on actual increases in communications or on impact for child protection. Social Safety Net Programs, SSNS. Social safety nets include cash transfers, payments in kind or public work programs for adolescent girls and women to alleviate poverty and gender inequality in LMICs. Reviews indicate that these have potential to reduce gender-based violence if delivered as part of an integrated violence prevention system. Empowerment, life skills and livelihood programs. Evidence from programs such as BRAC's Empowerment and Livelihood for Adolescents, combining social and economic empowerment and life skills education for adolescent girls in LMICs, show declines in early marriage and experiences of Non-consensual sex for girls at 4-year follow-up. In LMICs, there is some encouraging research that suggests programs that also involve men and boys, the wider family and the community can be helpful to prevent backlash. Effects against gender-based violence prevention. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 5 Ending Child Sexual Abuse and Exploitation, a review of the evidence 104. Table 6 below summarizes the findings of the review on primary prevention strategies for child sexual abuse and exploitation across different sectors, highlighting, with color coding, the strength of evidence for particular strategies. Where data exists, information on the main impact measures used to assess change in the research studies is included. Many interventions have measured correlated risk or protective factors, such as improvements in attitudes and knowledge, rather than direct changes in self-reported levels of victimization or perpetration, and this should be taken into account when considering the strength of evidence. Most of the interventions identified as prudent are those endorsed by international treaties and commitments where the policy commitment is strong but research evidence in some cases may be limited. Table 6. Summary of evidence on primary prevention across different sectors. Primary prevention across different sectors. Quality of evidence. Hicks. Quality of evidence. Mix. National framework. National Primary Prevention Plan, ineffective without resources and training to implement. Prudent. Collaboration on online XAM takedown strategies. Content is reposted but some monitoring data suggests decline over time in UK hosting. Prudent. Social marketing campaigns. For example, Soul City, Pants, Don't Trade Lives. Limited research on impact campaigns shows wide audience reach can improve awareness and attitudes about intimate partner violence, but changes in attitudes may be short-lived, likely to be ineffective. For primary prevention as one-off campaign without investment in resources, partnerships, community involvement in change and improved impact monitoring. Needs more research. Needs more research. Multi-sector risk assessment checklists to identify children vulnerable to sexual exploitation for targeted prevention. Needs more research. Multi-agency training and support for professionals, darkness to light, positive increase in knowledge and prevention strategies in short term. Needs more research. Needs more research. Creating safe organizations, child safe standards, Australia, based on extensive evidence. Review of organizational drivers and risks but no evaluations of implementation of standards. Needs more research. Needs more research. Criminal justice regulating known offender access to children, for example, employment vetting and barring, sex offender registration and notification. The evidence on these responses for primary prevention is low and limited to the small minority of sex offenders who are already known to agencies. Strategies may be effective for preventing known sex offenders working with children. Prudent. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 5. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 105. Primary prevention across different sectors. Quality of evidence. Hicks. Quality of evidence. Mix. Criminal justice. Continued. Child safety zones and hotspot policies. Limited evidence from arrest cases suggests only 4% of sex offenders meet victims in child-dense areas. Child safety zones likely to be ineffective to prevent first-time offending. Needs more research. Needs more research. Early help for undetected help-seeking sex offenders. For example, Stop It Now, Dunkelfeld Project. Few evaluations exist, but these show offenders will use the service but may continue to abuse children while on a program, raising issues about offender confidentiality and child protection. Needs more research. Health Sex Education /HIV Prevention. Stepping Stones. Reduced transactional sex reported by men, but no reductions in women's victimization. Not effective as a standalone intervention. Impact on associated risk factors. Promising. Education. Child sexual abuse. Preschool and school-based prevention programs such as Who Do You Tell have been found to improve some children's knowledge about sexual abuse, safe and unsafe touches. Who to Tell /What to Do, with some evidence on increased disclosures. There is no evidence of impact on reduced victimization after program exposure. Adverse consequences such as fears about abuse have not been found. Promising. Empowerment and self-defense for adolescent girls. RCTs in Malawi and Kenya found I Empower program, delivered in the context of wider Safe Schools program, brought reduced self-reported sexual victimization, increased self-confidence and self-reported use of defensive behavior. Analysis at the individual level was not possible. No data found on possible adverse impacts. Promising. Online sexual abuse and exploitation prevention programs for children, teachers and parents are widely used in Hicks. There are limited pre- and post-test evaluations that show children have learned the key safety messages. Needs more research. Needs more research. Community or school-based education to target entrenched norms and values that support gender inequality and partner violence among adolescents. Safe dates, dating matters. Reductions in victimization and perpetration measured by self-reports. Effective. Needs more research. Combined IPV and sexual violence prevention and situational /building strategies. For example, shifting boundaries. Reductions in self-reported victimization and perpetration. Promising. Whole school approaches, targeting not only peer violence but also violence perpetrated by teachers and other educational staff and general building safety. E.G. Good Schools Uganda. Effective for violence prevention measured by self-reports, but too little data on sexual violence self-reported to evaluate impact. Promising. Table 6. Summary of evidence on primary prevention across different sectors, continued. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 5. Ending Child Sexual Abuse and Exploitation, A review of the evidence 106. Primary prevention across different sectors. Quality of evidence. Hicks. Quality of evidence. Mix. Social welfare and children's services. Reducing vulnerabilities, child-focused social safety nets, SSNs, not as standalone but combined with other prevention may have potential to address associated risks of sexual abuse and exploitation, such as economic insecurity. Some studies found reduced transactional sex and risk-taking behaviors. Promising. Combined gender equity, economic empowerment and skills, for example creating futures and stepping stones. South Africa, WFW Afghanistan. Some positive impact on reduced male perpetration of IPV but mixed outcomes found across different contexts. Needs monitoring. Needs more research. Adolescent life skills and empowerment. Igala Uganda address associated risk factors. For CSA/CSE, impact measures include improved self-reported employment, self-reported reductions of unwilling sex from girls. Promising. Private sector situational prevention approaches, for example, codes of conduct in travel and tourism, low evidence on impact, need integration into broader prevention strategies to address risks and drivers. Prudent. Community situational prevention involving businesses and private sector in nighttime economy. In preventing CSE, IG, Nightwatch UK. Limited evaluation may be more effective at identification and response. No evidence found on impact on primary prevention. Needs more research. Needs more research. Whole community approaches. IG Rotherham citywide CSE program, Zero Tolerance Village. Alliance in camps for refugees and displaced people in Uganda. Limited evaluation of impact. Needs more research. Needs more research. Involving men and boys and communities in prevention, for example, White Ribbon. Low evidence but encouraging findings in LMICs. These may help prevent backlash effects if integrated in wider empowerment and community prevention programs. Needs more research. Needs more research. Child, family and relationships. Home visitation and parent support programs, for example nurse-family partnerships, PPP. Several RCTS show impact on child maltreatment reports and risk factors associated with this, such as parental warmth and attitudes to harsh physical punishment. Few of the studies provide separate impact data on child sexual abuse or exploitation prevention. U.S. program Early Head Start, supported by large investment in parent and child health and support services, one of the few evaluations showing an impact on cases of CSA reported to authorities. Limited data on programs in LMICs. Effective. Indirect evidence. Needs more research. Parent education programs that aim to improve communication about sexual and gender-based violence between parents and adolescent children, evaluated in Hicks and currently under trial in a number of LMICs. For example, Parents Matter. United States, Families Matter. In Botswana, Côte d'Ivoire, Kenya, Mozambique, Namibia. South Africa, United Republic of Tanzania, Zambia. Evaluations show improved knowledge and parent willingness to communicate with children but no data found on conversations held and impact on child safety. Promising. Humanitarian. Crisis-specific. Situational prevention approaches, for example, creating child-friendly spaces, camp design, WASH. Policies, codes of conduct for humanitarian workers, low evidence on impact. Needs more research. Table 6. Summary of evidence on primary prevention across different sectors, continued. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 5. Ending Child Sexual Abuse and Exploitation, a review of the evidence 107. Identification, reporting, and child protection. Responses. Protection responses included in this section are those that aim to identify children who are at risk and take action to stop further harm. In HIC's protection responses for sexually exploited and abused children are embedded in broader child welfare system responses. Many HICs have seen a shift from reactive child protection, police or child protection orders for children known to be harmed, towards earlier intervention to safeguard children at risk of harm and differential responses. Differential responses to safeguarding aim to meet the range of needs children have across a continuum of care from high-risk, complex needs, requiring specialist services through to lower-level support for vulnerable children that can be provided by Universal Children's Services, Frost and Parton 2009, Gilbert et al. 2011. This has meant identifying and coordinating the child protection and safeguarding responsibilities of professionals in a range of different services in contact with children, so that child protection is no longer seen as only the responsibility of social workers, although of course in HICs, social work is a key agency in this area of work. In LMICs, where child protection systems are less well developed, there may be no formal social work or child protection agency, and many of the responsibilities for the immediate and longer-term safety of children are taken on by NGOs, INGOs and services set up in the context of humanitarian crises. For example, a review by the East, Central and Southern Africa Health Community found that close to 90% of prevention activities and a very high proportion of response-related activities in South Africa are delivered by civil society organizations. SKHC 2011, and this is true across the continent. Services can therefore be patchy and can overlap or run in parallel as a result of being concentrated in areas where they were initially set up by NGOs, perhaps to respond to an humanitarian crisis. It can be challenging to coordinate protection activities in these contexts. UNICEF have recently published evidence-based guidance on developing capacity in the workforce for child protection and social work, UNICEF, 2019. 6. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 108. Identifying children living with, or at risk of, sexual abuse and exploitation is a notoriously difficult task. There is no conspicuous syndrome, Kendall-Tackett et al., 1993, or Single Symptom to Help with the Identification of Children Affected. Universal Challenges to the Recognition and Identification of Child Sexual Abuse and Exploitation include 1. Barriers to disclosure by children, Alagia et al., 2017. Colin Vazina, 2015. 2. Parents, carers and the wider public's lack of awareness, understanding and recognition of sexual abuse and exploitation, Colin Vazina, 2015. 3. There is often no immediate physical evidence to indicate abuse, Gilbert et al., 2009a. 4. Professionals' lack of skills and training in identification, as the signs and symptoms of distress can be ambiguous or may be misread as having another root cause, Gilbert et al., 2009b, OCC, 2015. 5. System failure where, despite training and policies, there is poor information sharing or working together by agencies resulting in failure to protect, Munro and Fish, 2015. 6. A policy or cultural context of secrecy, shame and stigma that does not support identification and child protection responses. In addition, prosecution and detention of the perpetrator may be influenced by common delays in presentation. 4. Treatment by sexually abused children, Gurgera et al., 2014. Sexually exploited adolescents may be resistant to child protection service involvement and may not regard the relationship as abusive, Buller et al., 2020. Victims of human trafficking may decline or avoid support or assistance if this assistance is seen as standing in the way of onward migration, Surtees and Branowskis, 2007. This section reviews research evidence on a range of identification, reporting and child protection responses towards children who are sexually abused or sexually exploited. These include training those who work with children to be alert to the signs of sexual abuse and exploitation, introducing methods to screen for sexual abuse, introducing assessment methods, particularly risk assessments, to identify children most likely to be vulnerable, improving data sharing and guidance for multi-sectoral methods of working together, and developing reporting and referral pathways. There are fewer studies that have rigorously evaluated what works in responding to child sexual exploitation, Scott et al., 2019. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 109. National and International Strategies for Identification, Reporting and Protection. Online international collaborations, as already discussed in the previous section, extensive collaboration occurs cross-nationally via online services and through the activities of law enforcement agencies such as Interpol to improve early identification of victims and offenders. Policy responses to identify and respond to child abuse online have included blocking and removing websites, covert infiltration into online worlds, identification of victims, sex offender registration, support and management of offenders, tools to facilitate safer internet use such as parental controls, and public awareness raising, Gini, 2015, 43p. This type of policy response requires multi-agency working that includes law enforcement agencies, child welfare organizations, ICT, companies and other stakeholders. The WIPO-TECT model national response sets out the components needed for a nation to develop an effective response. These include provisions for cross-sector working arrangements, a framework for prosecution and reporting, financial and human resources, and capacity to implement national legislation and the data required for monitoring and tracking trends and impact. Country reports show considerable progress across all 4 areas of response. WIPO-TECT includes UNICEF-managed capacity building funds for countries with low resources. Interpol has created an international child sexual exploitation database of known child abuse images to enable monitoring and investigation of files shared over peer-to-peer networks and to facilitate victim identification. In addition, international collaboration through organizations such as the European Cybercrime Center within Europol, EC3, work to prevent the sharing of child sexual abuse material and also on victim identification through the Victim Identification Task Force. The Center coordinates police agencies across EU member states in identifying victims in order to prevent re-victimization and to prosecute offenders. Gini, 2015. National Rapporteurs, the Council of Europe. Convention on Action Against Trafficking in Human Beings. 2005 and the EU Directive on Preventing and Combating Trafficking in Human Beings and Protecting its Victims, 2011. Calls on member states to appoint national rapporteurs or equivalent mechanisms to assess trends in human trafficking, monitor and measure the anti-trafficking activities of state institutions, gather statistics and report on their findings. Current monitoring of trends in child trafficking is poor in many countries. A national rapporteur exists in Holland and has made over 200 recommendations to the Dutch government, many of which have brought changes in policy and data analysis. Radford et al., 2017b. Mandatory reporting. Mandatory reporting means that a legal requirement is imposed on certain groups, professionals, or organizations to report child abuse and neglect. Mandatory reporting laws exist in HIC jurisdictions such as Canada, Australia, the USA, Ireland and in LMICs such as Brazil, Malaysia and South Africa. It can. 2018, Wirtz et al., 2016. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 110. The policy is widely recommended, Co. 2009, and is often part of a government's child protection plan. However, the content and professions covered by mandatory reporting laws vary substantially across countries. It can. 2018. Research on the impact is mixed, showing that mandatory reporting increases the numbers of reports to child protection agencies, especially if accompanied by publicity and training. If communication is poor, as one qualitative study in Cyprus found, notifications may not increase. Panayiotopoulos, 2011. Some researchers have observed that the increase of notifications include increased reports of suspected abuse or neglect which are subsequently found to be unsubstantiated. Wallace and Bunting, 2007, Gilbert et al. 2009. In such cases, families may be harmed by going through the process of a child abuse investigation. Views are mixed about whether or not increased reports are helpful or unhelpful. A review of evidence on health care responses in Latin America and the Caribbean found benefits from mandatory reporting in Colombia included improved visibility about the problem of violence against children and the ability of NGOs and survivor services to inform policy on sexual violence. Wirtz et al., 2016. Some researchers argue that children and families involved in cases that are not later substantiated may still have had their needs assessed and support given. Research has not generally taken into account the context in which reporting takes place, particularly features of the child protection system that may encourage or discourage reporting and taking action. Weckel, 2013, has argued that mandatory reporting is an important first step in creating resilience and early intervention, if reporting is followed up with assessment and an appropriate protective response. Others raise concerns that services can be overburdened and resources diverted away from cases with high levels of need. H. M. Guft, 2016. 2 systematic reviews of qualitative research studies found no research on implementing mandatory reporting. In LMICs, McTavish et al., 2017, 2019. The first study was a review and meta-analysis of qualitative research on mandated reporters' experiences. This found that although 14% of the 1,088 participants reported some positive experiences with mandatory reporting, 73% reported negative experiences such as harm to the therapeutic relationship with the child or death of a child following removal from the family of origin. McTavish et al., 2017. The second study reviewed qualitative research. Mandatory reporting research example, a study by Matthews, Julie and Norman, 2016, assessed the impact of the introduction of a mandatory reporting law in Victoria, Australia on the identification of child sexual abuse cases. Looking at reported cases over a 7-year period, it was found that there was an increase in cases reported from 551 in 2006 to 2,719 in 2012. The numbers of cases investigated grew from 366 to 2,040. But so did the numbers not investigated, from 185 in 2006 to 1,239 in 2009, 1,522 in 2010 and downwards to 679 in 2012, and the numbers not substantiated from 235 to 1,660. There was an increase in cases substantiated from 131 in 2006 to 380 in 2012. In areas such as New South Wales and Queensland, thresholds for reporting were increased to reduce the numbers of notifications made. Matthews, Julie and Norman, 2016. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 111 On Children's and Families' Experiences of Mandatory Reporting, McTavish et al., 2019. The positive impacts of mandatory reporting included getting access to resources, such as food stamps, or getting help where a parent had already recognized the need. Negative impacts included parents' fears of losing their children, unfounded reports by an abusive partner, the detrimental impact on help seeking for women with drug or alcohol problems or living with IPV. While neither study can be used as evidence of the effectiveness of mandatory reporting, the qualitative findings highlight the need to carefully monitor outcomes for families and children. Training is recommended for professionals working with mothers who experience IPV or have drug or alcohol problems, so that they are aware of these barriers to involvement and able to work sensitively and safely to protect children and support the mother. Safe and ethical research on children's experiences of mandatory reporting is urgently needed. So far, there is no robust evidence that mandatory reporting increases child well-being or child health outcomes. The lack of prospective studies and the possible adverse consequences indicate, at best, cautious introduction of new mandatory reporting responsibilities, supported by training, adequate resources and careful monitoring for unintended consequences. Multi-sectoral strategies for identification, reporting and protection. Responsibilities to take action to protect children from sexual abuse and exploitation commonly fall across a range of individuals in civil society and across different sectors and professions. Poorly coordinated services can cause unnecessary delays, inertia, duplicated efforts, and system failure. Munro and Fish, 2015. This section reviews the research identified on different organizational mechanisms that aim to improve the coordinated response to child sexual abuse. No experimental or quasi-experimental studies on coordinated working were found. The outcomes for these services are not all the same and are not always clearly stated in the available literature. Co-located investigation or assessment teams, promoting good practice among the broader community of practitioners by developing specialist but mobile multidisciplinary teams is one approach where evaluation evidence is developing in Australia. Powell and Wright, 2012, present findings from a qualitative evaluation of professionals and stakeholders involved in a multidisciplinary response in Australia that support Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 112. The findings from elsewhere that professionals can see benefits in these models for improving working together. The researchers interviewed 90 professionals in contact with a new multi-sector response to sexual violence for adults and children in Victoria, CSAE DC. CSAE Sexual offense and child abuse investigation teams. Bringing together police officers trained to the level of detective, in forensic interviews with children and in sexual assault. The CSAE work in a multidisciplinary center, MDC, separate from the police station alongside counseling and support services for victims, child protection, forensic medicine and mental health. The researchers found stakeholders believed the CSAE MDC had improved collaboration, referral rates, reporting, reduced response and investigation times, improved the quality of evidence, and rate of prosecution and convictions. A limitation of this study is, however, the lack of any evidence on victim perspectives, multi-agency risk assessment and management. Conferences, Marix in Wales, a survivor care pathway was developed to improve the safety and protection of trafficking victims and supported with a professional training program. This begins with a referral to a single point of contact and then a multi-agency conference is convened to assess the risks, share information across agencies and plan for coordinated safety and support. The approach adapts the Marix model, developed in England and Wales, widely used. Therefore, the multi-agency management of high-risk domestic violence, a non-experimental evaluation of the survivor care pathway model and the adaptation of Marix found this had a positive impact on the identification of potential victims /survivors, on the number and quality of referrals, on coordinated multi-agency support for victims /survivors and on their outcomes. Cordis Bright, 2016. The simplicity of the referral pathway was considered to be a major strength in the approach. While this particular approach is most relevant to HIC contexts, the development of an agreed, simple, multi-agency referral and support pathway and building on existing and familiar mechanisms for joint planning and working to improve safety for victims has potential relevance as part of a capacity building program where resources are more limited. One-stop shop models, one-stop services tend to be broader than co-located assessment teams as they bring together services that work with victims across the spectrum from identification to assessment, medical help, protection, forensic services and legal proceedings, family support and recovery. Two different approaches were identified in the review and are discussed further below. One integrated sexual health services, which primarily address post-rape care and HIV/AIDS prevention for adults and adolescents. For example, Thuzula centers in South Africa or sexual assault referral centers, SARCs, in England and Wales. 2 one-stop shop services for sexually abused children, providing child-friendly, comprehensive assessment. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 113. And Forensic Criminal Investigation, Multi-Sector Collaboration /protection, Family Support and Therapy. Physical and mental health care. Examples are the Children's Advocacy Centers, CACs, in the USA and Canada and the Barnahus, Children's House, approach in Nordic nations, Western and Eastern Europe and South Africa. Barnahus and CACs often deal with a wider range of child protection concerns, covering child maltreatment and children's exposure to domestic violence. The comprehensive child-focused response of the Barnahus has been promoted by the Council of Europe as best practice and is in keeping with the Lanzarote Convention. Integrated sexual health services. These services in low-resource settings typically provide health care, including psychosocial support, in combination with police and justice sector responses, and ongoing social support, usually in the context of a health care facility or a hospital, for example the Panzi Hospital Center in the DRC. Mukwege and Berg, 2016. Although a large minority of service users are children, girls under the age of 18, evaluations of these services rarely distinguish outcomes for child service users from outcomes for adults. An evaluation of an integrated and comprehensive health model to respond to rape and HIV in South Africa found that utilization of services increased from 8 to 13 cases per month. Those who reported seeing 6 or more providers on their first visit decreased from 86% to 54%. Quality of history and exams improved. More service users were provided with post-exposure prophylaxis, PEP, on their first visit and received the full 28-day course on their visit, and nurses' roles expanded in the delivery of post-rape care. Links with the police were made stronger, but the evaluation found that participant attitudes towards the criminal justice system, particularly the courts, remained very unfavorable. Kimmett al. 2007. Kimmett al. 2009. Another evaluation of a multisectoral initiative in the Copperbelt Ndala district, Zambia, examined police collaboration with the health sector with the aim of reducing unwanted pregnancy among victims of sexual assault through the provision of emergency contraception. The police were trained by health providers in how to distribute this. The study found that the police could be effectively trained to distribute emergency contraception safely. Health personnel were pleased with the intervention. There was a 48% increase in reported incidents of sexual violence. The police consistently referred victims to other health services, and management believed this to be a cost-effective and sustainable project. As a result, national scale-up of the project was strongly endorsed. Keysbury et al. 2009. Health-based facilities without adequate health promotion in the community may not meet targets to provide post-rape care services to survivors within 72 hours if women and girls in the community are unaware of the services offered or cannot access them. Sithole et al. 2018. The provision of psychosocial care in some contexts can be limited, but there are some findings that suggest these impact on service user satisfaction. Jones et al. 2007, Keysbury et. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 114. AL 2012. An evaluation of one-stop centers in Zambia and Kenya investigated whether different organizational models had an impact on service effectiveness. Keysbury et al., 2012. 3 types of one-stop shops, OSCs, were identified. OSCs owned by a hospital, OSCs owned by an NGO, but delivered in a health setting, where the NGO role is to improve the comprehensiveness of care. OSCs that are NGO-owned and survivors are referred outside for health care. Drawing on an evaluation of 5 OSCs, their service data, case files, justice system records, court transcripts, interviews with key informants, stakeholders, and survivors, it was found that the healthcare facility based OSCs achieved the broadest range of health and legal outcomes for survivors compared to other OSC location models. These were also perceived by survivors as being effective for meeting their health needs. Few cases were however processed by the justice system and prosecutions of perpetrators were low. The report authors concluded that the needs of child survivors of sexual violence could be better addressed. Some of the one-stop shop models have a specific focus on children. E.g. the Philippines National Police have Centers for Medico-Legal Examination of Victims of Child Sexual Abuse, UNICEF, 2014b. 2 studies in LMICs did identify findings specifically for children and adolescents using these services. A 3-armed RCT of the SAFE program for females aged 10 to 29 years and males aged 18 to 35 years in Dhaka, Bangladesh aimed to test if the Community Awareness Program on Gender-Based Violence, supported by a one-stop shop service and group work had any impact on reported levels of IPV, including sexual. No overall impact of SAFE on IPV was found, but for subgroups of girls aged 15 to 19 years who received the intervention in mixed gender groups, a 21% risk reduction was found for physical IPV, Navd et al., 2018. A simple pre-post test design evaluation of Chiquane-Equane's one-stop shop services offering medical, legal and psychosocial support for sexual violence victims in Malawi assessed impact on 107 sexually abused children, average age 9 years, 90% girls. Over 2/3 of the child victims, 67.3%, arrived for treatment within 72 hours and 80% of them had a follow-up visit for an HIV test 3 months later, while 80% also had a welfare assessment. At the initial meeting only 29% had a welfare follow-up home visit 3 months later. Almost all, 95.3%, had an initial police report and 27.1% ended in a criminal conviction. Most of the families were found to be happy with the service received, although a quarter were not satisfied with the law enforcement response. Malumbia et al., 2018. Children's Advocacy Centers, 7 of the papers on multi-sector identification of child sexual abuse report on research within USA Children's Advocacy Centers, Benya et al., 2015. Cross et al., 2008, Herbert and Bromfield, 2016, Jones et al., 2007, Lippert et al., 2009, Miller et al., 2009, Walsh et al., 2007. Child advocacy centers developed in 1986. and by 2019 over 1,000 were operating in the USA. These centers are one-stop shop, co-located multidisciplinary team. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 115. Approaches bringing together police, prosecutors, health and child protection professionals, to improve the experiences of child victims who disclose child sexual abuse and exploitation, as well as improve the agency responses. Children's advocacy centers aim to promote children's best interests, as well as respect the rights of defendants to be treated fairly in the prosecution process. There is qualitative research to suggest that agencies such as the police report better multi-agency working in areas with children's advocacy centers. Grace et al., 2019. The expertise over many years gained in these centers from working with abused children and young people has contributed to knowledge on many aspects of effective identification, including how to conduct forensic interviews and make timely decisions. One example of impact on practice has been promoting developmentally appropriate child-focused methods for forensic interviewing. Benia and colleagues, 2015, present findings from a systematic review and meta-analysis of an approach to best practice in interviews developed from the work in child advocacy centers, the National Institute for Child Health and Human Development Investigative Interview Protocol, hereafter NICT Protocol. The NICT Protocol was designed to improve the quality of forensic interviews with children thought to have been sexually abused. In Benia and colleagues' research, the interview quality was measured by the type of interview utterances and the amount of information provided by children. Comparing interviews following the protocol with those that did not. The studies show that interviewers using the NICT protocol made more invitations and fewer option posing and suggestive prompts than interviewers in the control group. Children interviewed following the NICT protocol provided more central details about the abuse. There is also helpful guidance from research on different interviewer question styles for sexually abused children, showing that use of certain narrative techniques and supportive comments can improve the quality of forensic evidence. Anderson and Giljan. 2014, Lui, CYR and Dion, 2015. Using the NICT protocol and other interviewing methods may improve the quality of interviews with sexually abused children and young people, but they do not entirely overcome the significant barriers to disclosure that exist for younger children, boys, and for children abused from an early age. Lippert and colleagues, 2009, found that the approach to interviewing and support given in a children's advocacy center was not the only factor influencing whether or not a child might disclose an experience of child sexual abuse. From an analysis of 987 interview records conducted in advocacy centers and interview sites outside centers, no differences were found in rates of complete, partial or no disclosure. The age of the child, gender, being female, and age at onset of the abuse had a greater impact on disclosures than whether or Not the child was interviewed in an advocacy center. Research on outcomes from children's advocacy centers has focused more on the impact on prosecution than on the outcomes for children and families. Herbert and Bromfield. 2016. There is evidence to support the view that non-abusive parents / carers of child victims have higher levels. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 116 of satisfaction about the interviewing of their children in children's advocacy centers, CACs, compared with parents of children interviewed elsewhere. Cross et al. 2008, Nwogu et al. 2016. However, no differences have been found for child levels of satisfaction. Cross et al. 2008, Jones et al. 2007, and there is no evidence that children who testify in court gain any therapeutic benefit. Elmi, Dano and Herbert, 2018. Cases of child sexual abuse in children's advocacy centers have been found to have greater law enforcement involvement, more evidence of coordinated investigations, better access to medical examination and higher rates of referral to mental health treatment services than cases outside CACs. Nwogu et al. 2016, Walsh et al. 2007. There is some evidence showing that early on in the criminal process, CACs have better outcomes than standard practice. Herbert and Bromfield. 2016. There is no evidence to show that CACs reduce the number of interviews children undergo, as both those in CACs and outside typically have only 1 or 2 interviews. Cross and colleagues, 2008, found children involved with child advocacy CACs were more likely to be removed from their homes than were children in control groups. While professionals in contact with child advocacy centers and similar multidisciplinary models tend to be satisfied that these approaches can improve multi-sector working. The research evidence on increased prosecution rates in the US appears to be mixed, suggesting that there are a number of factors that exert an influence. Cross et al. 2008. Found similar rates of prosecution for child sexual abuse cases in CACs and those outside. Miller and colleagues. 2009, looked at prosecutions over a 10-year period from 1992 to 2002 in 2 districts in the USA, comparing rates of prosecution in areas with an advocacy center with those without. Rates of reporting child sexual abuse fell in all areas in this time period, but prosecutions in one area doubled, while assessments in the CAC trebled, and prosecutions remained the same in a neighboring area where the CAC had no increase in cases seen. It seems that the implementation aspects of the CAC may exert an important influence on the effectiveness of the multi-sector response. Barnahus / Children's House, Barnahus developed from the CAC approach initially in Iceland in 1998 and then spread across the Nordic nations and is now present in Europe and South Africa. The Promise 2 website promotes quality standards for the Barnahus approach. While there are studies of implementation, Johansson et al. 2017, Johansson, 2019, and compliance with government quality standards, Landberg and Svadin, 2013, outcome. Research for the Barnahus approach remains limited. A policy review by the Children's Commissioner in England, 2015, presents data from Iceland's child protection system, showing an increase in referrals of children to Barnahus, trebling in indictments, 51 in 1995 to 97 to 145 2011 to 13, and doubling of convictions, from 49 in 1995 to 7 to 101. In 2011 to 13, for cases of child sexual abuse in the years immediately before and 3 years after the Barnahus was set up. The findings regards increased support for child victims, improved prosecution processes and victim satisfaction are supported by the Swedish evaluation of Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 117. 6 pilots published in 2008, which has a summary in English, Rixopolis Tilson, 2008. Implementation of the Barnahus approach and coordination of the child welfare and criminal justice functions varies considerably across different countries, and this influences the comparability of any outcome evaluations. Johansson et al., 2017. Research directly with children using Barnahus in Sweden and Norway found that children and young people found the environment in the building welcoming and non-threatening, and this helped to put them at ease. Olsen and Klaffvad, 2017. Stephenson, 2017. A qualitative study of parents and children who have used the services in Sweden found families were satisfied with the Barnahus approach. Rasmussen, 2011. The one-stop shop approach of the Barnahus was found to be impractical in Greenland, where the geographical distance presented a considerable challenge for co-located and central service provision. The Greenland Barnahus has now lost its assessment and treatment functions and operates instead as a knowledge center for child protection practice. Mosgaard Sobjerg and Fredsgaard Thams, 2016. The capacity of families to travel to such centers in LMICs is a factor likely to impact on access and use of services, especially in rural areas. Barnahus was established in London, England in 2018 as the Lighthouse Project, and there is an ongoing 2-year evaluation. A considerable and welcome innovation in the Lighthouse is the facility to set up a remote video link method for gathering court evidence and piloting cross-examination, as in the Nordic model but unique within an adversarial legal system. Final results of the evaluation are expected in 2021, Conroy et al., 2019. One-stop shops for child protection in mix. Examples of one-stop shop models focusing specifically on child protection were found during this review. Some have evaluation evidence, although not as yet any experimental trials. One example is the Child Protection Center model set up in Kenya. In 2009, a participatory assessment in the Malindi sub-county was conducted to identify the issues hindering community members reporting cases of child abuse, Violence and Exploitation to the Department of Children's Services. The survey identified the following problems. Abuse cases were frequently settled at community level by local authorities. Bypassing the law, the community were not aware on how the reporting system was working. The survivors and their families were giving up during the reporting due to lack of funds to follow all the scattered services, lack of trust from the community in the justice system, and very few cases were concluded. CSAE 2019. Evidence from the survey and international research was used to inform a new approach to child protection centers, with a detailed operational plan. In 2010, the community-led model was adopted by the government of Kenya, and the first child protection center was built in Malindi to provide a hub of quality, coordinated and inclusive services to ensure that children and their families had access to immediate support and guidance to respond to abuse, exploitation and violence, and to improve their lives in order to reach their full potential. The Child Protection Center aimed to strengthen case management through coordinated and effective psychosocial contents. Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 118. And legal services. The Child Protection Center is a one-stop shop where, when any abuse, neglect or exploitation is reported and essential services are offered in a child-friendly space. It is a community resource center providing a hub of information and coordinated services primarily for children and their families, supported by norms changing programs of activities in the local community. The CPC is open to all community members and is a place where needs are identified, assessed, addressed and referred. The CPC provides preventive community education, individual assessment of children, child and family counseling and psychosocial support, legal assistance, tracing, reunification, and reintegration of separated children, and referrals to other service providers such as health care centers, rehabilitation centers, police, judiciary or vocational training schools. The center staff include a manager, appointed by the Director of the Department of Children's Services, 4 social workers, a child counselor and a legal officer. The District Children's Officer and a police officer from the Police Gender and Children's Desk are also co-located at the center to help collaborative working. The center oversees each case from beginning to end, adopting a case management approach with a process of case review and staff supervision. It is supported by a free and confidential helpline so anyone can report a case of child abuse. Evaluation data, CSAE 2019, shows an increase in the average caseload of 100 per month in 2009 to 250 per month during the period 2012 to 2014, 300 in 2015. 2016 and 340 in 2017 to 2018. From 2010 to July 2018, the CPC in Malindi has provided quality and integrated services to 27,607 children, 51% girls. 90% of cases reported Tumalindi CPC in the 2017 to 2018 fiscal year were successfully solved. Child defilement, sexual abuse and exploitation cases reported have grown slowly and made up almost 6% of all cases referred in 2018, CISP, 2019. Sectoral strategies for identification, reporting, and protection. Crime and justice sector. Traffic stops and hotspot policing, in HICs. Responses to sexual exploitation include the use of vice units patrolling red light areas and off-street sex work locations, working with young people who run away or go missing by investigating missing persons reports, and working in partnership with other agencies through multi-agency planning and case management. However, evaluation research has found a range of challenges beset this work, including the lack of a clear remit to investigate sexual exploitation, a lack of resources and staff, and narrow levels of awareness of sexual exploitation and its contexts. Harper and Scott, 2005. A study in Texas of a program training traffic officers on identifying high-risk children and potential perpetrators of child sexual exploitation when stopping traffic reported 200 children were rescued from 2010 to 2015, and in 2015 alone 14 investigations were conducted on potential perpetrators. It is not known, however, whether children rescued from high-risk situations would have been sexually exploited without the intervention by the police. Burke et al., 2016. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 119. Raid and rescue policing, raid and rescue approaches. Involve police and immigration services conducting unexpected raids on establishments thought to hold victims of sexual exploitation and trafficking in order to rescue victims and apprehend traffickers. The approaches are widely used, but concerns exist about the harm caused to victims. Collateral damage describes the risk of anti-trafficking measures taken that affect the rights and freedoms of people who are experiencing human trafficking. The term describes how harm may be inflicted upon victims of trafficking as a result of anti-trafficking campaigns and actions. Gott, 2007. For example, detention in immigration centers, prosecution of individuals for offenses around illegal work, raids and rescues that do not adequately consider the protection of those involved, as well as forced repatriation. In other words, the victim of human trafficking is not placed at the center of actions designed to combat human trafficking, and which do not respect the dignity of these same individuals. Dotteridge, 2018, questions why such levels of collateral damage remain after more than a decade of awareness of the unintended side effects of anti-trafficking policies and legislation. Training programs, training on gender-based violence to aid identification and response among professionals has been provided by governmental organizations, NGOs, civil society organizations and international organizations such as the United Nations in LMICs. For example, in Latin America, Contreras et al. 2010, and Africa, EXA 2011, Usdin et al. 2005, Wessels. 2009. The Comité de Prévention y Contrôle del VIH/SIDA. De las Fuerzas Armadas y Policía Nacional, COPRECUS. Armed Forces and Police Committee for the Prevention of HIV/AIDS, United Nations Population Fund, UNFPA, and others have developed curricula of military and police academies to include reproductive and sexual health, gender and violence against women, and this training has been extended to many countries in the Latin American region. Contreras et al. 2005. In humanitarian settings, particularly in areas of ongoing conflict, training has been provided to personnel in the police, defense and judicial sectors to improve their knowledge of sexual violence, how they recognize it and respond. The civil organization Liga de Mujeres Desplazadas, Displaced Women's League, in Colombia, which established the Ciudad de Mujeres, City of Women, is an example, advocating for improved responses to sexual violence during the decades-long conflict. Bastic et al. 2010. Most evaluations of training initiatives mentioned above have not been very rigorous, but the training has been found to be constructive. Rashid, 2001, to have improved levels of knowledge and awareness of gender-based violence and to be most effective when all levels of personnel, especially high-level officials, participate and when training is backed by simultaneous reforms to policies, procedures, adequate resources and monitoring and evaluation processes. Bot et al. 2005. Training and awareness raising to prevent and protect against online child sexual abuse and exploitation has also Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 120. Been offered by criminal justice agencies to professionals working with children such as teachers and community youth workers. Ospina et al. 2010. As identified in the previous section, efforts in the United Kingdom by CSAE / the National Crime Agency include disseminating materials to teachers so they can know how to respond to online sexual abuse and exploitation. National Crime Agency, 2019. Ospina et al. 2010. Similar projects have been developed in LMICs, for example, a digital literacy course on safe internet usage delivered to 300 teachers in Thailand. UNICEF, 2011, although the evidence is not yet well developed. Policing and specialist children's desks. In many countries, the police may be the first responders to reports of sexual abuse and exploitation, or in areas of conflict and emergency, this may be NGO or military personnel. Population Council, 2010, Kerr Wilson et al. 2011. It is important that the police have the institutional and human capacities to respond sensitively to children and young people reporting sexual abuse and exploitation. This will encourage victims to report their experiences and provide them with referrals to services that they may need. The evidence base in this area is limited and refers primarily to police forces working with violence against women, not children, Kerr Wilson et al. 2011. There is also an absence of large-scale comparative studies and meta-analyses of police responses in this area. Despite the limited evaluated evidence of strategies and approaches, there are a growing number of programming guides and toolkits available for working with the security sector, particularly for training initiatives and largely drawing on experiences of countries in the global north or with post-conflict settings, IBAD, specialist children's police desks, or family violence units have been established in HICs and LMICs. Field evidence is available from the UN and UNICEF. For example, in the United Republic of Tanzania, the Tanzania Police Force established gender and children's desks in all 417 police stations in the country. These are dedicated units within police stations staffed by specially trained personnel to ensure an efficient and effective response to cases of violence against women and children. Latest available data found shows the police trained 1,000 officers on the national guidelines for the establishment of gender and children's desks, and on the standard operating procedures for prevention and response to gender-based violence and child abuse. UN Tanzania /UNICEF 2013. Challenges exist in implementation, but cases of reported rapes of women and children have increased since the police desks were set up. Ali Musa and Mohammed, 2019. At the agency level in HICs, it has been accepted that effective multi-agency or cross-sectoral working is vitally necessary. Examples of close collaboration between the police and social work to develop clear policy and reporting mechanisms exist, as in work developed in Glasgow, Scotland, Rigby et al. 2012. There is, however, a lack of rigorous evidence on how to respond to some groups of sexually exploited young people, such as those internally. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 121. Trafficked for purposes of sexual exploitation, and poor multi-agency practice is recognized as a problem still to be overcome. Jago et al. 2011. Specialist child protection, sexual violence, or vulnerable victim units, in LMICs, as in HICs. Specialist child protection or sexual violence units have developed with dedicated police specialists following up on or sometimes attending initial calls. Examples can be found in Liberia, Tanzania, Mozambique and Sierra Leone. ACPF, 2014. The Sierra Leone Police, SLP, for example, established family support units, FSU, with specially trained female and male officers dedicated to working with victims of rape, sexual abuse, domestic violence and trafficking. UNFPA 2005, UNICEF, 2014b. Some FSUs have social workers responsible for referral and child protection. Located in the main police stations across the country, the FSUs are intended to provide compassionate, humane and appropriate assistance, referral services for free medical care and legal Assistants have developed. The FSUs may also engage in public awareness-raising efforts, especially on the topics of sexual violence, domestic violence, HIV and AIDS, trafficking, and FGM, to improve channels for women and girls to report cases of gender-based violence. In 2003, FSUs in Sierra Leone received and investigated 3,121 reports of sexual and physical violence, a significant increase over reporting in previous years. This rise in the number of reported cases is seen as a result of increased public awareness and public confidence in the FSUs, based Ticket AL 2010. In Sudan, Family and Child Protection Units, FCPUs, have been set up involving the police and other agencies. These aim to provide support to child victims and to also work with children and adolescents in conflict with the law. Evaluations of outcomes for children have not been found, but data is available on the growth in cases processed by the FCPUs. This shows that 1,033 cases were processed in Khartoum State in 2007 and 5,152 were processed in 2011. In 2011, 2,734 of these cases involved child victims, mostly of sexual abuse and exploitation, and 2,418 were cases where a child was an alleged perpetrator. UNICEF, 2014b. Police forces in England and Wales have been establishing specialist child sexual exploitation teams since the early 2000s, although the rate of establishment is varied, as is the way in which these models are set up. Allnuck, Lloyd, and Pierce, 2018. A qualitative study of 8 forces in England found varied models, with some teams entirely separate from child abuse units and which are responsible for all aspects of CSE, including prevention, analytics and research, investigation and supporting young people. Others focus on particular aspects such as analytics or investigation, with other functions allocated to other units. Other forces, instead of implementing specialist units, seek omnicompetence in officers by expecting all units to be prepared to respond to sexual exploitation. The study sought to articulate the key features of different models. It would be beneficial to conduct further research to determine which, if any, model is most effective in addressing CSE. Special measures for child witnesses. The international research evidence suggests that even very young children can give credible evidence in the justice Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 122. System. They are however vulnerable to inept adult questioning, and their competence in communication depends greatly on the capability of the professional. Interviewers, court intermediaries, advocates and judiciary. Marchant, 2013. Children with learning difficulties, particularly, are let down in the court process by poor gathering and presentation of their evidence. Cederborg and Lamb, 2006. To facilitate the prosecution process for child witnesses, special measures have been introduced in many countries, including the use of intermediaries and guidelines. On collecting evidence and conducting inquiries. In South Africa, sexual offences courts have been established across the country whose purpose is to reduce further traumatization of victims by employing victim-friendly practices, ACPF, 2014. In HICs there is research showing that the special measures are not consistently applied and children in court may often be poorly supported. Jekowski, Havarth and Davidson, 2016, Plotnikov and Wolfson 2009. Hayes et al. 2011. Resources, training, multi-agency coordination and monitoring are needed to ensure that measures for child witnesses are implemented effectively. Health sector strategies. A growing body of research worldwide has explored the quality of the health service response to violence against women and girls, including sexual violence, Contreras et al. 2010. Professional associations are increasingly endorsing the view that health workers play a key role in identifying sexually exploited and abused children and providing emergency care following rape. Bott et al. 2010, WHO, 2016b. Children and adolescents may need emergency services such as first aid, STI/HIV prophylaxis, forensic exams and emergency contraception, in addition to immediate medical attention for physical injuries and non-emergency treatment for sexual health, pregnancy, and mental health services. However, health service responses to sexual abuse and exploitation remain poor in many parts of the world. Contreras et al. 2010. Key challenges in the health sector in many LMICs include either lack of basic infrastructure, problems maintaining privacy and confidentiality, discriminatory and patriarchal attitudes and behaviors of service providers who justify the behavior of aggressors and blame victims, an inability to help women and children in crisis, a lack of trained personnel to care for women and children who have experienced violence, poor or non-existent institutional policies and protocols. These problems can result in re-victimization of children and adolescents, and the problems are particularly acute in marginalized and poor areas, indigenous communities, and conflict settings. Guidelines on health care responses to sexual violence, WHO, 2017, and to violence against children have recently been updated, based on research evidence, by the WHO, 2019b. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 123. Evidence on identification, referral and care of trafficked adults and children in health is very limited and has been a largely neglected topic. Hemmings et al., 2016. Zimmerman et al., 2011. Zimmerman et al., 2011, outline how policymaking, service provision and research often focus narrowly on criminal violations that occur during the period of exploitation, overlooking the health implications within the multi-staged process of human trafficking. Zimmerman and Kiss, 2017, outline how the negative Health consequences of human trafficking are sufficiently prevalent and damaging as to comprise a public health problem of global magnitude. The few studies that exist highlight significant problems in child protection responses. Mason Jones and Logie, 2019, and the need to interview potential victims in private, to build trust, use professional interpreters, and an approach guided by trauma-informed care and cultural sensitivity. A review of 130 mental health case files of trafficking victims in the UK, 95 adult and 35 child cases, found 43% of adult cases and 63% of child cases were already identified as trafficking before referral to mental health services. Patients also disclosed their experiences. Barriers to responses included social and legal instability, difficulties ascertaining history, patients' lack of engagement, availability of services, and interagency working. Domani et al., 2015. Follow-up examinations may increase identification for sexually abused adolescents who face barriers to disclosure. Gavril, Kellogg and Ne, 2012. Multi-agency responses are essential for protection and support. Hemmings et al., 2016. In a systematic search of trafficking for sexual exploitation in conflict-affected settings across Africa, Asia, and the Middle East, McAlpine et al., 2016, found evidence to be not generalizable due to few prevalence estimates and inconsistent use of definition of sexual exploitation. Clinical inquiry about sexual violence, physical injuries in sexually abused or sexually exploited children are relatively infrequent. Gilbert et al. 2009b. Indicators of sexual violence have been built into training and protocols for health workers. A systematic review of methods of identification of abused and neglected children in healthcare found 4 out of 13 articles focused specifically on child sexual abuse. Bailhache et al., 2013. Methods of identification overall were rated as very poor, suggesting that there is too little evidence to inform early identification or screening policies for child abuse and neglect in health. Most of the identification methods reviewed assessed children only after they had presented with some symptoms. Diagnostic tools may lack precision and evidence to support their use. Vrolich-Boschert et al. 2018. Screening for IPV in HICs, i.e. a clinician sensitively and privately asking about IPV, shows that the majority of women do not mind being asked about domestic violence in carefully planned private interviews in reproductive health. Screening in selected contexts does increase identification and seems to do no immediate harm in the short term. It is not known, however, whether screening results in improved access to help and support. Doherty et al., 2014. By itself, screening is likely to be ineffective for responding to domestic violence without providing staff training, victim support and referral resources. There are concerns that screening where there is IPV Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 6. Ending Child Sexual Abuse and Exploitation, A review of the evidence 124 may discourage women in low-resource settings from accessing essential reproductive health care, and the WHO recommends clinical inquiry if abuse or IPV is suspected, rather than directly asking or screening all patients. It is not known whether these findings have relevance for adolescents. A non-experimental study of screening for sexual and gender-based violence in contexts in Uganda found that screening can be implemented and that survivors and providers had high levels of satisfaction with the screening process. Undi et al., 2016. Experience from HIV and health promotion services in LMICs indicates that those involved in prostitution are reluctant to approach services. Okela et al., 2009. Young people sexually exploited by prostitution may similarly be deterred from accessing services if they fear discriminatory responses from service providers. Integrating maternal health, violence against women and violence against children. An example of an integrated approach is the network of women and children protection units established in hospitals in the Philippines to provide a coordinated and informed healthcare response to adult women and child victims of violence. It is estimated that 59% of cases seen are cases of sexual violence. Department of Health Philippines 2011. No evaluation studies of these approaches have been identified as yet for LMICs, however. This is an approach that is recommended by the WHO in the Gender-Based Violence Prevention Strategy, Respect. WHO, 2019a. Technology to support capacity, the availability of expertise to enable good diagnosis of sexual abuse in health has been a factor that has contributed to variable practice. Telemedicine is an approach which aims to provide medical care at a distance using new technologies to communicate either directly with the patient or to provide specialist support to less experienced physicians. It is used in rural areas where there may be practical difficulties in transporting a specialist into the area or transporting the patient to see the specialist. An RCT evaluation of telemedicine in rural areas of the US found those hospitals that used telemedicine, 101 patients, produced more complete, higher quality examinations and diagnoses of child sexual abuse than hospitals without, 82 patients. Miyamoto et al., 2014. Other technological innovations supporting responses to low-resource settings include use of cloud-based GPS-enabled inventory management to ensure continuous supply of post-rape care kits in the Democratic Republic of the Congo, Bress et al., 2019. Reporting, recognizing that laws and duties for reporting child sexual abuse vary across different national contexts. The WHO guidance responding to children and adolescents who have been sexually abused, WHO, 2017, draws on a systematic review of research on healthcare professionals' values and attitudes on reporting cases of child sexual abuse to authorities to identify good practice principles for the ethical duty to report, WHO, 2017, GP 7, 39p. Education sector strategies. Given that children vulnerable to sexual exploitation are Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 125. Often missing from school, the education sector could be well placed to identify this group. Evidence also suggests that teachers are common recipients of disclosure, and a qualitative study by Karsar et al. 2013 found that among people posting in an online support forum, they most commonly advised young people to seek help from teachers. Although efforts have been made to improve school child protection responses, no tested effective studies could be found on identification strategies in schools. In some HICs, specially designated posts with responsibility for child protection have been set up to improve training, responses and coordination across different agencies. A cross-sectional study in the United Kingdom found that training and knowledge among these post holders in relation to sexual exploitation is highly variable. Harper and Scott, 2005. In LMICs, training initiatives in the education system may be helping to increase the numbers of children at risk of sexual violence and abuse who are identified. One whole school approach in Zimbabwe, for example, not only trains teachers and administrative staff in understanding gender-based violence but also teaches them how to detect, refer and counsel children who have been identified. Management Systems International, 2008. Teachers are taught how to produce accurate records for referrals and for court cases. To allow time for these new roles, the school has lightened the teaching load so that teachers are able to spend time with children to complete the required paperwork. Evidence of impact has not, however, been found. Analysis of data on child protection and help seeking in Uganda from the Good Schools Toolkit. Evaluations found that first-line responses to referrals made to child protection services were extremely poor, and only 3.7% of children referred to child protection met the criteria for getting an adequate response. 3.7%, n equals 20, out of 529 children referred from a baseline sample of 3,706 children, Child et al., 2014. Social Welfare and Child Protection Strategies. Historically, the lead agency for child protection in HICs has been social work, which after needs assessment, has developed two main responses: family support, which involves social workers supporting the child and family to improve safety and care, and removal of the child to a place of safety, usually short-term care with a foster carer. In HICs, evidence of outcomes for children who have been subject to orders for care or protection do not specifically consider protecting children from sexual abuse and exploitation. Davies and Ward, 2012, Farmer and Lutman, 2010, Wade et al. 2011. Identification and provision of protective services for children and young people who have been sexually exploited has recently been subject to scrutiny and efforts increased to improve responses. J. 2014, Mason Jones and Logie, 2019. In the UK, a new approach to understanding and responding to young people's experiences of significant harm, including child sexual exploitation, outside of the family home. Contextual safeguarding is being piloted across a number of local authorities. Contextual contents: Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References: Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 126. Safeguarding aims to expand the objectives of the UK child protection system, traditionally focused on abuse within the family home, in recognition that young people are vulnerable to abuse in a range of social contexts. Furman, 2017a. This approach has been adopted in, and is being promoted through, National Child Protection Policy and Guidance Documents, DFE, 2018a. While the evidence base on the effectiveness of this approach continues to develop, a range of research findings produced by the team developing this approach distinctly makes the case for a more flexible and inclusive child protection system that addresses the welfare and protection needs of adolescents. Furman, 2019a and 2019b, Furman, 2018. Furman, 2017b, Lloyd, 2018. A range of resources and papers have also been developed to aid improvement of local authority identification, assessment and response approaches to extrafamilial harm, and can be found on the Contextual Safeguarding Network, www.contextualsafeguarding.org.uk. In LMICs where social welfare systems are not well developed and lacking in resources, identifying and responding to the needs of sexually abused and exploited children is more difficult. In many LMICs, removal of the child into residential accommodation is the main child protection system response, and the outcomes of this are not assessed. Roche, 2017. Research to track outcomes from child protection responses is generally only possible in relatively well-resourced child protection systems. Research in South Africa, for example, tracked outcomes for child victims via police and child protection /social work records, and found, despite comprehensive legislation and policy on child protection, poor implementation, resources and training for professionals left many children without an adequate response. Almost 3/4, 74%, of cases referred to social workers did not get referred to the police for investigation. The police arrested only 75% of identified perpetrators, and 58% of those arrested were soon released and sent back to the victim's home or community. Only 12% were convicted. Jamieson, Sambu and Matthews. 2017. Messages from this study have relevance for many child protection systems regarding the need for supervision and monitoring of social workers, effective case management, evidence-based and standardized assessments of children's needs, ensuring a child has a safe environment, good multi-sector working, access to therapy and family support for the child, and efficient methods of information management and planning. Confidential child helplines. Child helplines have been set up in many parts of the world. The International Movement to develop child helplines has been identified as good practice in the UNSVAC report, Pinheiro 2006, and elsewhere, EXA 2011, UNISF 2014b, as a strategy for reaching out to children who may find it difficult to talk about abuse and find help. Helplines provide easy access for children via mobile and landline telephones, and, increasingly, web-based services. Child Helpline International 2011b, Fucking, Bruns, and Lichtvoort, 2016. They are becoming more available globally, although the services offered are not standardized and vary significantly from place to place. In HICs, child helplines generally take Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 127 Calls from children and provide an active listening service. And, where information becomes available, they offer a protective response through referral. The UK Childline model, well supported by government funding, has been adopted by LMICs such as India, Malaysia and South Africa. There are many more small helplines that exist worldwide without government funding and are entirely reliant on donors or partners. Mala Mjid 2008. Child helplines in LMICs fill gaps in the child protection system that those in HICs do not have to do, for example, providing education, housing or legal counsel or organizing direct interventions for recovery, covered in more depth in the final section, ACPF, 2014, Fucking, Bruns, and Lichtvoort, 2016. Child helplines often report annual figures on the numbers of children who call, why they call and other descriptive information on what they do, for example, numbers of referrals, and it is possible to track trends in caller demand, which can help governments and civil society organizations plan and meet children's needs. Child Helpline International has analyzed calls over a 10-year period and found differences in reasons for calls made in LMICs, many calls on safety and health issues, and HICs, where children more often call for emotional support with peer and family relationship issues. Fucking, Bruns, and Lichtvoort, 2016. Increasingly, child helplines are providing counseling services by mobile phone messaging. However, no long-term studies have been carried out to evaluate the impact of child helplines on caller safety because follow-up methodologies are difficult when anonymity is promised to callers. Child helplines have a crucial role in providing direct access advice and referral for children, including those in humanitarian contexts. For example, Childline India was swiftly established in the initial stages of the 2001 Gujarat earthquake and worked to refer vulnerable children to appropriate services. Childline India Foundation 2011. Proactive engagement, services that do exist. Attempt to provide integrated services that prevent further exploitation and help children and young people to reintegrate. A coordinated approach is crucial because the needs of sexually exploited children and young people are multidimensional and not likely to be met by one sector alone. Cregan et al. 2005, Lynch, 2017, Pierce, Williams, and Galvin, 2003. A non-experimental study of a service for sexually exploited young people in the UK found a decline in recorded episodes of young people in the service going missing, reduced conflict with families, improved ability to recognize risky and exploitative relationships, and an increased awareness of service users' rights. The direct service focused on access, assertive outreach, advocacy, and flexibility in service provision. Intensity of contact was found to be crucial in engaging service users, Beckett, 2011. While these types of services are valued by multi-agency partners and professionals, they are frequently underfunded, and providing a service in line with national guidance has not always been easy to achieve. Advocacy and outreach programs to overcome the considerable barriers sexually exploited adolescents face in accessing protective services, advocacy and outreach programs have been developed. Bovanik, McNeish and Pierce, 2016, Scott et al., 2019, Smeton. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 6. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 128. 2016. Outreach can take many different forms: home-based, street-based, traveling/mobile, satellite or peer. Models exist for work with sexually exploited adolescents. Scott et al., 2019. Outreach can reach vulnerable children and young people who are missed by other services, help identify unmet need, establish contact with hard-to-reach groups, motivate access to services, raise awareness about help, and building trusting relationships between the advocate/outreach worker and the child or adolescent. The UK children's organisation Barnardos developed the 4S approach to working with sexually exploited adolescents. This involved the 4 strands of assertive outreach, advocacy, attention, and access. The assertive outreach involves the advocate going into a community rather than expecting adolescent victims to come to a service. In the community, an advocate offers services an adolescent may need, responding to their immediate and basic needs such as health care, showers and food. The outreach approach is based on the understanding that the advocate needs to build a positive relationship with the young person to effect change, identifying small, manageable steps. Advocacy involves supporting the young person to get the services they need, sticking by their case and giving positive attention. Only qualitative studies of the program were identified in this review. Bovanik, McNeish and Pierce, 2016, Smeton, 2016. Shepherd and Lewis, 2017. Advocacy has been found to assist in building trusting relationships and help children navigate complex circumstances, speak up for children, and act in their best interests, maintain momentum when required, and improve decision-making as well as spreading expertise in trafficking. Coley et al., 2015. Advocacy programs for sexually exploited young people set up by the Home Office in England are currently being evaluated. Keeble, Fair and Rowe, 2018. There is movement towards understanding what works and good or promising practice in human trafficking interventions, Hines et al. 2019. Sexual exploitation survivor research in Cambodia has similar findings on the features of successful engagement and advocacy for young people, Cordisco et al. 2018. Case management. Case management is one particular approach that is seen as good practice across HICs. Chung et al. 1991, Holmes et al. 2012, Sartor et al. 2015, LMICs, McCormick, 2011, Terades Homs, 2009, UNICEF Malawi, 2011, and, increasingly, humanitarian settings, IRC/UNICEF, 2011. There are different approaches to case management, depending on the client population needs, but in general, case management is the process of a lead professional, often a social worker, assisting an individual child and his /her family through assessment of needs, direct support, referral to and coordination of other services, McCormick, 2011. Case managers may alternately be called key workers, advocates or guardians, as identified in UNICEF Guidance on the Protection of Trafficked Children, UNICEF 2006. Whatever the name, the case manager can advocate on the child's behalf, ensure any action taken is in the best interests of the child, coordinate the response, and act as a consistent, trusted person for the child to engage with, as well as a single point of contact for those. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 129. Different agencies to communicate with. This has been recommended for those working with child victims of sexual exploitation and internal and international trafficking for sexual purposes in many different contexts, Clausen and Dutch, 2008, Coley et al., 2015. In HICS, case management systems are usually statutory and are centered on collaborative and coordinated work with many actors, Gilbert, Partan et al. 2011. While evidence on impact for families and children is still limited, there is evidence of benefits from the method of general working involved, the assessment, individualized planning, coordinated services and monitoring of cases. From initial contact to end of service, Sartor et al., 2015. Case management methods in HICs have developed in specific ways, responding to their own national and regional contexts, and have not had the added pressures of dealing with complex situations that arise in LMICs. Case management systems that exist in LMICs and have developed very differently depending on country context, UNICEF Malawi 2011. While robust experimental evaluations with case management systems in LMICs were not found by this review, a study in Malawi at the pre-test and pilot phase of a case management system was identified. This system, developed by the government with the support of UNICEF, donors, partners and other NGOs, aims to strengthen the overall child protection System and harmonize the practices of identification, assessment, referral and provision of support services. The system was developed using indigenous knowledge and building on a foundation already in place. The pilot test found that the service benefited users and that coordination reduced duplication and clarified roles and responsibilities of individuals working in child protection. It is anticipated that a post-test study will add further knowledge in this area. IBAD case management is also recommended as a minimum standard for child protection in humanitarian settings. In several guidance documents, for example, Child Protection Working Group, 2012, IRC/UNISF 2012, but knowledge is currently limited to practice in the field. Private sector transport services. The transportation sector has a key role to play in responding to sexual exploitation. Taxi drivers, trucking companies and bus and railway stations all serve as links between potential perpetrators of sexual exploitation and vulnerable children and young people. IPIC 2007. There are some notable projects that have attempted to tackle the problem in this sector. In Brazil, for example, the World Childhood Foundation has developed a national program on the right track with the transport sector to combat internal trafficking for sexual exploitation. It includes private sector actors in transport who signed a pact that commits them all to a list of rules to combat trafficking for the purpose of sexual exploitation of children on Brazilian roads and highways. Promising evaluation findings are emerging. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 130. From this work, Wernick, 2015. The Transport Union in Burkina Faso has trained its staff, including bus drivers, on what child trafficking is and how and to whom to report cases. Lessons learned from the initiative have been shared in regional meetings, but so far no evaluation of this initiative has been found. IPIC 2007. Nighttime economy. There are community-based programs that provide resources and training to the private sector and to services in the nighttime economy, aiming to prevent and respond to sexual exploitation of adolescents. Limited process evaluations have been carried out, but studies on prevention impact have not been identified. One example of such a program is Night Watch, a UK-based initiative led by the children's organisation Bernardos. This aimed to safeguard children and young people from sexual exploitation by increasing awareness among businesses and services working in the nighttime economy, by developing strategies, in co-production with these businesses and others, to identify and protect children at risk at night, and by intervening early by providing advice, support, training and guidance. The project was delivered across 14 locations and included those working in fast food outlets, hotels and bed and breakfast accommodation, accident and emergency services, and security service roles, such as door staff. The program had a wide reach measured by numbers of individuals in receipt of training, and there is some positive evidence from the mostly qualitative evaluation that awareness of prevention and partnerships improved. As a result, Darcy and Thomas, 2016. There was no data collected, however, on the impact on preventing or responding to child sexual exploitation, Thomas, 2019. Community-level strategies for identification, reporting and child protection. Protective services for children in many LMIC's countries tend to be multisectoral or provided by NGOs and community groups, and they have more limited capacity and reach. For example, in Afghanistan, all protective services such as safe shelters and drop-in centers are limited to urban areas and often only open to children by day. Frederick, 2010. In LMICs, safe houses and temporary shelters are usually seen as a last resort, Zabala, 2001, and are often limited because they are expensive to run and difficult to sustain, Keysbury and Askew, 2010. As a response to protect children, the research evidence on shelters and residential care in LMICs is limited. Brody and Pierce, 2017, Gale, 2019. UN Guidelines for the Alternative Care of Children, United Nations General Assembly, 2009, and accompanying guidance, Cantwell et al., 2012, recommend use of alternative family-based or foster care, limiting use to smaller group residential institutions on the basis of suitability and necessity, and the gradual elimination of care for children in large residential institutions. Protection from exploitation and abuse and care of children and adolescents who, as a result of trauma, living on the streets or behavioral problems, may not be ready to return to family life may be. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 131. Reasons why an individual child might need care in a small residential community, Huyn et al., 2019. However, there is also research showing that children are re-victimized in residential care, Brody and Pierce, 2017, and many children in orphanages and shelters are primarily there because of separation resulting from poverty, suggesting that preventive measures to support and reintegrate separated children with families would be better strategies. Gale, 2019, Stark et al., 2017b. A number of civil society organizations are engaged in outreach work to identify children who are at risk of or who are currently being sexually exploited. For example, the Meninas Adolescents Project in Brazil provides a comprehensive service of prevention, protection and rehabilitation, but also seeks to identify children through coordinated actions with schools and community centers. Once identified, the young person is invited to take part in further services offered and may be linked into other organizations. A range of community-level actors may be involved in helping to identify children at risk of sexual abuse and exploitation in HICs, but this will be dependent on the level of knowledge they hold in relation to these issues. Youth workers, volunteers, civic organizations and faith leaders are all examples of those at the community level who may have a part to play. Helplines exist for adults to contact. For advice, for example, the NSPCC helpline is offered in several different languages and is staffed by trained social workers who provide confidential advice about recognizing and reporting sexual abuse. www.nspcc.org.uk/helpline right parenthesis. Although most of these projects keep data on caller numbers, there is little evidence from research on whether or not they lead to an increase in identification and referrals. Gilbert et al. 2009b. Community involvement in child protection. The Stewards for Children, Darkness to Light program, discussed in the previous section on prevention, has been subject to a randomized controlled trial that included evaluating whether or not rates of reporting child sexual abuse increased in the areas where the program operated. Letonio, Nietet and Ringold, 2016. Conducted an RCT in South Carolina comparing child sexual abuse reports made in 3 areas with Stewards for Children programs with child sexual abuse reports made in 3 areas without this program. Pre- and post-program implementation, child sexual abuse reports showed a significant increase in the numbers of child sexual abuse cases reported in the areas with Stewards for Children compared to areas without community-based child protection mechanisms. CBCPMS include all groups or networks that respond to and prevent problems of child protection and vulnerable children. These mechanisms may include family supports, peer group supports, and community groups such as primary and secondary schools, non-formal education and vocational training structures, women's groups, religious groups, and youth groups, as well as traditional community processes, government mechanisms, and mechanisms initiated by international or domestic non-governmental Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 132. Organizations, NGOs, Prickett et al., 2013, 5p. In LMICs and humanitarian contexts, community level mechanisms have become very important in supporting and strengthening child protection systems. Save the Children Sweden, 2010, Wessels, 2009, 2015. These may be formally established as community-based child protection or child welfare committees, to bring together a network or group of individuals at community level to work in a coordinated way toward child protection goals. DSAS. Kropinnicki, 2012. Identifying vulnerable or orphaned children and children at risk of abuse is one aspect of their work. These are increasingly being supported by child protection actors in NGOs and government to increase the impact and sustainability of the existing child protection systems and interventions. War Child, 2010. As they are based in local communities, they are well placed to identify local vulnerable children and can help to support the existing child protection system by facilitating links and access between community groups, family and kinship structures and national services, where they exist. Save the Children Sweden, 2010. Community mechanisms can be largely internal, a mixture of traditional and outside influence, or externally initiated and supported. Guidance in this area suggests that externally supported community-based mechanisms such as child welfare committees are less effective because they undermine existing community ownership and resources. Effective community mechanisms are those that include local structures and traditional or informal processes for promoting or supporting the well-being of children. Several studies in areas of conflict, delay and Knudsen. 2008, K. Foucault, Tuzeliru and Okbo, 2015, Prickett et al. 2013, Stark et al. 2012, Warchild UK, 2010, Warlake Ira. Ismail and Bjormujizga, 2013, Wessels, 2015, found evidence of the ways in which community mechanisms could strengthen existing systems by increasing access to services, strengthening relationships between civil society and government and supporting existing structures. One problem with community-based child protection mechanisms is that many rely on the family as the first line of support in cases of child abuse. A study in Uganda found that a common response of families to protect a child was to regulate or restrict the child's activities. Community elders were not helpful to children because of the culture that everybody should mind their own business. Community-based child protection groups need to be integrated with wider child protection services. K. Foucault, Tuzeliru and Okbo, 2015, Wessels. 2015. A review by Wessels, 2009, found that gender-based violence was not commonly covered in studies and documentation of community mechanisms he reviewed, making assessment of their usefulness in protecting children against sexual abuse and exploitation difficult. While these systems have been found to be effective under the right conditions, there is no clear evidence about their effectiveness in helping to identify and refer children and adolescents who are at risk of or being sexually exploited, although there is qualitative research that shows that associated risks such as teen pregnancy, poor school attendance and transactional sex may be reduced. Wessels, 2015. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 133. Reset, Bailey et al., 2015, Mace et al., 2015, is a multi-agency community engagement project developed in Australia to improve identification and reporting of child sexual abuse cases within Aboriginal communities, where risks are known to be high but rates of reporting currently low. Reset involves creating an interdisciplinary mobile team bringing together police, child protection, family support services with responsibilities for proactive outreach, to engage with and consult with members of the community, sharing responsibility with them to identify the nature and extent of child sexual abuse in the area, its underlying causes, and devise a collective action plan that builds relationships, capacity and strengths to respond. Bailey and colleagues, 2015. Report on the quantitative evaluation of data on reporting. Arrest and prosecution trends. Significant increases in reporting, arrests, prosecution and convictions for child sexual abuse cases were observed in the reset sites, compared with the 4 control sites that had no reset program. Mace and colleagues, 2015, evaluated the effectiveness of reset via a qualitative evaluation, involving 64 stakeholder interviews 18 months into the project. It was found that the 4 elements of reset success were proactive outreach, dedication to capacity building, taking a holistic focus to the community problems and establishing relationships to facilitate trust. While these findings are encouraging, further follow-up studies in different areas will be needed to support any conclusions about effective approaches to increase reporting in minority communities. Sport is an area where children and young people can be vulnerable to sexual abuse and where there is often a lack of supervision of coaches and teachers. Mountjoy and colleagues, 2015, report on the introduction of new international standards for safeguarding children in sport developed by the International Safeguarding Children in Sport Founders Group. The article refers to research conducted with stakeholders to guide the implementation of the safeguards, which emphasized the importance of tailoring responses to the local context. The models safeguards include establishing procedures, providing advice and support, guidelines for behavior, partnership work, effective training and monitoring and evaluation. No research on the impact of these standards was found in this review, although this may emerge if monitoring and evaluation recommendations are implemented in sports organizations. In the Netherlands there is a telephone helpline for child sexual abuse in sport which was established by the National Olympic Committee and the Netherlands Sports Confederation following a high-profile case in this country. A recent study by Vertomen, 2015, found that this had been useful to sports organizations. 42% of calls to the helpline from 2001 to 2010 were from staff concerned about abuse of a child. The level of calls provides some evidence that professionals will seek advice on identifying cases of sexual abuse, online abuse reporting, in the UK, and in similar jurisdictions. Organizations such as CSAE, Child Exploitation and Online Protection Center, part of the National Crime Agency, the National Child Exploitation Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 134. Coordination Center, part of the Royal Canadian Mounted Police, and FBI in the USA have established methods to identify victims of online abuse, to enable young people and adults to report abusive images and sites, as well as develop resources to support prevention, as previously discussed in Section 4, and to identify and apprehend offenders. Reports from these organizations show increases in online abuse reporting and increases in the numbers of child victims identified online, although most of the research has centered on the impact on offenders. A 5-year evaluation of Canada's National Strategy for The protection of children from sexual exploitation on the Internet by Public Safety Canada, 2015, found that during the time period 2008 to 13 there had been a significant rise in reports from the public to the online abuse reporting site, cybertip.ca during the evaluation period, although factors outside the strategy will have contributed to this. The increased reporting was noted to have put pressure on the resourcing of law enforcement agencies, interagency communication and problems with the rollout of the National Child Exploitation Tracking System, SETS, were found to hinder the coordination of the strategy's approach. Child, family and relationships. Although known adults or peers, including relatives, are the most prevalent perpetrators, family and friends also play a key role in protecting children. They often identify and report sexual abuse, McCormack et al. 2005. It appears that although family support has been crucial in child protection work, most of the research literature has centered on the family role in prevention or in supporting recovery and reintegration. In some cases, as in work by Save the Children Alliance in Afghanistan, children have participated in developing broader child protection procedures. A child protection monitoring tool was developed for children to record child protection incidents and to help them identify and plan protective actions. Frederick, 2010, although information on its impact has not been found. Parenting support is a feature of many combined programs such as Compass discussed later. Parents Against Child Exploitation, PACE, is one of the few voluntary sector services in the UK dedicated to supporting parents whose children are or are at risk of being exploited by perpetrators external to the family. They operate a relational safeguarding model, which recognizes the impact of CSE on the whole family, values parents' vital role in safeguarding their children, and takes a holistic approach working alongside parents to protect and safeguard their children. PACE, 2019. Parent liaison officers work with parents to build resilience, strength and empowerment to play a safeguarding role. A qualitative evaluation of the relational safeguarding approach with 14 parents and 14 professionals found those who had support from parent liaison officers had good attendance at court and parents reported better understanding of CSE and confidence in safeguarding their children. Shuka and Akali, 2017, PACE, 2019. Peer support. Peers and siblings can be an important source of protection and help for maltreated children. Although there has been little research on this in HICs. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 135. Examples are Olnick, 2015, Mudaly and Goddard. 2006, or LMICs. One example is Mainck 2014. Friends of adolescents, aged 12 years and over, can provide practical, moral and emotional support to peers experiencing sexual abuse in childhood. Olnick, 2015. But intervention responses have rarely recognized this, enabling children and adolescents to protect themselves has had more attention. Most efforts to build on children's roles in child protection in HICs have focused on online abuse. There are simple but important ways that children can protect themselves and others through opportunities to report abuse easily in the online environment. Ospina et al. 2010. Internet providers and software packages can provide parents with ways to monitor their children's online activities, although the evidence is mixed as to the effectiveness of some software. Quayle 2012. Humanitarian context-specific responses. Child-friendly spaces. UNICEF's gender-based violence in emergencies strategy recommends creating safe environments inside camps for women and girls to access confidential services and resources. UNICEF 2017. C. In humanitarian and emergency settings, child-friendly spaces have been used with increasing frequency to provide protection for children. Save the Children Sweden 2010. These are also places where children may be identified and referred to other services. Child-friendly spaces are recommended as good practice in guidance on sexual exploitation in emergencies based on experience in the field. CCF 2008. Save the Children. Sweden, 2009. Guidance on child-friendly spaces has also been produced. Save the Children, 2011a. Many examples exist, such as those set up by UNICEF in Indonesia following the 2004 tsunami. Many centers have gained long-term sustainability by transforming into more formal service providers. A review of the literature, Agar and Metzler, 2012, on child-friendly spaces did not identify any impact on identification methods but did find outcomes for protection. Several studies documented an increased sense of safety among children. Iber et al. 2014, and a decrease in sexual exploitation and rape. Agar and Metzler 2012, Kostelny 2008, Madfis et al. 2010. One study found an increase in child rights awareness, which meant children were more likely to tell someone if they saw something bad happening. Gladwell 2011. Other studies documented a decrease in physical injuries since the start of the child-friendly space intervention. Kostelny, 2008. The study by Metzler et al. 2014 found some increases in sexual harassment if children had to walk across the camp to get to the child-friendly space, and a review for the International Federation of Red Cross and Red Crescent Societies notes that violence within child-friendly spaces is an issue that needs attention. Building on the earlier evidence review, which found a lack of robust outcome evaluations, Agar and Metzler, 2012, World Vision has supported research on child-friendly spaces in several regions, including some comparison between children attending child-friendly spaces and children who did not attend, considering vulnerability variables. World Vision. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 136. 2015. This concluded that there is evidence that children benefit from child-friendly spaces, for example improved literacy and numeracy, but the impact is varied and often small. No information on impact regards sexual violence was found. Further thought needs to be given to what aspects of child-friendly spaces and activities undertaken are effective. Key issues seem to be program quality and fit with local circumstances. Risks faced by children require assessment in context as needs may vary in relation to age, center location in urban or rural contexts, etc. Child-friendly spaces are less successful in engaging with older children and adolescents, and the nature of activities offered should be reviewed so these are relevant to their needs. Follow-up evaluations are required to assess the impact of these programs on children and young people in the longer term. The Compass program, creating opportunities for mentorship, parental involvement and safe spaces, now renamed Safe Place to Shine, is a combined safe spaces, parenting support and adolescent empowerment program supported by the International Rescue Committee and evaluated by Columbia University in Pakistan, Ethiopia and the Democratic Republic of Congo. FALB, 2016, Stark, 2018, IRC, 2017. Compass included the following 3 core interventions. Adolescent Girls Life Skills Sessions, weekly discussions with groups of adolescent girls in allocated safe spaces, facilitated by young female mentors. Parent/caregiver discussion groups, monthly discussions with parents/caregivers of adolescent girls participating in the program. Service provider support, targeted training and ongoing support to develop knowledge, capacity and skills regarding the specific needs of adolescent girls, and particularly those who have experienced gender-based violence, GBV. RCTs in all 3 countries found a number of positive outcomes from Compass for girls, for example more friends, more hope for the future, parents, e.g. improved relationships with girls, and services, increased use of services. The program increased girls' knowledge of services so that those who took part in Compass were twice as likely to go for help if sexual violence was experienced. Compass provided girls with a safe place, but its broader impact on girls' safety was unclear. Although there was an overall reduction in girls' reported exposure to GBV in DRC from the beginning of the program to the end of it, the evaluation could not demonstrate that this change came as a result of Compass. The evaluation also did not show a statistically significant improvement in girls' feelings of safety outside the safe space in Ethiopia or DRC. Consultation with girls was essential throughout the program to ensure it was flexible and relevant to girls' needs. The evaluations also show that it is important to have quality GBV services and trained staff to implement Compass, IRC, 2017, Stark, 2018. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 137. Peacekeeper Responses, a review of evidence highlighted the importance of humanitarian and peacekeeping personnel assisting in the establishment of community initiatives to identify and respond to sexual violence. Examples include initiatives such as building communities around safety, led by UN police officers in Darfur, which have involved creating women's desks in camps and other groups that can respond to sexual violence and collect data, allowing humanitarian agencies and the United Nations to more effectively target activities. Anderson, 2010. Uniformed peacekeepers have worked with humanitarian agencies to establish grassroots referral networks for sexual violence victims, to facilitate access to medical /psychosocial support. Humanitarian organizations have developed safeguarding policies to protect children from abuse and exploitation by staff in those organizations, as well as provide staff with clear guidelines for responding to abuse disclosed in the course of their work. Save the Children International, for example, developed policies that include a global safeguarding policy, a code of conduct for staff, global human resources policies for recruitment, induction, staff development and training, whistleblowing pathways, and country-specific child protection procedures. Save the Children, 2011b. There is often a resistance to reporting, investigating, and punishing abuse. A key issue for this sector is that peacekeeping forces are not accountable to the host country's criminal jurisdiction but to the country that deployed them. Steps should be taken to address a culture of impunity by sending clear messages to military and police traveling into humanitarian settings that sexual abuse and exploitation will not be tolerated. For example, certain countries have taken steps to hold peacekeepers accountable by implementing disciplinary action. It is far from clear, however, how successful these measures are in protecting children and adolescents from sexual abuse and exploitation, given the difficulties in gathering evidence and calling witnesses at a distance from the setting in which the abuse occurred. Base Ticket AL 2010. To address these problems, it is recommended that troop contributing countries hold on-site court-martials in the country where the alleged offenses were committed. United Nations General Assembly 2006. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 138. Review Question 3. What is known about effective approaches to identify and protect child and adolescent victims of sexual abuse and exploitation, online and offline? Identification. There are many reasons why it is difficult to identify children living with sexual abuse and exploitation. These will differ according the age of the child, the nature of the abuse and the relationship and context in which it occurs. Universal challenges to identification include 1. Barriers to disclosure by children and adolescents, especially social stigma, shame and secrecy. 2. Lack of awareness, understanding and recognition of sexual abuse and exploitation among parents and the wider public. 3. There is often no immediate physical evidence to indicate abuse. 4. Professionals' lack of skills and training in identification and response. 5. Poor multi-sector coordination and information sharing. 6. A policy, cultural or organizational context that blames or criminalizes the victim, normalizes child abuse and or does not support identification and child protection responses. A wide range of efforts to improve the identification of children who are sexually abused or sexually exploited have been made. These include public education campaigns encouraging victims to access services, programs for children in education settings or the community urging them to speak out, i.e. tell a trusted adult about abuse to themselves or to other children, providing confidential services such as helplines that allow children to talk about their worries, including abuse, improving the accessibility or child-friendliness of services, forensic methods of screening online to identify victims or perpetrators, hotspot policing and traffic stop policies, screening / directly asking about victimization in healthcare settings, screening vulnerable groups for indicators thought to be linked with sexual exploitation, training parents, communities or professionals on how to spot the signs of sexual exploitation and how to respond, setting up specialist outreach and advocacy services to engage with vulnerable groups such as runaway or trafficked children, multi-agency data sharing to aid early identification and coordinated action. Public awareness campaigns have assessed reach, for example number of leaflets distributed or audience size, and sometimes changes in contact with services, but without additional strategies and resources, impact on access to services may be short-lived. Education and training programs targeting professionals frequently measure only changes in levels of awareness and knowledge or self-reported motivation to apply the knowledge to identify victims or speak out about abuse. Programs that include adequate investment of resources with training for professionals and integration into wider child protection services are more successful in increasing identification and access to services for children and adolescents. This is also the case for specialist services such as one-stop shop or integrated health services for rape and sexual violence or child maltreatment. Health workers play a key role in identifying sexually exploited and abused children, and training and indicators of sexual abuse and exploitation have been provided in HICs and LMICs, especially in connection with STI/HIV services. Guidance, common assessment, treatment and referral methods are essential for effective identification and response but need to be supported by adequate training, take up by the community and services to respond to referrals. Screening has been implemented in primary care in the US and in emergency contexts, for example in Uganda, and preliminary results show this increased identification and referral rates and survivors and providers. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 139 were satisfied with screening. Although often recommended, no evidence was found on the effectiveness of screening for child sexual abuse and exploitation in health reporting. Underreporting of child sexual abuse and exploitation is a problem identified in most jurisdictions. Mandatory reporting increases reporting rates but is ineffective without sufficient resources for assessment and support for children and families identified. Encouragingly, in Australia, introducing mandatory reporting brought increased reporting of child sexual abuse. Some contraindications have been found for mandatory reporting, such as avoidance of services by parents / survivors fearing loss of their children, harm to professional or therapeutic relationships with the child or family, overloading resource-poor services. It is not known if increased reporting improves safety for children and adolescents. To address barriers to reporting and access to services, it is important to have context-specific assessment and involvement of children, adolescents and communities in implementation so programs fit with local circumstances. Child protection responses. Child protection services in HICs have been the main agency responsible for protecting children from sexual abuse and exploitation, although there is a lack of evidence on outcomes for children and on what responses are the most effective. Child protection in LMICs is more commonly provided through NGOs and community groups, and services tend to be thin and unevenly spread. Case management is seen as good practice across HICs, LMICs and increasingly humanitarian settings, and although evidence on outcomes for children is limited, research shows clear benefits from good case management methods. Outreach services for sexually exploited children and young people are successful in engaging with young people who avoid service contact. For example, Barnardo's UK 4 model, Runaways programs in the US. However, more research on outcomes is needed. Integrated or one-stop shop identification and response teams, as in health or child welfare, for example Thuzula services in South Africa, SARCs in UK, Children's Advocacy Centres in the US, Barnahus / Children's House, can bring an increase in numbers of sexual abuse and exploitation victims. Using services, increases in non-offending caregivers' satisfaction with the child's treatment and swifter provision of therapeutic help and support. In HICs, some of these services have been shown to lead to increased offender prosecutions. Evidence in post-conflict and / or humanitarian contexts remains particularly low. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence 140. Table 7. Summary of evidence on identification, reporting and protection. Identification and protection across different sectors. Quality of evidence. Hicks. Quality of evidence. Mix. National mandatory reporting leads to increased reporting of child sexual abuse cases, but increased resources are needed to respond. Few studies have followed up responses to assess outcomes. For children, adverse impacts include damage to therapeutic / professional relationship with a child and family, deterrent impact on child or parental help seeking. Prudent. Evidence-based guidelines on identification, assessment and multi-agency referral. Responsibilities evaluations mostly measure impact on professionals, system efficiency and policy implementation. Prudent. Multi-sector multi-agency identification, assessment and coordinated response mechanisms. Example: MAICs in UK. Evaluations limited and mostly measure impact on professionals, system efficiency and policy implementation. More research needed. One-stop shop sexual health / gender-based violence services, for example, safe in Bangladesh. Impact on physical violence from partners for girls aged 15-19 years in mixed gender group. Evidence of take up of sexual health services, for example, Pansy Hospital Project DRC, Copper Belt Project. Evidence that examination services can be done by forensic nurses. Little impact on prosecutions. More research needed. More research needed. One-stop shop services for children / children's houses / child advocacy and support services, for example, Barnahus in Europe and South Africa, CACs US and Canada, Chiquanequanes in Malawi. Evidence of take up of services, caregiver and child satisfaction and possibly improved access to therapeutic support. Although outcomes rarely evaluated. CACs in HICs do not increase rates of disclosure but increase use of forensic interviews and medical examinations. Early on in the justice process, CACs have better justice outcomes than standard practice. Impact on prosecutions is mixed / limited. Prudent. Coordinated programs to respond to gender-based violence and child maltreatment, for example. Specialist women and children protection units, for example, Philippines. Limited research on impact. Prudent. Helplines for professionals, for example, trafficking helplines. Increases in service take-up but evidence of impact on safety of children and adolescents limited. Likely to be useful in developing capacity. In the context of comprehensive community response programs. Needs more research. Training professionals to identify and report child sexual abuse / sexual exploitation, for example, stewards of children in the U.S. Cases reported to authorities rise, but it is not known if increased reporting has an impact on quality of responses given and outcomes for children reported. Prudent. Contents: Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References: Section 6. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 141. Identification and protection across different sectors. Quality of evidence. Hicks. Quality of evidence. Mix. Criminal justice. Cross-national police collaboration, online victim and CSAM identification. Increases in rates of detection and takedown of CSAM. Prudent. Patrolling hotspots for sexual exploitation, research on impact limited. A study in Texas found this led to an increase in the number of missing and sexually exploited children identified. Needs more research. Special police units, for example, family support units, children's desks, Tanzania. Evaluations are few but audit data mostly measure impact on professionals, system efficiency and policy implementation. Needs more research. Investigative child interview protocols, for example, NICT protocol found to improve evidence collected, although not for preschool-aged children. Promising. Special measures for vulnerable and child witnesses some positive outcomes in terms of client satisfaction, but service provision is uneven. Prudent. Health screening for sexual violence. There is evidence from primary and antenatal care in the US and UK and from emergency contexts in Uganda that this can be implemented, can increase identification and referral rates, and survivors and providers were satisfied with the screening. But it is not known if this leads to better responses. Harmful impacts include risk that victims may not access health care due to concerns about confidentiality. More research needed. More research needed. Screening for trafficking victims. Research in the UK found that most referrals to health have already identified the child as a potential trafficking victim. Health professionals need training on what to do to protect the child. Ineffective education training. Education professionals on sexual violence prevention and response evaluations show a positive impact on levels of knowledge and intent to report, but limited evaluation of impact for child or adolescent victims. More research needed. More research needed. Social welfare and child protection. Child helplines or report abuse lines for adults. Children call services and access services as a result, but evaluation of outcomes is limited. Prudent advocacy and outreach programs. For example, Barnardo's UK trafficking advocacy. Qualitative evidence of effective engagement with sexually exploited young people, reaching vulnerable groups missed by other services, some improvements in well-being and access to other services, and client satisfaction. Prudent. Table 7. Summary of evidence on identification, reporting and protection, continued. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 6 Ending Child Sexual Abuse and Exploitation, a review of the evidence 142. Identification and protection across different sectors. Quality of evidence. Hicks. Quality of evidence. Mix. Social welfare and child protection. Continued. Case management systems. Limited research on impact for children and families. Evidence on service efficiency from improved assessment, individualized planning, coordinated services, and monitoring of cases from initial contact to the end of service. In Malawi it was found case management reduced service duplication and was received well by families and professionals. More research needed. More research needed. Private sector. Involving the transport sector in identification and response, IG on the right track. Truck drivers program in Brazil. Limited evidence on impact found. More research needed. More research needed. Training and support for services in nighttime economy. Limited research suggests improved awareness but only limited information available on impact on referrals. Ignite Watch. More research needed. More research needed. Online report abuse buttons lead to increase in public reports of CSAM or harmful materials. Prudent. Community crisis centers and shelters. Limited evaluation of outcomes in LMICs. while mostly qualitative. Research on GBV in HICs shows positive impact of shelters on adult women's safety. Residential care for children and adolescents can bring additional risks of harm and should be a last resort. Ineffective. More research needed. Community-based child protection committees' data on impact on children is scarce. In the mix, these often rely on families as the first line of support, and links with services and child welfare may be poor. More research needed. Whole village / whole town interventions, for example Operation Reset, Australia, Reach Out, Rotherham, UK, increased reporting of child sexual abuse found in Australian Indigenous communities. More research needed. Child, family and relationships. Peer support. Qualitative studies show mostly positive impact for older children but limited research found on how to strengthen peer support. More research needed. More research needed. Humanitarian crisis. Specific child-friendly spaces. Some are associated with reduced rates of rape and exploitation, although there is counter-evidence that in some contexts children are at increased risk walking across camps to reach these facilities. Parents report reduced concerns about child trafficking. There is no evidence from reviews of increased community capacity to protect children and adolescents. More research needed. Combined safe spaces, empowerment and life skills, GBV prevention and parent support, e.g. Compass / Place to Shine. RCTs show a number of positive benefits for well-being of adolescent girls, but only one RCT found reductions in sexual violence, and this could not be attributed to the program. More research needed. Table 7. Summary of evidence on identification, reporting and protection, continued. Contents: Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References: Section 6. Ending child sexual abuse and exploitation, a review of the evidence. 143. Preventing reoffending. This section discusses the evidence on the effectiveness of interventions to prevent further offending. Deterrence of child sex offenders and preventing reoffending is an essential part of child protection. Having legislation that is compliant with international standards on human rights is an important first step in creating an enabling national context for responding to child sexual abuse and exploitation. WHO 2016a, WHO 2019a. Available evidence suggests that the certainty of being caught is a stronger deterrent to reoffending than the severity of a sentence, and sentences for offenders that are viewed as too tough can create reluctance to enforce. Ritchie 2016. The management of sex offenders requires law enforcement, monitoring their activities in the community, and attempts to change behavior, social norms and institutional / organizational practices. There are considerable gaps in the evidence. The discussion of the treatment of adult sex offenders draws entirely from research completed in Hicks, where most of the work has focused on the small proportion of offenders who are convicted and incarcerated, rather than the majority living in the community. No evaluations of programs to prevent reoffending by perpetrators of child sexual abuse or exploitation were found in LMICs, although there are primary prevention programs that address gender-based violence. See Section 5. Apart from studies that include treatment of perpetrators who access or produce online XAM, no evaluations of interventions specifically to prevent further child sexual exploitation offending were found, and this seems to be a gap in the research. Drummond and Southgate, 2018. Evaluated treatment programs for children and adolescents with harmful sexual behaviors are similarly limited in number and originate primarily from HICs. Multi-sector coordination. HICs such as the United Kingdom and United States have put substantial resources into the surveillance and monitoring of sex offenders in the community, grading the level of resource to the level of offender risk assessment. The purpose of community-based monitoring and risk management, usually performed by probation officers, and, in England, by multi-agency public protection panels, MAPPAs, is to protect the public and especially children from the offender living in the community, and also to reduce the level of perpetrator risk via behavior management, supported by delivery of a perpetrator treatment program. Researchers have explored the effectiveness of sex offender risk assessment and risk management methods. Andrews et al., 2006, Hansen and Morton Bargan, 2009. But concluded that it is not known whether the resources devoted to monitoring in the community have had an impact. 7. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 7. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 144. On improved public safety. A study for the Ministry of Justice in England found evidence that MAPPAs may have reduced reoffending rates, especially for offenders convicted for the most serious offences. MAPPAs may be associated with a 4 percentage point reduction in proven reoffending by new MAPPA-eligible offenders, and a 2 percentage point reduction in serious reoffending found from 2000 to 2010. Bryant, Peck and Luffbach, 2015. As with any multi-sector coordination approach, the success of working together is heavily reliant on the availability of resources to provide a holistic and coordinated response. Crime and justice. Sex offender registration and notification. Research on registration and notification schemes in the U.S. indicates these are ineffective for preventing reoffending. In the U.S., SORN policies include public notification so that members of a community are informed via the Internet, SMS and other alerts if sex offenders are released into the neighborhood, as previously discussed in Section 5. This public notification approach has been more frequently researched, but there are also offender registration schemes, for example in the UK and Australia, and in LMICs such as Argentina, Chile, Jamaica, that do not include automatic public notification. U.S. Dept of Justice, 2016. The non-public registration schemes exist largely to aid law enforcement in monitoring offenders and have a different impact on re-offending. Napier et al., 2018. In the U.S., Letonio and colleagues conducted 5 studies looking at whether sex Offender Registration and Notification Schemes, SORN, in South Carolina helped reduce reoffending. 3 looked at the impact on children with harmful sexual behaviors and young adult offenders, aged 18 to 21 years, referred to as youth, and 2 studies looked at the impact on adult offenders, Letonio and Armstrong, 2006, Letonio et al., 2010a, Letonio et al., 2010b, Letonio et al., 2013. Levinson et al., 2012. Findings differed for adults and youth. Follow-up over a mean 8.4-year period of 19,060 youth in South Carolina who committed sexual offenses found SORN had no impact on recidivism, Letonio et al., 2010b. 1. Study found that adolescents who were registered were more likely to commit other non-person offenses than were those not registered, Letonio and Armstrong, 2008. There are concerns that young people may also be subject to registration schemes when involved in consensual sexting with another adolescent, Dodge and Spencer, 2018, Napier et al., 2018. For adults, a significant deterrent effective SORN policies was found for first-time adult sex offenders. In 1995, the year that Internet notifications were introduced. Letonio et al., 2010a. Other studies with adult sex offenders have found no impact on reoffending, Zgaba, Jennings and Salamo, 2018, and SORN policies may have been counterproductive, Sandler et al., 2008. Bornakid, 2010, highlights the collateral damage of U.S. policies in terms of vigilante behavior in the community and the severe restrictions imposed on where an offender can live, making the possibility of an offender finding employment and leading a good life more remote. Tewksbury, Jennings and Zgaba, 2012, analyzed reoffending for 2 matched groups of sex offenders before SORN, 1990 to 1994, N equals 247, and after. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 7. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 145. SORN, 1996 to 2000, N equals 248, in New Jersey. They found SORN policies had no impact on reoffending. 3/4 of sex offenders were assessed as a low risk of recidivism, and high-risk offenders were most likely to reoffend and do so soon after release from prison. SORN was unrelated to reoffending risk. These findings were confirmed by a longer-term follow-up study in New Jersey where reoffending rates were analyzed for an average of 15 years after release from prison. Zgaba, Jennings and Salamo, 2018. A review of registration and notification schemes in Australia and other HICs also noted that recidivism rates for sex offenders are lower than for other crimes, between 10 to 14% reoffend. Napier et al., 2018, so targeting the community monitoring better to offender risks may be more effective than public notification. Napier et al. Concluded that non-public registrations are effective for police and other agencies monitoring offenders in the community, as most sex Offenders are already known to the victim. Public notification is unlikely to improve public safety. Napier et al., 2018. Online restrictions for sex offenders. Management of sex offenders in the criminal justice system and community often includes restrictions on use of the Internet. Chan, McNeil and Bunda, 2016. Research on the impact of these restrictions on reoffending was not identified, suggesting this may be a gap in the research. Adult sex offender treatment. Treatment programs can be the responsibility of the justice system, of health and mental health services, an NGO or a range of services working together. To simplify the discussion, all treatment of sexual offenders will be covered in this section on the justice system response. It should be noted that the distinctions between medicalized responses and justice system responses across different jurisdictions may influence outcomes and implementation. It has not been possible to consider these issues in this study. There has been fairly extensive but inconclusive research into adult sex offender treatment programs. Research on effectiveness exists in many jurisdictions including the USA, Canada, UK, Australia, New Zealand, Sweden, Holland and Germany. The most commonly employed treatments include cognitive behavioral therapy, CBT, designed to change the attitudes and distorted cognitions that underpin sex offending behavior, as well as to teach sex offenders to manage their behavior. Hansen et al., 2009. Some programs, especially in prisons, have combined CBT and pharmacological treatment. However, a systematic review of these programs found the research on pharmacological treatments to be limited, with no RCTs and no recent studies of drugs currently in use in prisons. Khan et al., 2015. This is an area identified as needing further research. Other approaches draw on the Good Lives model, which takes into account motivations to sexually harm children, recognizing these in therapy and behavior management, and encouraging pro-social behavior using a range of strengths-based therapeutic methods. Ward and Brown, 2004. Most adult offender treatment programs have focused on convicted sex offenders and men in prison, although community-based treatment programs also exist. Contents: Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References: Section 7. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 146. Although some positive findings have emerged from meta-analyses and systematic reviews on sex offender treatment, they are limited. Hansen et al., 2009, and the research quality is still regarded as being too poor to support any conclusion on effectiveness. Gronrod and Grondel, 2015. Programs that are specific to offenders' needs and learning styles are more effective at sustaining motivation among offenders. Hansen et al., 2009. While one review of psychological treatments for sex offenders that included experimental RCT and cohort studies concluded that treated sex offenders had lower recidivism rates than non-treated sex offenders. Walton and Cho, 2015. Most reviews of sex offender treatment programs have found only limited evidence for reduced recidivism. Dennis et al. 2012, Langstrom et al. 2013. 1 meta-analysis specifically focused on psychological treatment of adults convicted only of sexual offenses against children. Found 14 studies, only 9 were rated as good to weak on scientific quality, but no evidence was found for any treatment effect on recidivism. Gronrod and Grondel, 2015. In the UK, an extensive study of the impact of the CBT prison-based sex offender program compared outcomes over an average period of 8 years with a matched group of offenders who did not receive the program. It was found that men who had been on the treatment program were more likely to re-offend than men in the matched comparison group. MIP, 2019, Muse et al., 2017. The sex offender program was subsequently withdrawn and redesigned. Little evidence has been found on the effectiveness of treatment for female sexual offenders. Gannon and Alain, 2013. There is some evidence that community-based treatment programs for adult sex offenders may produce better outcomes for reducing re-offending when compared with usual supervision provided by probation services. Lambie and Stewart, 2012. Restorative justice for adult offenders. Restorative justice approaches aim to involve the victim/survivor, offender, and community in acknowledging and confronting the harm caused by sex offending, the offender making reparations to the victim/survivor and the community, the offender changing his behavior with the support of members of the community, and then moving towards a position of re-acceptance and reintegration. Restorative justice, RJ, models are regarded as more suitable for minority communities and young offenders than conventional law enforcement approaches, which can be experienced as discriminatory. Braithwaite, 1989. Restorative justice approaches aim to divert offenders away from the penal system as well as involve members of the community in managing offender behavior and reintegrating them safely into the community. Evidence from research on restorative justice for general criminal behavior indicates that offenders, especially young offenders, benefit most, but victims and survivors are not always adequately supported in feeling safe. Braithwaite and Daly, 1994, Daly, 2006. Not all schemes seem to directly focus on support and recovery for victims. One review found that while 60% of the restorative justice programs evaluated had a clear victim/survivor focus, 40% focused primarily on perpetrators of child sexual abuse and reducing re-offending. Bolitho and Freeman, 2016. The experiences of adult victims of sexual violence of RJ schemes. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 7. Ending Child Sexual Abuse and Exploitation, a review of the evidence 147. In the USA seems to vary with the closeness of the prior relationship with the offender. Koss, 2014. As yet, findings focusing on safer outcomes for child and adolescent victims are limited. Wilson et al. 2010, although 2 studies from Australia were found, discussed below, Daly, 2013, 2006. An example of a restorative justice approach applied to sex offenders and victims is the Circles of Support and Accountability, CSAE, program, which has operated in the US, UK and Canada. The approach developed in Canada in the 1990s within the Mennonite faith community, as a response to concerns about public panic over sexual offenders, Wilson et al. 2010. It involves volunteers providing community support and practical help to high-risk sexual offenders released into the community to reduce their social isolation and rate of recidivism. A systematic review of research literature on circles of support found 19 publications, of which 6 empirically studied the impact of the CSAE approach, Wilson, Bates and Volm, 2010. 4 were from Canada, Cicerone, 2001, Wilson et al., 2007a, 2007b, 2009, and 2 from the UK, Bates et al., 2007, Hazelwood et al., 2008. The findings from the studies are described as encouraging, but the authors conclude that further high-quality research is needed. A second review for the Australian Royal Commission into Institutional Responses to Child Sexual Abuse concluded that there is strong evidence for the effectiveness of CSAE, Bolitho and Freeman, 2016. The CSAE studies to date have drawn results from small samples of offenders. The first Canadian evaluation study by Wilson, Piszczeka and Prinzo in 2005, published 2007, compared 60 matched high-risk sexual offenders in an CSAE group with 60 offenders not in a group and living in the community. Following up over an average period of 4.5 years, it was found that men in the CSAE group had significantly lower sexual, violent and general crime reconviction rates than men in the comparison group. The sexual crime reconviction rates for the CSAE men was half that of the men in the comparison group, 8.5% for CSAE men, 16.7% comparison group. P equals 0.01. The study does not describe the eligibility criteria for the CSAE group, so bias in motivation towards change among the CSAE men may have influenced the findings. Subsequent research by Wilson, Cortoni and McQuinney, 2009, replicated the findings from the earlier research, showing lower rates of reconviction when comparing 44 men on CSAE programs with 44 offenders in the community who were not in a CSAE group. This study matched the groups for risk assessment, time in the community, location and prior treatment history. Average sex offense reconviction rates for CSAE men was 2.3%, for the comparison group it was 13.7%. In common with the study described above, this study also does not describe the eligibility criteria for the CSAE group, so motivation bias cannot be ruled out. In Minnesota, Duet, 2013, set up an RCT comparing outcomes on release from prison for 31 sex offenders on a CSAE group with 31 sex offenders not in a group. Offenders willing to take part in a CSAE group were randomly assigned to either the CSAE group or not. This random assignment only of willing offenders aimed to address the motivation bias in earlier studies. Recidivism was measured on 5 assessments including reconviction rates. 6 to 5 per. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 7 Ending Child Sexual Abuse and Exploitation, a review of the evidence 148. % of offenders in the comparator group were rearrested, compared with 39% in the CSAE group. Those in the CSAE group had significantly lower scores on 3 of the 5 measures compared with those in the comparator group. Reoffending rates for sexual offenses were however low, with only 1 arrest in the comparator group for a sexual offense and none in the CSAE group. Responses to children and adolescents with harmful sexual behaviors. Diversion policies, diversion of young offenders from conventional punishments such as custodial sentences, has been a policy option in HICs since at least the 1960s. Campbell and Leroux, 2002. It is now recognized that risks of reoffending are different for adults and children who have committed sexual offenses. Children who have committed sexual offenses have a low rate of sexual reoffending and, as with other offending behavior, rates of law breaking for the majority decline with age. Hackett, 2014, Moffitt et al., 2002. States which have ratified the United Nations Convention on the Rights of the Child 1989 are obliged to ensure that children in conflict with the law benefit from diversion and the use of alternatives to custody to the greatest extent possible. CRC, Articles 37, b. 40.1, 40.3, b. 40.4. Diversion typically has been applied to the treatment and response to first-time non-serious offending, although it is policy for a wide range of sexually harmful behaviors in some countries. In Australia, for example, a distinction is made in law between children with problem sexual behavior, PSB, who are aged under 10 years and below the age of criminal responsibility, and children with harmful sexual behavior, HSB, aged 11 to 17 years who could be liable for sex offending convictions. When dealing with children who show HSB, the emphasis is on diversion, rehabilitation and restoration with criminal sanctions as a last resort. Diversion options include giving warnings, formal or informal cautions, youth justice conferences and threatment orders. Blackley and Bartels, 2018. In Victoria, Australia, therapeutic treatment orders divert children and young people who sexually harm others onto community-based treatments. Pratt, 2013. The therapeutic treatment programs are trauma-informed, developmentally appropriate and involve parents/caregivers. Evaluation research on these programs is however limited and reoffending data is not provided. Diversion programs for children and adolescents accused of committing sexual offenses have existed in South Africa since 2008, often with a restorative justice focus. A review of literature and evaluation of the programs in the Western Cape area found research on the impact of diversion on reoffending is mixed. Sauls, 2016, 2018. Implementation of the programs vary and A more holistic focus on diversion and aftercare for young offenders is needed. By itself, diversion out of the court system is unlikely to have an impact on young people's harmful behaviors without follow-up remedial support programs. Examples of a remedial program linked to diversion is the South African Young Sex Offenders Program, SASTOP, implemented at the Stepping Stones Project in Eastern Cape Province and by the Provincial Department of Social Development in Western Cape. An evaluation of SASTOP in 2002 suggested that it Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 7. Ending Child Sexual Abuse and Exploitation, a review of the evidence 149. Had developed an intervention useful for holding children who have committed sexual offenses accountable and providing them with an opportunity to reflect on their abusive behavior. The sessions appeared to be fairly successful in accomplishing their individual aims and objectives. In particular, the children assessed seemed to have developed insight into their victims' feelings and realized the importance of responsible decision-making. Group work seemed to be a necessary and beneficial aspect, UNICEF, 2005b. Another example of a program aiming to provide holistic therapeutic support to children and young people with harmful sexual behavior is the South African Teddy Bear Clinics Support Program for Abuse Reactive Children, SPARK. A multi-method evaluation collected data on outcomes and recidivism for young people after SPARK, but the quantitative data on reoffending was limited. Qualitative feedback suggested that the young people who attended the program had low rates of reoffending. Rangasani, Stewart and Maharaj. 2013. No other studies of effectiveness of diversion policies have been identified. This highlights a particularly stark gap in post-abuse responses to young offenders, some of whom, as previously shown, page 51, have themselves been victims of sexual abuse. Treatment to prevent reoffending by young people with harmful sexual behavior. Findings are mixed regards the effectiveness of treatment programs for children and young people with sexually harmful behaviors. One strong finding from many studies is that treatment methods developed for adult offenders are not appropriate for young people. Hackett, 2014, Street. Armand et al., 2008. The International Association for the Treatment of Sexual Offenders developed guidance on the care of juveniles, sick, who have committed sexual offenses. Minor et al., 2006, recommending that they are understood in the context of their family and social environments, that assessment and treatment should be developmentally focused and strengths-based, that they are a diverse group who should be treated individually, that treatment should be broad-based and comprehensive, that sex offender registries and community notifications should not apply to juveniles, and that effective interventions result from research guided by specialized clinical experience and not from popular beliefs or unusual cases in the media. 2 meta-analyses considered how to reduce recidivism among young people who present with harmful sexual behavior and concluded treatment could be effective. Rietsil and Carbonell, 2006, Walker et al., 2004. Two other reviews concluded that the poor quality of the research prevents any firm conclusions being drawn. One study concluded too little is known about which risk factors might predict further sex offending among young people to inform this type of work. McCann and Lucia, 2008. Dopp et al. 2015. Note weaknesses in the research including failure to report dropout rates from treatment programs, lack of comparison groups and wide variations in measures and time periods for assessing recidivism. In Australia, Lang et al., 2014, analysed recidivism for children and adolescents aged 10 to 17 with sexually Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 7 Ending Child Sexual Abuse and Exploitation, a review of the evidence 150 harmful behaviors 5 years after taking part in a community-based treatment program, the New Street program. Outcomes were compared across 3 groups: completers, those who completed the community-based treatment, N equals 34, withdrawers, those who withdrew from treatment, N equals 16, control group, those who had no treatment, N equals 50. Children and adolescents in the treatment group and withdrawer group were matched with those in the control group on key risk factors such as age, at-index offense, type of offense, relationship with victim, whether in family or non-family care, etc. The treatment program was found to be effective for reducing recidivism for general offending and for personal violence, both measured as any further criminal charge or report. No significant difference was found between the completer and control groups regarding sexual reoffending. The withdrawal group, however, showed higher levels of sexual reoffending, suggesting that further research on young offenders who drop out of treatment would be helpful. Other therapies, research on other forms of therapy for children with harmful sexual behavior is more limited. An RCT in the USA prospectively looked 10 years later at further sex offending among children aged 5 to 12 years with sexual behavior problems who had CBT or play therapy, N equals 135, comparing outcomes for non-sexual offending children with other clinical behavior problems. N equals 156, Carpentier et al., 2006. The CBT group had a 2% sex offending rate at 10 years follow-up compared to 10% for the play therapy group, compared with a 3% sex offending rate among the control group. Multisystemic therapy for young sex offenders. Multisystemic therapy, MST, programs show more significant effects on recidivism in young people with sexually harmful behavior than programs based on adult offender treatments, although these approaches are less commonly used. Dopp et al., 2015. MST programs are based on socio-ecological theory and aim to address risk factors for the individual child, in the child's family and relationships and in the community. MST approaches are tailored to an individual child's needs, are developmentally appropriate and involve highly trained therapists working intensively with the child and family in the home, using strengths-based approaches that draw on CBT and family therapies. Parents and caregivers are seen as essential in enabling change, and there is emphasis on strengthening and mobilizing the parents' resources and skills. A review of 55 outcome studies for MSD found this approach to be more effective than diversion for improving parent and peer relationships and reducing behavior problems in young people. Hengeler and Schiefer, 2016. For children and adolescents with harmful sexual behaviors. A 9-year follow-up of outcomes for MSD from an RCT. Comparing MSD with treatment as usual found improvements in family and peer relationships, as well as reduced sexual and non-sexual recidivism for children and adolescents on the MSD program. Baldwin, Schiefer and Heiblum, 2009. An adaptation of MSD specifically for children with problematic sexual behavior. MSD-PSB was subject to an RCT in the UK but was unable to recruit a sufficiently large sample of young people to test the approach. Qualitative findings from the study suggest that parents and young people found the 8 strengths-based or asset-based approaches refer to a way of working to promote well-being by drawing on an individual's strengths, social and community networks. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 7. Ending Child Sexual Abuse and Exploitation, a review of the evidence 151. Program helpful and practitioners were also positive but unsure as to whether the program would suit all young people they worked with. Further research is needed on this approach. Finnergy et al., 2017. Restorative Justice for Children and Adolescents who commit / are accused of sexual offences. Australia and New Zealand are reported as being the only jurisdictions in the world that support restorative justice for children and adolescents who commit or are accused of sexual offences. Given the low conviction rates for sex offending, it is argued that this approach addresses cases that do not proceed through the legal system. Blackley and Bartels, 2018. Conferencing is a widely used restorative justice method that has been adopted specifically for sexual assaults. Bolitho and Freeman, 2016. It involves victims, offenders and their family and friends meeting after intensive preparation. A systematic review of 44 restorative justice programs for adults, children and adolescents who committed sexual offenses found future offending for children and adolescents was predicted more by the history of offending than by whether the young person had taken a restorative justice or a court route. Bolitho and Freeman, 2016. The evaluations by Daly in Australia included some young people aged under 18 at the time of the offence who were referred to harmful sexual behaviours programs where they also had contact with counsellors for a year. 400 case records were analysed to compare conferencing outcomes with outcomes for young people taking a court route, including those also getting support from a specialist program, the Mary Street program. The prevalence of reoffending was higher for the young people taking a court route, 66%, than for those conferenced, 48%. Participation in the Mary Street program was associated with a significantly lower prevalence of reoffending for the young people who had been to court, 50%. Preliminary findings suggested that a targeted program to support children and adolescents who present with harmful sexual behavior may have a greater impact on reducing reoffending than whether a case is finalized in court or by conference. Daly, 2006. 6 years later, Daly and colleagues, 2013, published an important study in South Australia which reviewed over a period of 6.5 years 365 cases of young people charged with sexual offences when under age 18. The offences ranged from indecent exposure to rape. Overall rates of general and sexual reoffending were assessed for cases finalized by 3 different methods: in court, N equals 226, 59%, by conference, N equals 118, 31%, and by formal caution, N equals 41, 10%, including cases with referral to a community HSB service. By the cut-off date, 54% of young people had been charged with new non-sexual offences but only 9% with new sexual offences. As in the earlier study by Daly, 2006, young people who had cases dealt with by the court had a higher rate of re-offending than young people who had cases dealt with via a conference. These differences were however largely explained by differences in prior offending. For the subgroup with no previous offending, a significantly slower rate of re-offending was observed for conference youth and for those who were referred to the community service. The researchers were able to control for the main effect of prior offending, but complex interactions between covariates such as offense types, early contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 7. Ending child sexual abuse and exploitation, a review of the evidence 152. Admissions to offending and legal and therapeutic responses could not be disentangled in the small sample, and they therefore could not explore factors linked specifically to sexual reoffending. Daly concluded that the main benefit of restorative justice for victims was that offenders admitted responsibility / guilt early on in the process, thereby reducing the likelihood of the harmful impact of a longer trial for conviction. Further, research with a larger sample is needed to test the finding. Education. Research on school responses to offending is mostly covered by the gender-based violence and whole school approaches to prevention previously discussed in Section 5. Responding to harmful sexual behavior in school requires teachers to be aware of responsibilities, actions that can be taken to support and protect young people and the continuum of behaviors from inappropriate to harmful. It cannot be said that those most vulnerable to sexual violence in schools have been protected and supported adequately. School exclusions. Managed moves of victims or victims and offenders dropping out of school have been too frequently reported. USCO, 2019, Women and Equalities Commission, 2016. Research on specific responses of schools to harmful sexual behavior is limited, but descriptive studies mapping school responses exist drawing upon contextual safeguarding approaches. Furman, 2019, Lloyd, 2019. Given the important Role schools can play in violence prevention and promising. Results from primary prevention evaluations in LMICs for gender-based violence and whole school responses, Section 5. This is an area of research that could be developed further. Community treatment for adult online offending. Treatment in the community is an appropriate option for online sexual offenders who receive non-custodial sentences and may be unable to access prison-based rehabilitation programs. The Inform Plus program, supported by the Lucy Faithfull Foundation, is a psychoeducational group program in the UK that targets men in the community who use online child sexual abuse / exploitation materials. An evaluation of outcomes for 92 men, mostly without prior convictions. 90% found post-program reductions in self-report. Measures for known risk factors associated with contact. Child sexual abuse, Gillespie et al., 2018. The study was a simple pre- and post-test self-report design with a smaller subset followed up for 8 to 12 weeks. The findings are limited by the lack of a comparison with men not on the program but are worthy of further investigation. Treatment for young people with harmful online behavior. No robust evaluations were found on treatment for online abusive behavior, although there are reports on early help programs for young people in the community who access abusive images in projects such as the Berlin Project for Primary Prevention of Child Sexual Abuse by Juveniles, PPJ. The PPJ targets young people aged 12 to 18 years through media campaigns, designed by young people who have been affected, to reduce the use of online child sexual abuse images. A report on the first 3 years of operation shows that parents and young people will directly access the service. For assessment and treatment, Bayer et al., 2016. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 7 Ending Child Sexual Abuse and Exploitation, a review of the evidence 153. Table 8. Summary of evidence on preventing reoffending. Preventing reoffending across different sectors. Quality of evidence. Hicks. Quality of evidence. Mix. Multi-sector coordinated risk assessment and management mechanisms, for example MAPA in UK. Analysis of case outcomes over 10 years found reduced reoffending for first-time and serious sex offenders involved in MAPA. Needs more research. Needs more research. Crime and justice. Prosecution and criminal penalties for adult offenders. Prudent. SORN policies, sex offender residency restrictions, registration and notification schemes. Public notification ineffective in preventing reoffending, measured by arrests, charges or convictions, but non-public registration may aid law enforcement. Ineffective / harmful. Review Question 4. What is known about effective approaches to prevent reoffending and ensure the recovery and reintegration of child and adolescent perpetrators of sexual abuse and exploitation, online and offline? Review Question 5. What is known about effective approaches to prevent reoffending by adult perpetrators of sexual abuse and exploitation, online and offline? Preventing sex offending behavior is crucial, but to date most efforts have been directed towards the minority of convicted offenders diverted to treatment programs or supervised on release into the community. Efforts need to broaden to evaluate and apply earlier responses and disruption strategies to reduce demand and deal with the drivers for child sexual abuse and exploitation among different types of potential perpetrators in the broader community. There are mixed messages from research on treating convicted adult sex offenders with many programs that exist, such as drug treatments, being poorly evaluated. Programs that give offenders positive goals, motivate them and can be tailored to offense type and learning style are thought to be more effective for engaging offenders in treatment, but evidence of impact on recidivism is poor. Treatment for children and adolescents with harmful sexual behaviors needs to be developmentally appropriate, tailored to individual needs and to involve parents and caregivers where suitable. Multi-systemic therapy has produced promising results compared with other CBT-based treatments. Further research is required on earlier responses for children and adolescents with harmful sexual behavior in school and educational settings, especially in LMICs where responses could be built into the whole school approaches to address gender-based violence which have developed. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 7 Ending Child Sexual Abuse and Exploitation, a review of the evidence 154. Preventing reoffending across different sectors. Quality of evidence. Hicks. Quality of evidence. Mix. Crime and justice. Continued. Diversion of children and adolescents who commit / are accused of sexual offenses from custody. Low evidence of impact on further harmful sexual behaviors, although other recidivist-related outcomes such as other reoffending promising. Needs holistic approach to remedial follow-up. E.G. Teddy Bear Clinic Spark Program South Africa. Prudent. Pharmacological treatment experimental studies are over 20 years old and do not consider current medications used. Needs more research. Adult sex offender treatment programs, for example Good Lives in UK and Australia. Evidence of impact on change is mixed. Programs that can motivate change and are tailored to offense type, motivations, and learning styles are thought to be more effective, but evidence of impact on reoffending is poor. Mixed. Adult sex offender treatment programs adapted for children / adolescents with harmful sexual behaviors. One older systematic review found the programs reduced recidivism compared with young offenders without the treatment. A more recent study found programs based on adult sex offender treatment were less effective than programs for young offenders that included parent / behavior management elements. Mixed. Multi-systemic therapy, MST, for children with HSB effective for behavioral problems, but small samples for HSB used in RCTs. Promising. Restorative justice and conferencing approaches, adult offenders, for example circles of support and accountability, COSA, UK, Canada, US and Australia. Samples in RCTs and evaluations are small. Needs more research. Needs more research. Restorative justice, RJ, and conferencing approaches for children and adolescents who commit are accused of sexual offences, for example, Australia community programs. No impact of RJ for children who commit sexual offences can be shown, from reoffending rates. The main benefit of RJ seems to be early admittance of guilt, so victim is spared the ordeal of a long trial. Needs more research. Needs more research. Education school responses to HSB findings from qualitative research that ineffective responses may result in victim dropping out of school. Findings from contextual safeguarding support whole school and community approaches. Needs more research. Needs more research. Community online adult offender rehabilitation in the community E.G. Inform Plus UK, evaluation studies are limited. Needs more research. Treatment in the community for non-adjudicated cases of online harmful sexual behavior by children or adolescent E.G. PPJ Berlin, Germany, evaluation studies are limited but show parents and children will access the service and undergo assessments. Needs more research. Table 8. Summary of evidence on preventing reoffending, continued. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 7. Ending child sexual abuse and exploitation, a review of the evidence 155. Supporting child and adolescent victims. This section focuses on recovery, overcoming the harmful consequences of child sexual abuse and exploitation, and reintegration of the victim back into a family and community. Responsibilities of states are set out in Article 39 of the CRC, which requires states to provide recovery and reintegration in an environment that fosters the health, self-respect and dignity of child victims of sexual exploitation and abuse. Much of the work in this area of victim support and recovery has been initiated by NGOs and survivor organizations or by the healthcare sector in HICs. Most of the research has looked at individual therapies for children following experiences of sexual abuse and exploitation, and this is reflected in the content of this section. However, a range of different types of help and support will be needed to help children and young people to cope with and overcome the harmful consequences of sexual abuse and exploitation. Systematic reviews of research, policy and practice have concluded that for adult and child victims /survivors of sex trafficking, aftercare services are required across a continuum of care needs on the road to recovery, from immediate protection and safety to recovery and then reintegration. Macy and Johns, 2011, see Figure 9 Model for Aftercare. Appendix to this section, Neria Muriah and Fry, 2016. It should be recognized that children have agency. The consequences of abuse will vary and not all will want or need the same type or intensity of support. The needs of children who have been sexually abused and those who have been sexually exploited are likely to differ, and the impact of cultural differences on somatic symptoms such as PTSD is an area of relevance to treatment. Blair et al., 2017. Sexually exploited and trafficked children and adolescents may have additional vulnerabilities requiring different types of practical, emotional, therapeutic and social support. They may need translators, be homeless, have drug and alcohol dependence, be single parents, have low self-esteem and poor employment options. Scott et al., 2019. They might also have uncertain legal immigration status or needs around being supported through criminal justice processes if separated from or unaccompanied by a parent. Addressing their immediate needs for survival and safety and providing practical and psychosocial support to help them to overcome these difficulties is important to prevent further victimization. When effective support is not available or inadequate, sexually exploited children may go missing from care, return to prostitution or be re-trafficked. ECPAT International 2011, Pierce, 2014, Sunasi, 2012. 8. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 8. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 156. Recovery and reintegration following sexual abuse and exploitation are particularly challenging areas of work in regions with low resources and where there has traditionally been poor recognition of these issues. It is important to focus on the immediate protective needs of victims. The longer-term processes of recovery and reintegration have had less attention. IRC/UNISF 2011, Blair et al., 2017, Cody, 2017. Addressing the wide spectrum of needs of sexually abused and exploited children and adolescents requires a comprehensive, multi-sector response, as these needs are unlikely to be met by one organization alone. Service planning for victim support and recovery, however, has not necessarily been demand-led. Evidence from a range of different sources show substantial gaps in the provision of recovery-focused services in the community for child and adult victims of sexual violence in HICs and LMICs. Allnutt et al. 2012b. Blair et al. 2017, Chowdhury et al. 2018, Wismyanti, 2019. Other challenges faced by recovery services relate to the impact of sexual violence on children and young people, where, as previously discussed in Section 4, for various reasons the experiences are not disclosed / made known. Although there may be harmful consequences on the child's or young person's health or behavior, young people who have been sexually abused and exploited may be reluctant to seek help, may experience discrimination when approaching services, and may not identify as victims or recognize the relationship with a perpetrator as abusive. In some areas, victims of sexual violence prefer to resolve the issue at home, with possible reasons stemming from the influence of traditional culture, honor, fear and stigma. Keysbury and Askew, 2010. Overcoming the barriers to access to services is an essential first step in developing an effective response, and this requires organizational and cultural change. Cody, 2017, Lynch, 2017. Researchers who have asked children and adolescents what they want have identified key components of services that are important to children who have been sexually abused and exploited. Cody, 2017, Harper and Scott, 2005. Specialist. Services should be flexible, confidential, comfortable for children and adolescents and delivered by staff who are proficient at forming relationships based on trust, and knowledgeable about the dynamics and impacts of sexual abuse and exploitation. The types of services most often accessed by sexually exploited children/adolescents are those that offer a range of services such as translation, legal advice, health, social care, outreach and drop-in access. Macy and Johns, 2011, Nerium Uriah and Fry, 2016, Pierce, Williams and Galvin, 2003. For sexually exploited children and young people, proactive methods of outreach have been recommended as an appropriate method to build safety and a trusting relationship. Jago and Pierce, 2008, Macy and Johns, 2011, Scott et al., 2019. Services for victims and survivors of child sexual abuse and exploitation must also work to support family members and carers. Pierce, 2014. Trowell et al., 2002. In economic settings, available research shows survivors value trauma-informed therapeutic support, phased approaches to reintegration, and an emphasis on vocational skills and empowerment approaches to aid the transition towards community reintegration. Cody, 2017. Cordisco, Vam Theory and Shanna, 2018. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 8. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 157. Multi-sector. Many of the services that have developed to address recovery and reintegration are closely linked with existing protective services. International commitments, the Inspire and Respect strategies, legal frameworks, and NAPs set out the commitment of states to provide recovery and reintegration services to children who have experienced sexual abuse and exploitation. Of course, as with other areas of response, national level commitment does not mean that meaningful action is being taken to meet these obligations for a whole host of reasons. Specialized services, more often NGO than government operated, most often deliver recovery provision and employ staff trained in responding to sexual violence. Clayton et al., 2013, reviewed multisector responses to child sexual exploitation and trafficking in the U.S. and found there is limited research on the impact of this work in HICs, although there are examples of good practice in multisector collaboration. One example is the Support to End Exploitation Now, SEEN, coalition in Suffolk County, Massachusetts, which involves multi-sector collaboration, a trauma-informed continuum of care, casework, management and training and guidance for professionals. Clayton et al., 2013. Moynihan, Pitcher and Suike. 2018, systematically reviewed global research on a wide range of interventions to foster healing among sexually exploited children and adolescents. Interventions included those in health and social care, intensive case management, psychoeducational therapy groups and residential programs. Of the 21 studies reviewed, 7 were based in LMICs. It was found that the quality of research varied considerably, few papers disaggregated findings separately for children from adult survivors, or for girls and boys. However, there is some evidence that, despite the diversity in programs included, most of the interventions had some positive impact on healing. It is clear that there are a variety of different multi-sector working arrangements being implemented in HICs and LMICs, but the research on which approaches are effective is rather limited. This is an area in need of further research. One-stop shop services, one-stop services that bring together forensic services, medical help and support with legal proceedings and counseling exist in some countries, and, as discussed in Section 4, are yielding encouraging evidence of positive outcomes for children and families. Protective functions cannot be completely separated from recovery responses in one-stop shops, shelters and other multifunctional services in LMICs. The provision of psychosocial care in some contexts can be limited, but there are emerging and positive findings on service user satisfaction. Jones et al. 2007, Keysbury et al. 2012, Mulambaya et al. 2018. Child-focused one-stop shops such as Barnahus provide more comprehensive therapeutic aftercare, and this is included under the 10 principles for multi-sector service provision within the guidelines for the children's rights-based model of Barnahus in the EU. Hal Dawson, 2018. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 8. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 158. Trauma-Informed Care, Trauma-Informed Approaches to Working, which recognize the impact that sexual abuse and exploitation may have on children and young people at different stages of development, are widely recognized as good practice and have spread in HICs where there have been concerns that contact with services can be unhelpful and re-victimizing experiences. Neria Muriah and Fry, 2016. Quaidara and Hunter, 2016, Scott et al., 2019. Trauma-informed approaches can be found in many services, including in one-stop shop and Barnahus models. Trauma-informed care approaches aim to create safety and trust in the relationship between the young person and the practitioner, to promote control, build resilience and empowerment, and prioritize self-empathy and self-care. Scott et al., 2019. It most often involves working also with family and other people in the child or young person's life, including teachers and peers. Trauma-informed care approaches are implemented at all levels of a service, from reception and administration through to specialist care. Knowledge about the impact of sexual abuse and exploitation is used across all levels of service delivery to prevent re-traumatization of victims /survivors. Toolkits and guidance for trauma-informed care exist, and a review for the Australian Royal Commission on Institutional Child Abuse identified the common principles as being having a sound understanding of the prevalence and nature of trauma arising from interpersonal violence and its impacts on other areas of life and people's functioning, Ensuring that organizational, operational and direct service provision practices and procedures promote, not undermine, the physical, psychological and emotional safety of consumers and survivors. Adopting service cultures and practices that empower consumers in their recovery by emphasizing autonomy, collaboration and strength-based approaches. Recognizing and being responsive to the lived, social and cultural contexts of consumers, for example, recognizing gender, race, culture and ethnicity, which shape their needs as well as recovery and healing pathways. Recognizing the relational nature of both trauma and healing, Quaidara and Hunter, 2016, pp. 5-6. Research on the effectiveness of trauma-informed approaches is rather limited, but the basic principles for working correspond with what victims/survivors say about their needs, as discussed above. For individual service users, including victims of sexual exploitation, some positive impacts have been found upon levels of trauma symptoms, substance misuse and mental health problems. Scott et al., 2019. At the system/organizational level, there are some positive findings from evaluations that training and other organizational policies increase professionals' knowledge about the impact of trauma on their clients and what this might mean in terms of their experience in services. Evidence of changes in professional and organizational behavior is slim, and evaluation methodologies have struggled to capture organizational changes as these can take time. Quaidara. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 8. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 159. And Hunter, 2016. Data monitoring for organizational changes would help to address this knowledge gap. Reintegration, follow-up and repatriation. Recovery from sexual abuse and exploitation is broader than an individual's journey to physical and emotional well-being. And, if returning to places of origin, includes acceptance and processes of reintegration into a community without stigma or shame. It also requires the original causes, such as fear of persecution, debt or lack of opportunities to have lessened if further migration is to be avoided. In the context of a humanitarian crisis and its aftermath, recovery includes enabling families and communities to care for and protect children themselves, including supporting them in livelihoods. IRC, 2011, 2012. There are some NGO projects and one-stop-shop services that aim to provide these more comprehensive services for the recovery and rehabilitation of sexually exploited children, and program evaluations, although limited, are indicating the value of these services. Cody, 2017, Scott and Skidmore 2006. Transit homes run by a number of ECPAT groups have been set up in high-risk areas in South Asia as temporary safe shelters for trafficked and sexually exploited children rescued from various establishments such as brothels. Recovery and reintegration services are provided, including counseling, medical checkups, non-formal education and the development of case management profiles. ECPAT in Latin. America provides similar services, for example, RACES in Chile and ECPAT Guatemala run centers / transit homes, and child victims are provided with individual treatment, crisis intervention, group and individual counseling, peer support, legal assistance, recreational activities such as drama, school support, sensitization activities and assistance in tracing family members. Therapeutic interventions generally form part of a holistic plan wherein therapy reinforces and is reinforced by other types of activity. Children trafficked across borders may be returned to families in their country of origin and sometimes face the original drivers of their migration. Trafficking shelters have been established to provide vocational training and support mechanisms for victims, such as that introduced under the Vietnamese government's Receiving and Reintegration Program, CSAE Command and British Embassy, 2011. After return or repatriation, ongoing reintegration support for the children is necessary, Cody, 2017. This includes psychosocial recovery, formal or non-formal education and economic empowerment. Follow-up visits and sensitive monitoring are especially important to help avoid children being re-trafficked. Studies examining the effectiveness of these types of services are very limited. The ones that do exist report mixed practice, making it difficult to identify promising practice in this area of response. 4 evaluations of UNICEF-supported programs for trafficked children were examined within a larger meta-synthesis of UNICEF evaluation reports, UNICEF 2012 c. The evaluator concluded that only 2 of these were effective in the provision of repatriation services, Rasmussen 2006, and psychosocial support, Tan and Baguio, 2007. A qualitative study of NGOs in Cambodia implementing the IOM's long-term recovery and reintegration Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 8 Ending Child Sexual Abuse and Exploitation, a review of the evidence 160 Assistance to Trafficked Women and Children Project examined the partner NGO provision of these services. Bureau of Population 2006. The service was designed to offer long-term accommodation and, to variable degrees depending on NGO resources, counseling, education and income generation support. The ultimate goal was repatriation via recognized procedures and plans designed to prepare children for reuniting with their families. Although the study was not able to assess whether the support received prevented future trafficking and sexual exploitation among the participants, it was able to assess satisfaction of the service user and document the ways in which the service helped support the building of protective factors such as educational and employment achievements. Findings were mixed, noting that girls who received the services felt they benefited in some ways, but the services were also criticized for being disorganized and support after reunification with families was limited and not well understood by the girls and their families. IBID, a case study of repatriation services in Thailand, noted that these services represented progress in providing short, medium and long-term support for trafficked women and girls. However, it also found shortcomings, limiting the service's effectiveness. Notably, this service was located in the country to which the girls had been trafficked, not their home country. Preparation. Activities for employment were often not matched to the availability of work in the girl's home country, and thus this aspect of the service was a failure. Gerseld, 2008. Findings from an ongoing 10-year longitudinal study of child and adult victims of sexual exploitation in Cambodia show that education to provide skills and qualifications for employment were seen by women and young people to be the most essential element of their recovery and reintegration. However, most of those who were in the process of reintegration with their families were returning to situations of poverty. Miles et al., 2013. Crime and justice. Criminal justice sanctions, arguably, could contribute to victim recovery by bringing closure or a sense of justice through responses made to offenders. Making courts child-friendly could prevent the secondary victimization of children in court processes. Sonner et al. 2013. The justice sector is responsible for providing justice for victims of sexual violence and other human rights violations, upholding accountability and supporting the long-term process of rebuilding communities. The right to justice for victims of violence and human rights violations has been extensively affirmed and developed in international law, from the International Covenant on Civil and Political Rights of 1969 to the United Nations Guidelines on Justice in Matters Involving Child Victims and Witnesses of Crime 2005, UN ECOSOC, 2005, UNODC, 2009. Even in times of armed conflict, the national courts of a state have the responsibility to prosecute sexual abuse and exploitation and provide justice for victims, although many face significant economic, educational and socio-cultural barriers in gaining access to justice. Bastic et al. 2010. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 8. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 161. No research was found to show the therapeutic benefit of prosecution of offenders for the recovery of child victims. While there has been considerable interest in victim redress and compensation schemes for adult survivors of childhood sexual abuse, Daly, 2014, Radford et al., 2017b. No research was found on the use nor impact of these schemes for child victims in HICs or LMICs. Health and mental health services are essential for victim support and recovery, providing services to assist recovery, responding adequately to the harm caused by those victimized in health or mental health settings, and ensuring that support is equitable so that services are relevant and accessible for different groups of children and young people. The health sector, however, makes little contribution towards longer-term psychosocial support in some LMICs, particularly in humanitarian, emergency and conflict/post-conflict settings. There are emerging examples of integrated and comprehensive care, as described in the previous section, but these are still not widespread. Exa, 2011, and are not often able to provide more than minimal and short-term counseling to victims of sexual abuse and exploitation. It could be argued, however, that they contribute in early stages to the recovery from trauma because recovery is not something that happens down the road but can begin immediately. Healthcare professionals can play an important role in providing a sensitive response that will aid recovery from trauma. General principles of good practice include avoiding inducing further trauma to a child or adolescent, good communication skills that can help engender trust and comfort, and providing a safe and healing environment. IRC 2011. Comprehensive and integrated approaches as described earlier also aim to address poor service responses that may have a negative effect on a child/adolescent's recovery. EXA 2011. How health professionals ask about sexual abuse and violence, and the availability of safe and confidential spaces for interviews and assessments, for example, may be very important in aiding recovery by rebuilding trust. While there have been evaluations done of healthcare reforms such as these, findings did not focus on recovery per se but on the overall functioning of the reforms. Therefore, there are no tested, effective or promising studies that can shed light on the recovery outcomes in these settings. Two areas where there has been evaluation and practice development regards recovery of victims/survivors are health-led outreach and advocacy services and therapeutic aftercare/recovery services. Outreach and advocacy programs, previously described in Section 6, are often linked with one-stop shop or shelter services and increasingly tend to draw on trauma-informed practice and case management methods. One example of an evaluated health-led outreach service for runaway and Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 8 Ending Child Sexual Abuse and Exploitation, a review of the evidence 162. Sexually abused/exploited young people is the runaway intervention program offered by a children's advocacy center in the U.S. The project combines a program of nurse visits to young people to build trust, complete assessments and develop and implement an individualized multi-sector care plan with case management. Young people are visited by the outreach nurse weekly in first 3 months, bi-weekly in months 4-6 and every 3 weeks in months 7 to 12. The outreach nurse provides health care and aims to reconnect young people to their families and services. Young people may also join empowerment groups also offered in CSAE. Analysis of data collected from 362 young people using standardized measures at baseline and at 3, 6 and 12 months after, found the nurse visits independently predicted a decline in young people's emotional distress, self-injury, suicidal ideation and suicide attempts. Empowerment groups predicted a decline in trauma symptoms and all other indicators of emotional distress apart from suicide attempts. Bounds et al., 2019. As no other services were offered to sexually abused and exploited runaway children and young people in the area. Where this project existed, an RCT was not practical nor ethically possible. Similar findings on the positive impact of outreach and advocacy have been found in the research on sexual exploitation in the UK, Bovanik, McNeish and Pierce, 2016, Scott et al., 2019. Therapeutic aftercare. Sexual violence can lead to a variety of behavioral and mental health problems including post-traumatic stress disorder, PTSD, depression, anxiety disorders, borderline personality disorder, etc. Post-traumatic stress disorder, PTSD, is a common adverse impact of sexual abuse in childhood. 1/3 to a half of all school-aged children who report experiences of sexual abuse also have clinical levels of PTSD, Colin Vazina, Danio and Herbert, 2013. There has been extensive research into therapeutic interventions for treatment and the outcomes on improving individual mental health, using a variety of measures. Definitions of the main therapies discussed in this section are included in the appendix to this section. What works for children and adolescents who have behavioral or mental health problems as a consequence of sexual abuse will depend upon the diagnosis, so not all survivors of sexual abuse will benefit from the same therapeutic intervention. Research indicates the importance of involving the client in treatment choices. Schlonkse, Albus and Patterson, 2017. Cognitive behavioral therapies with a trauma focus. The knowledge base currently identifies cognitive behavioral therapies, CBT, with a trauma focus, creative therapies, eye movement desensitization and processing, EMDR, and counseling as potential models of treatment for behavioral, emotional or mental health problems that may result from child sexual abuse. Allnock and Hines, 2012. Benuto and Donohue, 2015. Kim, No and Kim, 2016. Schlonkse, Albus and Patterson, 2017. Chowdhury, Satapathy and Sagar, 2016. Who, 2017. CBT approaches are endorsed by systematic reviews for the treatment of general childhood trauma, Dorsey et al., 2017, Trask, Walsh and De Lillo, 2011, Wethington, 2008, and those with a trauma. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 8. Ending Child Sexual Abuse and Exploitation, a review of the evidence 163. Focus work across several diagnoses including for PTSD, depression and anxiety. Trauma-focused CBT, TFCBT, which is a copyrighted therapeutic approach specifically developed for the treatment of children who have experienced sexual abuse, has provided the most robust evidence of impact through randomized controlled trials. RCTs, Cohen et al. 2004, 2005, 2006, 2007, Deblinger et al., 2011, Manarino et al., 2012, Sanchez-Meca et al., 2011, Wethington et al. 2008. It has, as a result, become a recommended treatment for adolescents by the U.S. Centers for Disease Control and the National Institute for Clinical Evidence in the United Kingdom, NICE, 2018. The WHO has endorsed CBT with a trauma focus as a treatment for sexually abused children and adolescents with PTSD, WHO, 2017. Sanchez Mecca, Rosa Alcázar and Lopez Sola, 2011, found from a systematic review that CBT with a trauma focus combined with supportive therapy and a psychodynamic element, for example play therapy, showed the best results, including a narrative element in TFCBT therapy with a trauma focus where the child is assisted by the therapist to produce an account of the sexual abuse, which is discussed with the non-abusing parent, has been found to be effective in reducing children's abuse-related fear and general anxiety as well as ameliorating parents' abuse-specific distress. Deblinger et al., 2011, Manarino et al., 2012. It is thought that while TFCBT may be effective for some adolescents, it is less appropriate for younger children. Trask, Walsh and DeLillo, 2011, and authors reviewing the treatment have urged caution in assuming universal application with children. TFCBT approaches have been evaluated in mix, although only a small number of experimental trials have been found focusing on treatment for trauma in general, or with small samples. One example is an RCT in Zambia that aimed to compare trauma symptoms in orphans and vulnerable children provided with TFCBT treatment, N equals 131, with outcomes for a comparison, waitlist / treatment as usual group, N equals 126. Due to the low resource setting, treatment was delivered by lay counselors recruited, trained and supervised by experienced professionals in the community. Statistically greater reductions in trauma symptoms and functional impairment were found for children in the TFCBT group than for those in the comparison group. There were reductions of 81.9% in trauma symptoms and 89.4% in functional impairment for the TFCBT group compared with reductions of 21.1% for trauma symptoms and 68.3% for functional impairment in the comparison group. Murray et al., 2015. This evaluation, however, had very few children involved who were assessed to have experienced sexual abuse. N equals 5. In the Democratic Republic of the Congo, DRC, Callahan et al., 2013, compared outcomes for 52 girls aged 12 to 17 years randomly assigned to TFCBT, N equals 24, or to a waitlist comparison group, N equals 28. Girls in the TFCBT group showed significantly greater reductions in trauma symptoms. The Multifamília program in Brazil also shows some positive results from combined play therapy and TFCBT, including improved communication for the child and family. Wirtz et al., 2016. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 8. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence. 164. Eye movement desensitization and reprocessing. EMDR has a strong evidence base for relieving distress caused by trauma, including sexual violence. Bisson et al., 2013, Kemtarb et al., 2002, Edmund et al. 1999, Louis et al., 2018, Schlansky, Albus and Patterson. 2017, although most of these studies have been adult-focused. EMDR is often used for treating PTSD and aims to help people recover from problems triggered by traumatic events by helping the brain to reprocess memories. In the UK it is recommended by NICE on the basis of an extensive evidence assessment for the treatment of children with PTSD who do not respond to TFCBT, NICE, 2018. The Systematic Review of PTSD Treatment for Children and Adolescents by Louis et al. 2018 concluded that TFCBT and EMDR are both effective for reducing trauma symptoms in children and adolescents. But TFCBT is marginally more effective. Children at subclinical levels of post-traumatic stress show more improvements. The type of trauma, whether child sexual abuse, physical violence, motor car accident or firework disaster, had no impact on the treatment effectiveness. Little research has been published on the effectiveness of EMDR in low-income contexts, and challenges exist for delivering this service where mental health professionals are few. Kazlauskas, 2017, notes that other modes of delivery could be more appropriate, such as online therapy and the involvement of non-professional volunteers. Other therapies, 3 reviews of a diverse range of psychotherapies including CBT with a trauma focus, play therapy, group and individual psychological therapies, found that most treatments had positive effects for trauma symptom reduction, although CBT with a trauma focus shows the greatest effect on trauma symptoms. Harvey and Taylor, 2010, Kim, No and Kim, 2016, Trask, Walsh and DeLillo, 2011. However, in one of the reviews, the meta-analysis found that moderators of treatment varied with symptoms, indicating the need for treatment to be individually tailored to a child's treatment needs. Harvey and Taylor, 2010. This study had broad inclusion criteria and, as well as experimental and quasi-experimental studies, included repeat measure, before and after, design studies. Trask, Walsh and DeLillo, 2011, found that longer treatment was associated with greater treatment gains regards PTSD symptoms, externalizing and internalizing behaviors, and that there were no differences in the effectiveness of group and individual therapies. Parker and Turner, 2013, 2014, sought to determine the effectiveness of psychoanalytic / psychodynamic psychotherapy for children and adolescents who had been sexually abused. No experimental or quasi-experimental studies were identified that met the stricter inclusion criteria, and the authors argue that this is a substantial gap in our knowledge. Other therapies such as psychoanalytic / psychodynamic psychotherapy, play or drama-based therapies, narrative therapies, have been less rigorously evaluated, so whether they are effective or not is not known. Parker and Turner, 2013, 2014. A review by Benuto and O'Donoghue, 2015, concluded that eclectic or play therapy may be best for social functioning problems, however precisely what intervention strategies contribute to improved outcomes for what. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 8 Ending Child Sexual Abuse and Exploitation, a review of the evidence 165. Presenting problems, for example, behavioral problems, anxiety, and so on, remains unclear. Creative therapies such as play, dance or music therapy can offer children an alternative to or an additional therapy to aid healing and restoration, and there are examples of this approach being used in LMICs such as Cambodia, Schrader and Wendland, 2012, in poor regions of South Africa, Van Westerhunen et al., 2019, and the Philippines, Brilliance Evangelista, 2013. A meta-analysis of play therapy in HICs with children, which did not analyze treatment use for children affected by child sexual abuse separately, found positive impact across modalities, settings, age, and gender, with the most significant impact seen with humanistic, non-directive play therapy approaches, Bratton et al., 2005. Few robust studies, however, have been undertaken on the use of play and other creative therapies, specifically with sexually abused or exploited children and adolescents. Therefore, more research is needed to understand the impact with this group. In a quasi-experimental evaluation in a children's advocacy center in the U.S., Dietz, Davis and Pennings, 2012, investigated the effectiveness of treatment for sexually abused children with trauma symptoms, comparing outcomes for children who received group therapy only, N equals 32, with those who received group therapy and animal therapy, N equals 60, and those who received group, animal and narrative /story therapies, N equals 61. Children in the groups that received the animal therapy, which involved contact with therapy dogs during group sessions, showed significantly greater decreases in trauma symptoms than children in the group without animal-assisted therapy. Children in the group with therapeutic stories as well as animal therapy showed significantly more change in trauma scores than the other groups. The authors urge further research into the benefits of animal-assisted therapies, mentalization-based treatment, MBT, and adolescent mentalization-based integrative treatment. Ambit mentalization involves the ability to make sense of one's own and others' states of mind, desires, intentions, thoughts, feeling and behaviors. MBT aims to address mentalization failures common in people with borderline personality disorders. MBT is also increasingly used with children and adolescents who self-harm. Adolescent mentalization-based integrative treatment, Ambit, and with parents who have drug or alcohol problems. MBT and Ambit places great emphasis on the relationship between the professional and the client, so is used for adults and adolescents who may be hard to reach, such as sexually exploited adolescents, or who do not engage with psychological mental health therapies. Bevington et al. 2013, Griffiths et al. 2017, Scott et al. 2019. A systematic review of MBT by Malda, Castillo, Brown and Perez Algorta, 2019, found 23 studies of effectiveness, 7 specifically on ambit approaches, and concluded that this showed some positive results worthy of further research. Modular approaches. These approaches recognize the limitations of single problem or single intervention. Focused evaluation studies, considering variations in Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 8. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 166. Problem type, such as the type and duration of abuse or maltreatment and overlapping impacts, and context, often considering moderating factors such as age, gender, ethnicity and so on, and aim to identify common elements found in evidence-based, gold standard practice, CPTA, and Dalyden, 2009. Bentovim and Elliott, 2014, apply a common factor framework that asserts that the personal and interpersonal components of an intervention, such as alliance, client motivation, therapist relationships and so on, influence treatment outcomes to a significant extent regardless of specific treatment intervention type. Common practice elements were identified for work with sexually abused children, non-abusive caregivers, and young people with sexually harmful behavior, and working with practitioners. A modular practice manual was developed into the Hope for Children and Families approach, which can be used to individually tailor therapy to a child's needs. Education. Teachers see children every day and are a potential source of support and help for sexually abused children and young people. This review, however, identified no recent research on the education sector with respect to victim support, recovery and reintegration. This is a stark gap in the research literature, as in HIC's schools may have counseling services available for children, but the emphasis in most research into schools and safeguarding is on prevention, disclosure and referral to child protection, with little said about supporting child victims in schools thereafter. Education is a vital component of the multi-sector reintegration process for children and adolescents in OMICs and HICs, Miles et al., 2013, and there is a crucial gap in the literature regarding the role of education in this area of work. The UK government guidance for safeguarding children in schools was updated in 2017 to address the sexual abuse and harassment of children by peers in schools. This gives helpful guidance on practical steps that schools can take to implement contextual safeguarding, Firmin, 2019, and support victims as well as address the needs of peer perpetrators in schools, DFE, 2018b. Social welfare and child protection. Child protection agencies may directly offer recovery services to child and adolescent victims of sexual abuse and exploitation, or refer them on to other agencies able to provide these services. Responses should be determined by the victim's level of risk and by what agencies and services can offer. Best practice suggests that the gold standard of support is delivered through multi-agency teams that are co-located, offering direct support to victims. Benedos, 2012. Capacity, resources and good Multi-agency working arrangements are not always available, however, even in relatively high-resource areas. A study of therapeutic services for children and young people in the United Kingdom found significant gaps. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 8 Ending Child Sexual Abuse and Exploitation, a review of the evidence 167. Locally and nationally between the availability of resources, levels of demand and estimated need, Allnukit AL 2009. 2012b. While providing services to aid the recovery of child victims of violence is one of the 7 recommended strategies of INSPIRE, the INSPIRE framework states that basic health needs such as emergency medical care and clinical care for victims of sexual violence must be in place before specialized provision of counseling and social services are contemplated. WHO, 2016a. Child protection sector responses to recovery in LMICs are generally weaker. Few children receive formal services, Sumner et al. 2015, and local grassroots organizations tend to be the main providers, Mildred and Plummer, 2009. Efforts to improve the social welfare response to service provision in LMICs have been in evidence, for example, to expand, improve and coordinate services for victims such as counseling, shelters, victim advocacy, hotlines, women's support groups, children's services and legal aid, Bot. Morrison and Ellsberg, 2005. Much of this work has relied on attention to better coordination between agencies, NGOs and other community organizations. Community shelters were mentioned above in Section 6 as services for protection from sexual violence, but they often provide more than this. Shelters provide women and children with a place to recover from their experiences, rebuild self-esteem and take steps to regain a self-determined and independent life. Blair et al., 2017. Historically, of course, these developed to respond to domestic violence against women, although sexual violence is usually part and parcel of this. Shelters continue to focus on protecting and empowering women who have experienced intimate, partner and gender-based violence. Although shelters vary in structure depending on funding and resources, recovery and reintegration services typically offered include counseling and therapeutic support, financial and economic assistance, legal assistance and long-term housing. Blair et al., 2017, Gurman et al. 2013. Most of the evaluations and research studies on shelters derive from Europe and North America, Sullivan et al., 2008. And the evidence base remains limited due to deficits in research and rigorous evaluations. Services such as these are difficult to evaluate because of the multiple components that contribute. Understanding the individual impacts of, for example, counseling services is not easy, given the other multiple services also being provided. However, some evaluations in HICs have found improved outcomes for women's resilience, self-esteem and coping through individual counseling interventions. Bennett et al., 2004, Tutty et al., 2006. It is likely that shelters raise Different issues for the recovery of adult and child victims. As adults are less likely to remain in these institutions for long periods of time and less likely as a result to suffer the disadvantages associated with institutional accommodation, where young people have lived in conditions of poverty. Shelter accommodation may provide a better standard of living than would be possible in the community, stressing further the need for empowerment, education and building alternative livelihoods for young. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 8 Ending Child Sexual Abuse and Exploitation, a review of the evidence 168. People After Shelter Life, Cordisco et al., 2018. Alternative accommodation with safe carers is the recommended first option for children, supported by case management and multi-sector coordination through outreach, advocacy or social worker support. Inspire, 2016. Therapy by Community Lay Workers, TFCBT. Delivered by specially trained and supervised lay workers in the community, discussed earlier in this section. Produced positive changes in trauma symptoms of adolescent girls in Zambia, Murray et al., 2015. Child, parents and relationships. Support for parents, as previously discussed. Parental support is the strongest predictor determining good outcomes for sexually abused young children. Ramkandani and Jones, 2003, Who, 2016a. The non-abusive parents and families' response to child disclosure or discovery of sexual abuse and exploitation has been found to have an important impact on child recovery and well-being. Melville et al., 2014. Indeed, in therapeutic provision, a safe carer model has been increasingly adopted. Scott et al., 2019. Safe carers may undertake joint counseling or therapeutic play with the child, but they also receive support and learn about the dynamics and impacts of sexual abuse so that they can better support their children at home. Hill, 2005. When considering reintegration of children who have been trafficked for sexual purposes, good practice recommends consideration of the environment into which the child is being reintegrated. TDH, 2009. Although not all children will be able to return to the family home, for those that can, family support interventions are critical to ensure that parents or carers are able to cope and welcome back and support the child through recovery. It is important for non-abusing parents and carers to be offered counseling and access to ongoing support. The Coalition for the Removal of Pimping, CROP, is an organization based in the United Kingdom that supports and works with families whose children are or have been involved in sexual exploitation, and enables them to effectively support the child. CROP's Parent Support Unit offers a unique service that includes providing confidential and non-judgmental advice on a one-to-one basis and acting as a mediator between the child and caregiver. Such approaches are sustainable and keep the child in the family home. In cases where a child is integrated into a new setting, similar work with foster parents or carers will be important. Home visits to support parents are resource intensive and may not be practical in low-resource settings. On the basis of a review of evidence and guidance on healthcare responses to violence against children in Latin America and the Caribbean, Wirtz et al., 2016, suggest that training and using paraprofessionals to deliver evidence-based programs to support abused children and caregivers in the home would be more feasible. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 8 Ending Child Sexual Abuse and Exploitation, a review of the evidence 169. Child and Adolescent Participation, Child/Adolescent participation in programs is seen as a contributor to their recovery and rehabilitation, Heisler, 2001. An international desk-based review about the involvement of children and young people in participatory research found that the act of self-representation may offer therapeutic benefits to those involved, Bovanik et al., 2018. There are numerous examples of the ways in which children who have experienced sexual abuse and exploitation have become involved in service design and delivery, Frederick, 2010. An example is a project developed by ECPAT International and supported by other NGOs locally, the Youth Partnership Project, YPP, for child victims of sexual exploitation and children from vulnerable communities. It is designed to empower and build the capacity of children and young people by involving them in the fight against sexual exploitation. Children and adolescents are given training and support in, for example, media advocacy and peer support, to develop the knowledge and skills to help themselves and their peers to create positive changes in their lives, ECPAT, 2005. YPP encourages young people's participation in social activism to raise public awareness and to demand better protection of their rights from decision makers. Crispin, 2009. This project has been replicated across Africa, East and South Asia, Latin America and Eastern Europe. The authors have so far been unable to identify any formal evaluations of this project or any of its sections, although the project provides some monitoring statistics and reports on activities. Guidelines for peer supporters have also been developed and made accessible online. Crispin et al., 2008. Humanitarian sector. In humanitarian and conflict settings, field experience has shown that staff are implementing basic psychosocial interventions for children who have experienced sexual abuse, including supportive counseling during the case management process. However, many field staff are not trained mental health experts and have limited knowledge and skills to assess and respond to children who have experienced trauma. Supervision is often needed to reduce secondary trauma to professionals working with these children, but is limited in these settings. IRC/UNICEF, 2011. As a response to this, guidelines have now been developed in caring for children who have been abused. IRC/UNICEF, 2012. Policy and guideline development such as the Inter-Agency Standing Committee Guidelines, IASC, 2005, which recommend comprehensive care for women and girls affected by sexual violence, also seem to have had some influence. A number of examples of comprehensive care for war-affected women and girls exist, providing medical services, reproductive health care, psychosocial counseling and referral and advocacy. The Compass program previously discussed in Section 6 includes support for the recovery of children, adolescents and their families, offering child victims /survivors psychological support, empowerment and skills-based programs. Compass shows some positive results, but the impact on recovery is not shown in the research so far. Falb, 2016. Stark, 2018, IRC, 2017. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 8. Ending Child Sexual Abuse and Exploitation, a review of the evidence 170. Review Question 7. What is known about effective approaches to support, ensure the recovery, reunification and reintegration of child and adolescent victims of sexual abuse and exploitation? There is still a need to develop broader research and evaluation on programs that aim to improve children's and young people's recovery from different experiences of child sexual abuse and exploitation across the continuum of care needs. A common approach in LMICs for child sexual exploitation is for NGOs to rescue children, provide shelter accommodation with varied services for assessment, recovery and reintegration. A challenge for this approach, also observed in HICs, is that sexually exploited and trafficked children may be resistant to being rescued, and institutional care does not guarantee safety. Qualitative and context-relevant research directly involving young survivors has provided important insights that can be used to develop more effective responses. Services that are trauma-informed, take empowerment approaches, involve young people in decisions that affect their well-being, are strengths-based, involve family or safe carers and able to provide vocational skills and education, are likely to be more effective and are showing some positive results. As recovery can begin from the first point of contact with services, health and other related professionals should be trained in responding sensitively to children and adolescents. Greater attention should be focused on building capacity and providing humanitarian staff in LMICs with training and guidance on responding to the individual and developmentally different needs of sexually abused and exploited children and adolescents. Children and adolescents who have been sexually abused and exploited require individually tailored, comprehensive services providing a package of multisectoral support to cater for basic needs for food, shelter, safety, medical care to emotional, practical and social support that will enable recovery and reintegration into communities. Improved multi-sector cooperation and good case management is needed to bring together responses in health, law, child protection, education and employment especially. This is especially the case for vulnerable children and adolescents leaving residential services. More attention needs to be given to the safety and risks of further harm to young people, from adults and peers, in different organizations, including residential services. Recommendations for standards and findings from research from recent national inquiries in Australia and the UK have wider relevance. School staff, especially teachers who see children daily, have an important part to play in child protection and supporting the recovery of child and adolescent victims of sexual abuse and exploitation. There is a gap in knowledge about the role of teachers in supporting children's recovery. Effective programs. A series of systematic reviews reaffirm that for treatment of trauma associated with child sexual abuse, the best evidence on recovery responses is for trauma-focused cognitive behavioral therapy in HICs. This approach has also been tested in economic contexts such as Zambia with implementation adaptations such as apprenticeship models and task splitting to address the professional capacity challenges. TFCBT has been found to have moderate effects on reducing post-traumatic stress disorder, PTSD, and anxiety symptoms in sexually abused children, and these outcomes are sustained over the medium term. EMDR also has good evidence of impact if delivered in sessions of 50-60 minutes and over 10 to 20 weeks. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 8 Ending Child Sexual Abuse and Exploitation, a review of the evidence 171. Table 9. Summary of evidence on victim support and recovery. Victim support and recovery across different sectors. Quality of evidence. HICS. Quality of evidence. Mix. Multi-sector one-stop shop models can include counseling and comprehensive psychosocial support and tested therapies, for example, sexual assault referral centers, SARCs, children's advocacy centers, Children's House, Barnahus, and Thuzula Care Centers. Barnahus have service standards, but it is not known whether similar one-stop services provide evidence-based recovery programs beyond immediate counseling. Prudent trauma-informed care approaches. Some positive impacts for individual children and adolescents have been found in qualitative research. Evidence of professional and organizational changes in behavior is limited. Needs more research. Needs more research. Aftercare and reintegration services. There are positive but mixed findings on service user satisfaction. Services that provide qualifications and skills for employment and follow-up support in the community are preferred by survivors. Needs more research. Needs more research. Crime and justice. Victim redress and compensation. Mixed findings on impact, and organizations that provide compensation often do not publish information on these schemes. Needs more research. Needs more research. Health outreach and advocacy. E.G. Runaway Intervention Program. US research is limited, but one study without a comparison group shows positive findings for reduced emotional distress and trauma symptoms. Needs more research. Needs more research. Cognitive behavioral therapy effective for reducing general childhood trauma, PTSD, depression and anxiety among adolescents. May be less appropriate for younger children. Research in LMICs is still limited. Effective promising. EMDR, eye movement desensitization and processing, found to be effective for treating trauma symptoms in older children and adolescents, especially if below the clinical level for PTSD. Effective. Other therapies, for example, group, individual, creative therapies, psychoanalytic / psychodynamic, narrative therapies, Animal-assisted therapies most show positive impact on global well-being measures. Although many studies are based on small samples and limited designs, play and creative therapies may be more suitable for younger children and those with limited communication. Needs more research. Needs more research. Mentalization-based treatment, MBT, promising findings for treatment of multiple personality disorder and for adolescents who self-harm. Needs more research. Needs more research. Community shelters providing holistic services. Research evidence is limited and relates mostly to adult victims in shelters in HICs. CSAE and trafficking shelters have focused on rescue and provide varied services. Insights from young survivors can inform services, especially where there is resistance to rescue and residential service provision. The Butterfly longitudinal study has provided important findings on survivor perspectives on all stages of support and recovery. Needs more research. Needs more research. Community-based psychosocial support, for example, apprenticeship models for community-based CBT, with a trauma focus for sexually victimized children. Research is limited, but some positive findings on reduced trauma symptoms. Needs more research. Child, family and relationships. Safe carer model. Parental and carer support is a strong predictor of improved outcomes for sexually abused children, but evaluations of program outcomes are limited. Needs more research. Needs more research. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 8. Ending Child Sexual Abuse and Exploitation, a review of the evidence 172. Appendix to Section 8. Figure 9, Framework for Continuum of Aftercare Services, Macy, R. and Johns, N. 2011, page 90. Definitions of therapeutic interventions discussed. The main types of therapies tend to be psychotherapies. Therapies that are based on psychological methods. Therapies considered in the review include cognitive behavioral therapy, CBT, a form of psychotherapy which aims to focus on and solve problems by changing unhelpful thinking and behavior associated with these. For a sexually abused person, this might, for instance, involve looking at the self-critical and harmful coping behaviors a young person may have by analyzing comprehensive and coordinated case management. Continual focus on 1. Safety and 2. Trauma-informed service delivery. Immediate needs, ongoing needs, long-term needs. Crisis safety services. Crisis shelter services. Basic necessities. Language services. Emergency medical care. Crisis legal advocacy. Physical health care. Mental health care. Substance abuse services. Safety services. Transitional housing. Immigration advocacy. Legal advocacy. Language services. Life skills training. Language skills. Job skills training. Long-term housing. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 8. Ending Child Sexual Abuse and Exploitation, a review of the evidence 173. These, helping the young person to recognize triggers and Develop cognitive skills to counteract the negative thoughts. Cognitive behavioral therapy with a trauma. Focus as defined by the WHO, 2017, refers to a broad range of cognitive behavioral interventions that address trauma, including trauma arising from child sexual abuse and exploitation. Trauma-focused cognitive behavioral therapy, TF. CBT, is a patented variant of CBT developed by Cohen et al. 2001, specifically designed for those who have emotional or behavioral difficulties arising from significant traumatic events. Family therapy is a type of psychotherapy that involves all family members having multiple meetings with a therapist to discuss and solve family problems and strengthen family communication. Non-directive therapy, where the therapist refrains from giving advice or interpretation as the process of therapy, is client-led and involves helping the person to identify conflicts, clarify and understand their own feelings. Psychodynamic therapy /psychotherapy / psychoanalysis therapies that focus on unconscious processes that influence a person's present behavior, aiming to improve self-awareness and understanding of the influence of the past on present behavior and feelings. Creative therapies, for example, play therapy, music, art and drama therapies are therapies that use creative methods to communicate, often where talking cures may be more difficult. Play therapy is often used for younger children between the ages of 3 to 11 as a method for communicating with the child about feelings and experiences and facilitating their understanding and recovery. Narrative therapy aims to separate the person from the problem using storytelling or narrative techniques to co-author with the therapist personal life stories that help to reshape their identity and encourage them to rely on their own skills and agency for change. Animal-assisted therapy involves animals, often especially trained dog or a horse, in the therapeutic process to enable rapport between therapist and client and improve motivation, eye movement desensitization and reprocessing. EMDR, a therapy frequently used for treating PTSD that aims to help people recover from problems triggered by traumatic events by helping the brain to reprocess memories. Mentalization-based treatment, MBT, draws on attachment theory and psychotherapies. Mentalization involves the ability to make sense of one's own and others' states of mind, desires, intentions, thoughts, feeling and behaviors. MBT aims to address mentalization failures common in people with borderline personality disorders. MBT is also increasingly used with children and adolescents who self-harm. Adolescent mentalization-based integrative treatment, AMBIT, and with parents who have drug or alcohol problems. Contents: Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References: Section 8. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence. 174. Strategies for Action. As children who experience one type of victimization may also experience others. Ayoninai and Salmi, 2011. Finkelhor, Ormrod and Turner, 2007, Fisher et al., 2015. Strategies to end sexual violence need to be embedded in broader action to end all forms of violence, whether physical violence, emotional abuse, sexual abuse, neglect, or living with a mother victimized by domestic violence. Findings from the evidence review support many of the recommended actions already agreed within the INSPIRE Framework and Handbook, WHO, 2016a, 2018, within UNICEF's own work on preventing and responding to violence against children and adolescents, UNICEF 2017b, and within the Gender-Based Violence, WHO 2019a, and Gender-Based Violence in Emergencies Strategies, UNICEF 2017c. The evidence review also highlights areas where having different and more specific strategies for child sexual abuse and exploitation are needed alongside those currently recommended for violence against children in general. In this concluding section, we will contextualize the review findings within the Inspire and Respect strategies for action, highlighting implications for sexual violence prevention and the existing gaps in knowledge, and bring together recommended strategies for action within a theory of change on preventing and responding to child sexual abuse and exploitation. Drawing it all together. In drawing together messages from the review, there were 3 key criteria. 1. To focus on the whole system, as discussed on pages 62 to 64. Although it was necessary to review available evidence from single-issue interventions, such as teaching children in elementary schools about bodily safety, and combined interventions, such as life skills, gender, social and economic empowerment programs, the aim was to identify a combination of strategies that together might bring system change. 2. To build on what is already being done under other evidence-based programs for violence prevention, especially on violence against children, as in Inspire, WHO, 2016a, violence against women, as in Respect, WHO, 2019a. Consultations with a wide range of experts on violence prevention programming. Described below, identified 3 key questions they felt should be answered from the review findings. A. What is currently already being done or recommended under coordinated efforts to end violence against children and violence against women that will help end child sexual abuse and exploitation? B. Where do we need to do things differently to adequately address 9. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 9. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 175. Child Sexual Abuse and Exploitation. See what are the most pressing gaps in knowledge and practice about what works. 3. To develop a theory of change for preventing and responding to child sexual abuse and exploitation, reading across to other strategies, to aid planning and programming. The review was supported throughout by a process of consultation where experts in violence prevention scrutinized and shared their knowledge about how the findings could be used, with considerable help from child protection specialists in UNICEF HQ in New York. To coordinate participation, 3 groups of experts were involved: specialists on preventing violence against children from global external partner organizations such as the Global Alliance to End Violence Against Children, WHO, ECPAT, Together for Girls, UN Women, UNFPA. Policy and Program Specialists from UNICEF New York. Child Protection Program Leads for UNICEF Regional Offices, who in turn facilitated some consultation with specialists in their country offices. 3 rounds of consultations took place online to give expert feedback on the theory of change, the findings from the evidence review and on the draft summary for policymakers. There was also an independent peer review of the evidence review. Unfortunately, resources were not available for any meaningful consultation with children and young people themselves. Strategies that were rated on the basis of the body of evidence reviewed as effective, promising or prudent, as described on page 62, are presented within the framework of a theory of change for preventing and responding to child sexual abuse and exploitation, developed in consultation with experts and partner organizations, with reference to UNICEF's theory of change frameworks and the Inspire, WHO, 2016A, and Respect, WHO, 2019A, guidance. A theory of change. There is no fixed blueprint to guide violence prevention. Much has been achieved in the 30 years since the implementation of the Convention of the Rights of the Child, and use of better data and research, widening collaboration and partnerships and amplifying the voice of children themselves have been among the key ingredients of change. UN 2019A. A theory of change takes a structured and outcome-focused approach to defining in context the problem and what needs to change, identifying the barriers to change, the processes for overcoming these, the anticipated outputs and outcomes. It can be used to aid description, to get agreement about the process of change, to aid planning and the evaluation of outcomes. It can also be linked to sources of evidence which can be useful in trying to improve evidence-informed approaches. Each step in the process can be shown in a diagram which can be a useful starting point for dialogue and consultation when developing responses in different contexts with relevant partners and stakeholders. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 9. Ending Child Sexual Abuse and Exploitation, a review of the evidence 176. Figure 10, Theory of Change for Preventing and Responding to Child Sexual Abuse and Exploitation. Girls and boys of all ages grow up with a freedom from sexual abuse and exploitation, and those who do experience sexual abuse or exploitation, in all the settings and contexts in which it occurs, benefit from greater access to care, support, justice and other services needed to ensure physical, mental and social well-being. Sexual abuse and sexual exploitation of male and female children and adolescents perpetrated by adults, including caregivers, other adults and peers, in the settings of the home, school, community, workplace, media and online environment, in residential accommodation, justice system or in care, in faith-based organizations, travel, tourism, sport and leisure, and in the contexts of armed conflict, displacement, migration or emergencies. Enabling environments social and behavioral change service delivery. Those in contact with children, in all settings and contexts, are prevented from sexually abusing and exploiting children. Perpetrators are disrupted, identified, prevented from getting Access to children, given appropriate sanctions and stopped from committing further offenses. Lack of political will and evidence. Poor legal protection, policy and resources. Implement national strategies. Align and enforce laws with international standards and invest resources. Address risks and drivers in context and build resilience. Build capacity for services and invest resources to prevent and respond. Regulate, demand, and prevent reoffending. Change social norms and behavior that supports gender inequity and sexual abuse of children. Improve participation, advocacy and accountability to children. Create safe environments and institutions. Support parents and caregivers to prevent and protect sexually abused and exploited children are not criminalized, are effectively protected and given help for recovery and reintegration. Limited focus on deterring offenders and bringing them to justice. Children know how to recognize sexual abuse and exploitation, and boys and girls can access information, help, and support directly themselves. Poor coordination and capacity of child protection system. Health, education, justice, and community responses. Families, peers, communities and professionals across all sectors have knowledge, resources and motivation to take effective action to prevent and respond. Limited focus on child's, especially victims, voice and best interests in decision-making and policy. Respect for diversity. Children in situations of vulnerability are identified, and effective interventions are provided to reduce risks and prevent sexual abuse and exploitation. CSA/CSE risks and drivers at levels of individual, family, community, organization, and society. Key population groups have greater exposure to messages about preventing child sexual abuse, social norms and practices that support child sexual abuse and exploitation and gender-based violence. Impact, problems, outcomes, outputs, barriers, actions, conditions and norms of behavior promote gender equity, respect for children, their healthy development, and capacity for healthy and equitable intimate relationships. Improved outcomes for prevention and response from coordinated multi-sector, key services and communities. Social conditions, structural inequalities, beliefs, behaviors, and practices that allow child sexual abuse and exploitation to happen no longer exist. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 9 Ending Child Sexual Abuse and Exploitation, a review of the evidence 177. Rationale. An effective system response is essential for the implementation of children's rights as set out in the Convention on the Rights of the Child, 1989 and 4. Meeting the Commitment of Sustainable Development. Goal 16.2 to end violence against children by 2030. National governments carry the ultimate responsibility to ensure that the rights of children are met and that resources are provided for this purpose. Implementation and enforcement of laws to criminalize child sexual abuse and exploitation and ensuring the safety of the environments in which children spend their time are strategies recommended by Inspire, WHO, 2016a, and supported by Respect, WHO, 2019a. The model shown in Figure 10 above is not designed to be prescriptive but to aid consensus building for the planning, governance, implementation and monitoring of responses. It is based on a children's rights perspective, as set out in the Convention on the Rights of the Child, and international standards and the understanding that violence is preventable. It draws on socio-ecological theory, recognizing that actions to end all forms of violence against children need to address individual, relationship, community, organizational and structural risks and drivers that contribute to violence. Reading from the bottom of the diagram to the top level, it sets out in an accessible manner common challenges in responding to child sexual abuse and exploitation, identified from the evidence review, and a range of evidence-based strategies and anticipated outcomes to address these. It is assumed that change must be internally driven and that child, family and community level knowledge and expertise will be essential for understanding the problem and responding to the challenges in specific contexts, and for boys and girls. Responses and priorities for action may differ for different forms of sexual abuse and exploitation against children in different contexts. For example, the diagram could be used as a basis for discussion and review by children and other stakeholders who prioritize taking action against the sexual abuse of children within the family by relatives or trusted adults and peers. Or it could be used to review and agree on actions and priorities for reducing the risk of sexual exploitation and trafficking of adolescent girls in a high-risk area such as a refugee camp. Building on what is already being done under existing violence prevention strategies, such as Inspire, WHO, 2016a, Respect, WHO, 2019a, and UNICEF's own guidance, UNICEF, 2017b, 2017c, 2018a, 2018b. The theory of change sets out actions across three broad areas of interrelated activity to create enabling environments for prevention and response, build capacity for services and mobilize social and behavioral change. The next section looks in more detail at recommended actions under each of these three areas, drawing together findings from the evidence review on programs identified as effective, promising or prudent, enabling national environments. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 9 Ending Child Sexual Abuse and Exploitation, a review of the evidence 178. 3 specific actions for creating an enabling environment were identified from the evidence review. I. Implementing and enforcing laws and policies. I. Regulating demand and preventing offending. I. Creating safe environments and institutions. Because different forms of violence against children, physical violence, neglect, psychological and sexual abuse and exposure to domestic violence, often occur, responses towards child sexual abuse and exploitation at the national level must be integrated into broader violence prevention responses. However, as previously argued, a specific focus on child sexual abuse and exploitation is needed in policy, planning and legislation due to the particularly hidden nature of child sexual abuse and exploitation, the different gender-driven inequalities and developmental risks and drivers, and the substantial gaps in knowledge and practice about how best to address these challenges in different contexts. Around 60 countries have comprehensive laws to ban all forms of violence against children, including at home and in schools, and a growing number have adopted legal and policy frameworks to end child marriage, UN 2019a. However, gaps and anomalies in law and policy on child sexual abuse and exploitation persist in many countries. Common policy gaps are discrepancies in laws on the age of consent or failure to define a specific age of consent, parental and judicial consent exceptions to early marriage, laws that only criminalize the prostitution of children below the age of consent, define prostitution in gender-specific terms or exclude certain sexual acts. CSAE and NGO, 2017, SRSAT, 2017, UNFPA, 2017. Wodon et al., 2017. The sexual abuse of boys is a neglected issue in policy and child protection practice. Economist, 2019. The laws to regulate child sexual abuse materials online in 62 of the countries surveyed by the International Center for Missing and Exploited Children were rated in 2018 as not being sufficient to prevent this form of abuse, and 16 countries still had no legislation at all. ICMEC, 2018. Guidance exists to help policy makers to address these anomalies and gaps. 2011, ICMEC, 2018, Gini, 2015, UNIDC/UNICEF. 2009, UN General Assembly, 2014, WHO, 2016a, WHO. 2018, WIPOTECT, 2016. Most countries have laws that criminalize child sexual abuse, but the main issue is poor enforcement. Prosecution rates for child sexual abuse and exploitation are low in many countries, and there is a huge gap in knowledge and practice about how to regulate demand and intervene early to prevent sex offending. Although some countries have adopted increasingly harsh penalties for rape and child sexual abuse, the deterrent effect of imprisonment alone is a contested issue. Indeed, evidence indicates that the certainty of being caught is a stronger deterrent to further offending than the severity of the sentence, Ritchie, 2016. If more perpetrators of sexual abuse and exploitation are to be identified and prevented from further offending, criminal law needs to be enforced, resourced for delivery, supported. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 9 Ending Child Sexual Abuse and Exploitation, a review of the evidence 179. By services for victims such as child-friendly reporting, trauma-informed victim support and protection, with guidance and training for professionals, UN, 2019a. Responses to children and adolescents who commit sexual offenses should not be the same as responses towards adults. States which have ratified the United Nations Convention on the Rights of the Child 1989 are obliged to ensure that children in conflict with the law benefit from diversion and the use of alternatives to custody to the greatest extent possible. CRC, Articles 37, b. 40.1, 40.3, b. 40.4. Children and adolescents who commit sexual offenses before the age of 18 have low rates of sex offending. Recidivism and offending in general declines with age. Burton, Duty and Leibowitz, 2011, Moffat, 1993, Moffat et al., 2002. Diversion from custody towards alternative developmentally appropriate therapeutic treatments, involving parents and caregivers where possible, is recommended. Hackett, 2014. Learning from several national inquiries into organizational and institutional abuse has shown that too often, organizations that have responsibility to protect vulnerable children and adolescents have been sites of further abuse and compounded children's vulnerabilities. 1. Action to create safe environments within institutions needs to move beyond manipulation of the physical environment. Situational prevention, to include organizational and individual responsibilities for child safety at home, school, residential institutions of justice and care and other areas of everyday life. Funders and philanthropic organizations can contribute to this work by supporting the implementation and external monitoring of institutional standards for child protection, including better advocacy and voice for child and adolescent victims. Evaluations of whole school approaches to violence have brought promising findings on creating safe institutions, basing programs for change on what young people have said about their daily experiences. These approaches aim to change the whole school culture, involving pupils, teachers, other school staff and often parents in a comprehensive program of change to create a safe learning environment. Examples are the Good Schools Toolkit in Uganda, DeVries et al., 2015, 2017, and Shifting Boundaries in the U.S., Taylor et al., 2013, 2015, 2017. Lack of political will and lack of adequate resources are often cited as the reasons that systems do not work or that children do not have access to services. However, much can be achieved in contexts where resources are scarce. Economist, 2019. Context-relevant evidence can aid decisions in low-resource environments about which responses may be most effective. Table 10 summarizes effective, promising and prudent actions to help create an enabling national environment for preventing and responding to child sexual abuse and exploitation. Examples of actions and programs are shown. These have been selected from HICs and LMICs on the basis of the strength of evaluations and commitments to international standards. In LMICs, some examples shown are adaptations and implementations of programs evaluated in HICs only. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 9 Ending Child Sexual Abuse and Exploitation, a review of the evidence 180. Table 10, Actions to support an enabling national environment. Evidence Key 1. One or more of the Inspire 7 strategies. High-income countries. Evidence rating effective. 2. One or more of the Respect 7 strategies. Evidence rating promising. Low and middle income countries. 3. Recommended action in UNICEF strategies. Evidence rating prudent. Enabling national environment. Actions examples implementation issues evidence. Implement. National strategies and policies, align and enforce laws with international standards and invest resources. Legislation that operationalizes commitments under the United Nations Convention on the Rights of the Child and other relevant commitments. Adequate resources, staff, training, multi-sector coordination, monitoring etc. are allocated for enforcement. 1, 2, 3. Minimum age of marriage laws, 18 years, remove parental or judicial permission. Exceptions. Policies to address the root causes of early marriage, for example education for girls. 1, 2, 3. Global harmonization of laws on online CSA/CSE as in WIPOTECT model national response. Support collaboration between government, ICT sector and services working with children. 1, 2, 3. 2. Victim-sensitive and child-friendly justice, for example trauma-informed approaches in children's advocacy /Barnahus models, specialist police desks, for example Tanzania. Monitoring outcomes in different contexts with attention to access inequalities, for example in rural communities. Implementation challenges and impact on prosecution. 1, 2, 3. National policy protocols on identification, assessment, reporting and response (UK and Zimbabwe). 4. National commitment to learn about and confront the barriers child victims face in getting help. Training, resources and multi-sector coordination for service responses. Phased, adequately resourced and monitored. Introduction of mandatory reporting as evidence of impact is mixed. 5. 1, 2, 3. 6. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 9 Ending Child Sexual Abuse and Exploitation, a review of the evidence 181. Enabling national environment. Actions examples implementation issues evidence. Regulate. Demand. And prevent reoffending. Prosecution and criminal sanctions on adult offenders, for example Remove exceptions from criminal prosecution for rape and sexual offenses by offenders who are married to or who offer to marry the victim while ensuring protection of victims from secondary victimization. Resources for enforcement. 123. Divert children who commit sexual offenses from custody. Resources for enforcement and alternatives to custody for juveniles. 123. Treatment for children with sexual harmful behaviors. For example, multisystemic therapy, MST, targeted support involving juvenile and caregivers. MST requires high level of professional resource, so piloting and monitoring targeted support likely to be more practical where resources are scarce. 123. 7. Create safe environments and institutions. Manipulation of physical environment to increase safety. For example, combined IPV and sexual violence prevention and situational /building strategies, shifting boundaries, US, child-friendly spaces and camp design in humanitarian contexts. Needs young people's participation in mapping unsafe hotspots and integration with service responses such as school response to peer perpetrators. 123. 89. Whole school approaches, targeting not only peer and partner violence but also violence perpetrated by teachers and other educational staff and general building safety. E.g. Good Schools Uganda, Doorways 3 Ghana and Malawi. Effective for violence prevention but too little data on self-reported sexual violence to evaluate impact. Longer-term monitoring is needed as reports of sexual abuse may rise at first as victim confidence to report increases. Needs coordination and resources in schools and the wider community to implement an effective response. 123. 10-11. Use of technology to detect and online report abuse buttons lead to increase in public reports and identification of and takedown of XAM or harmful materials. Requires continued international efforts to identify materials reposted on different sites or in unregulated areas. 123. 12. Safeguarding policies and systems for children's and community organizations, faith groups and sports. E.g. Child Safe Standards, Australia, Guidance on Child Safeguarding in Sport. Needs integration into broader prevention strategies to address risks and organizational drivers. Currently low evidence on impact. 123. 13. Involving private sector and communities in creating safe environments, for example codes of conduct in travel and tourism. 123. 14. Table 10, Actions to support an enabling national environment, continued. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 9. Ending child sexual abuse and exploitation, a review of the evidence. 182. Rationale. Articles 19, 20, 34 and 39 of the United Nations Convention on the Rights of the Child, CRC, set out a state's obligation to protect children from all forms of violence, neglect, maltreatment, sexual abuse and exploitation, and to establish procedures and social programs for prevention and response, including the identification, reporting, referral, support and care of children. Improving access to good quality health, social care. Justice and support services for all children is one of the 7 Inspire strategies. This can reduce the long-term impact of sexual abuse and exploitation, thereby also helping to prevent abuse in the next generation. CRC Article 12 sets out state responsibilities to protect, promote and respect the rights of children to participate in decisions that affect them, taking into account the best interests of the child. Participation work with children should be ethical, safe and meaningful. SDG 16.7 aims to ensure responsive, inclusive, participatory, and representative decision-making at all levels. Service delivery. 2 specific actions to improve service delivery were identified from the evidence review. Investing resources and building the capacity of services to prevent and respond. Improving the participation of, advocacy for and accountability towards children. All child protection systems need responses to be developed in context and make sense to the communities that use them. Wessels, 2015. Many countries face challenges in ensuring there are services that are accessible and relevant to the needs of children and young people at risk or experiencing different types of sexual abuse and / sexual exploitation. Blakemore et al., 2017, Baum et al., 2014, User et al., 2014. John Jay College, 2004, No Violence in Childhood, 2017. Lineham and Facchini, 2019, Sawikar and Katz, 2018, Mason. Jones and Logie, 2019, Shea, Roberts and Gandhi, 2016, Scott and Swain, 2015. Sumner et al., 2015. Friends, family and informal support are the first port of call for many children seeking help. Alagio, Colin Vazina and Latif, 2019, Colin Vazina et al., 2015. Lartinen et al., 2018, Stiller and Hellman, 2017. Lack of trust and frustration with inaccessibility or poor responses from formal services can leave children and families with little option other than seeking informal solutions. Some community responses, such as requiring the rapist to marry an adolescent victim, may be unhelpful in tackling the underlying causes. K. Foucault et al., 2015, Stark et al., 2012, Wessels, Castelny and Ondoro, 2014. Services are more likely to be effective where 1. Children are meaningfully and ethically involved directly in multi-sector efforts from the community level upwards in mapping needs and the availability of services. Direct, inclusive and ethical consultation with young people can improve service delivery and, given the hidden nature of the problem, the shame and blame. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9 References Section 9. Ending Child Sexual Abuse and Exploitation, a review of the evidence 183. Too often experienced by child and adolescent victims. This is a clear area of priority for child sexual abuse and exploitation. Benelli, Fikiri and Umrai, 2019, Save the Children, 2015, Scott et al., 2019, Wessels, 2015. Two formal services build on the strengths and gaps in existing child protection mechanisms to prevent, identify, report and respond to sexual abuse and exploitation in specific communities. UNICEF, 2019, Wessels, 2015. 3. Help is accessible and appropriate to the needs of younger and older girls and boys. No violence. 2017, Ligero et al., 2019. 4. Delivery is guided by the principles of trauma-informed care. Cody, 2017, Pratt, 2013, Quaidara and Hunter, 2016. Scott et al., 2019. In low-resource settings, frontline services may be concentrated in urban areas or unevenly available in areas of past conflict or emergency, making accessibility a particular challenge for children in rural areas. Many states have set up free and confidential child helplines providing advice and support directly to children themselves as a first step. Response, United Nations, 2019a. Resources are needed to respond to children in communities who are identified as vulnerable, and children and adolescents themselves are best placed to express their views on which services are helpful. Multi-component and multi-agency services, such as well-resourced one-stop shop style services with effective coordination and links with other services, are likely to be more effective, although research on child and adolescent safety and well-being outcomes needs to be further developed. One-stop sexual violence services, such as gender and child abuse police desks in Tanzania and Sudan, or South Africa's Thuzula services and SARCs in the UK, typically bring together professionals from health, forensic, and legal services, counseling and victim support to provide more holistic and coordinated care. One-stop services with a specific child protection focus typically include more child-focused services and specialists from child welfare and advocacy, health and justice professionals in a child-friendly environment to provide holistic care from identification, assessment, protection and prosecution through to treatment and recovery. There is evidence from services such as children's advocacy centers in the US and from children's houses / Barnahus across Europe of a growth in sexual violence-related referrals and services provided, improved prosecution processes and child and parent / caregiver satisfaction with the service. Ali Musa and Mohammed, 2019. Children's Commissioner, 2015, Cross et al., 2008, Herbert and Bromfield, 2016, Johansson and Stephenson, 2019, Johansson et al., 2017, Miller and Rubin, 2009, Nwogu et al., 2016, United Nations Tanzania / UNICEF, 2013. Service standards and guidelines for Barnahus have been developed to help guide implementation of these services across different national contexts while maintaining fidelity to the main standards of holistic care for children. Hal Dawson, 2018. The social work workforce is thinly spread and poorly supported in many countries, and there is a need for further Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 9 Ending Child Sexual Abuse and Exploitation, a review of the evidence 184. Investment. UNICEF have recently published guidance on strengthening the child protection social work workforce. UNICEF 2019. There are encouraging early research findings that suggest that in low-resource settings, capacity of services can also be developed through specialist task force or mobile hub-and-spoke models of service development. Bailey et al. 2015, Mace, Powell and Benson, 2015, Pierce, 2014. Sexually exploited adolescents may be resistant to traditional child protection responses, particularly if they have run away from a residential care facility and lack trust in welfare services. Outreach and advocacy programs are often linked with one-stop shop or shelter services, and increasingly tend to draw on trauma-informed practice and case management methods. Consultations with adolescents, qualitative evaluations and practice experience favor specialist outreach or advocacy models that respond to immediate practical needs, food, health, care etc., and build trust, taking a staged approach on the journey to safety, recovery and reintegration. Cordisco et al. 2018, Scott et al. 2019, Shepard and Lewis, 2017. These approaches warrant further research and attention. Table 11, Actions to support service delivery. Evidence key. 1. One or more of the Inspire 7 strategies. High-income countries. Evidence rating effective. Evidence rating promising. 2. One or more of the Respect 7 strategies. Low and middle income countries. Evidence rating prudent. 3. Recommended action in UNICEF strategies needs more research. Service delivery. Actions examples implementation issues evidence. Build the capacity of services and invest resources. Child helplines or report abuse lines for adults, for example. Childline Kenya, Tanzania, UK. Bring an increase in calls and children's access to services. Follow up. Research on outcomes is limited. Resources needed for implementation, training, policy, procedures and governance framework and links with multi-sector responses, resources and awareness raising. Many helplines also provide online services. 15. 123. 16. Training professionals to identify and report child sexual abuse / sexual exploitation, for example Darkness to Light Stewards of Children, U.S. Reported cases rise. Training has to be reinforced and repeated. Further monitoring is needed to assess the impact of reporting on child outcomes. 123. 17. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 9 Ending Child Sexual Abuse and Exploitation, a review of the evidence 185. Service delivery. Actions examples implementation issues evidence. Build the capacity of services and invest resources. Continued cross-national police collaboration on online victim and CSAM perpetrator identification, reporting and prosecution, increases reports, prosecutions and takedown of CSAM, requires implementation of We Protect guidance, a framework of legislation, resources to develop, expertise for collaboration in national police, collaboration with private sector online service providers, supported by preventive education, with children in schools and parents. 123. One-stop coordinated services to respond to gender-based violence and child abuse, for example. Thuzula Centres, South Africa, Malindi CPC. Kenya, SARC's UK. Service design is appropriate and accessible to children and adolescents in the community. 123. 18. Outreach and advocacy providing trauma-informed, staged approaches to care for sexually exploited children and adolescents. E.G. Benedos. 4am Model UK, Advocacy for Trafficking Victims. Multi-sector coordination with formal services and community. 23. 1920. Services for recovery, for example cognitive behavioral therapy with a trauma focus. In low-resource settings, mentorship and trained paraprofessionals can provide therapy. 123. 2122. EMDR, eye movement desensitization and processing, found to be effective for treating trauma symptoms in older children and adolescents, especially if below the clinical level for PTSD. Other modes of delivery may be better in low resource areas, for example use of volunteers, online therapy. 123. 2324. Improve participation of advocacy for and accountability towards children. Children and adolescents have a meaningful role in public policy and in the design, delivery, and monitoring of services. IG Congo, identifying priorities in conflict contexts, influencing law of consent. Kosovo requires organizational structures and processes for children's voices to be heard. 1-3. Table 11, Actions to support service delivery, continued. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 9. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 186. Social and behavioral change. 3 areas of interrelated activity were identified in the review of evidence. Addressing the risks and drivers, and enhancing protective factors for child sexual abuse and exploitation. In context, some of which differ from those associated with other forms of violence. Changing social norms and behavior that support gender inequality, discrimination and the sexual abuse of children and adolescents. Supporting parents and caregivers to keep their children safe from child sexual abuse and exploitation. All 3 areas of action work best if they involve children, families or caregivers, where appropriate, and communities. Efforts to change social norms, for example, will not succeed without the involvement of people in the community, including men and boys. Community participation aids coordination and working together and supports local capacity to respond, and also contributes to more sustainable outcomes. The general messages for best practice are: 1. Good quality, Interactive, gender and age appropriate. Programs work best for targeting the behavior and attitudes of children and young people. For example, as part of making environments safe for younger children, safety education in school, home and community settings for parents and their children aged 4 to 9 years may focus on safety in relationships with adults and peers, including trusted adults, body parts, recognizing inappropriate touching or other forms of sexual behavior, including online, and who to talk to about this. Programs for older children, aged 10 plus, might address sexual victimization and perpetration, include consent and respectful and gender-equal peer, family and intimate relationships. Two comprehensive approaches that combine risk reduction with education, behavior changing and broader asset, skills building and empowerment strategies are showing the most promising results. Rationale. All 7 of the INSPIRE strategies for action are founded on the recognition that ending violence against children requires both primary prevention and effective responses. Primary prevention addresses the underlying beliefs, attitudes and behaviors, inequalities, risks and drivers for violence at the levels of the individual, family and relationships, community, organization / institution and broader social and political context. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Section 9 Ending Child Sexual Abuse and Exploitation, a review of the evidence 187. Table 12, Actions to support social and behavioral change. Evidence Key 1. One or more of the INSPIRE 7 strategies. High-income countries. Evidence rating effective. Evidence rating promising. 2. One or more of the Respect 7 strategies. Low and middle income countries. Evidence rating prudent. 3. Recommended action in UNICEF strategies needs more research. Social and behavioral change. Actions examples implementation issues evidence. Address risks and drivers in context. And build resilience. School and nursery-based keeping safe education for children for example. Who do you tell? Canada, I have the right to feel safe, Ecuador. Improves children's knowledge about sexual abuse, safe and unsafe touches, who to tell / what to do without adverse consequences such as increasing fears. There is no evidence of impact on victimization rates after program exposure. Impact influenced by the quality of the program, longer duration, interactive format that allows children to practice skills, such as role play, and involvement of parents and teachers. Data on disclosure. Often not collected. 1-2. 25-26. Empowerment and self-defense for adolescent girls. No evidence on impact on under 18s in HICs found. RCTs in Malawi and Kenya found I-Empower program, brought reduced self-reported sexual victimization, increased self-confidence and self-reported successful use of defensive behavior. Analysis at the individual level was not possible. Delivered in the context of a wider Safe Schools program, not as a standalone. 1-2-3. 27. Economic strengthening for women and girls and vulnerable children such as orphans, for example Social Security, conditional or non-conditional cash transfers as in Zomba program, Malawi, if combined with other prevention efforts, may have potential to address associated risks of sexual abuse and exploitation for adolescents. 28. Combined gender, economic empowerment and vocational life skills programs for adolescent girls, for example ILA program Uganda. Programs vary in different contexts, but usually involve safe spaces for peer groups, health education, life skills, and confidence building and economic empowerment. 29. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References Section 9. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 188. Social and behavioral change. Actions, examples, implementation, issues, evidence. Change social norms and behaviors that support gender inequality and sexual abuse of children. Community or school-based education to target entrenched norms and values of males and females that support gender inequality and violence. Most programs have IPV focus and no direct evidence of impact on CSA/CSE, for example Safe Dates US and South Africa. Programs for adolescents that involve parents seem to be more effective. 30-31. Sex education /HIV prevention programs for males and females. Lower rates of transactional sex and IPV perpetration reported by men after intervention, but no impact on women's victimization. For example, Stepping Stones, South Africa, may work better for females if combined with economic empowerment. 32. Involving men and boys and communities in violence prevention, for example mentoring, community engagement and bystander programs. Evaluations show changes in attitudes and bystander intentions, but impact on child sexual abuse has not been measured. 33. Support parents and caregivers to prevent and protect children from sexual abuse and exploitation. Targeted home visits with vulnerable families and structured program to develop positive parenting. For example, Family Nurse Partnerships UK, Netherlands, US. Effective at reducing child protection registrations and addressing risks related to child sexual abuse. Although effective for reducing associated risks, data specific to child sexual abuse and exploitation is limited and could be improved. 34-35. Parenting programs to prevent maltreatment and physical punishment. Few report impact on CSA/CSE and none address risk of children developing harmful sexual behavior. For example, Head Start RCT in US found reduction in child sexual abuse. Effective at reducing child protection registrations and addressing risks related to child sexual Abuse such as perceptions of punitive parenting. Most effective if resources exist for coordinated child protection system. Responses 1, 2, 3. 36. Improving parent-child communication about sex and safety. For example, Parents Matter. US, Families Matter. Botswana, Côte d'Ivoire, Kenya, Mozambique, Namibia, South Africa. United Republic of Tanzania, Zambia. Communication improves but impact on sexual abuse and young people's behavior needs to be measured. 37-38. Table 12, Actions to support social and behavioral change, continued. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 9. Ending Child Sexual Abuse and Exploitation, a review of the evidence. 189. Gaps and Challenges. The purpose of this review is to build on, and hopefully take forward, existing system-focused work to end child sexual abuse and exploitation. Knowing the facts about the problem in context is necessarily the first step, but also an ongoing part of the process of change. Much is already being done, because there are some common risks and drivers for violence against women and violence against children. Guides et al., 2016, interventions that aim to reduce these, such as life skills, gender equity, and economic and social empowerment programs, are likely to have an impact on some forms of child sexual abuse and exploitation, such as transactional sex or adolescent partner abuse. Findings from this review endorse recommendations for further collaboration and coordination of efforts to address violence against children and violence against women. Gathering data from this work to examine the specific impact on child sexual abuse and exploitation is a necessity, although likely to be challenging given the hidden nature of the problem for both girls and boys and widespread underreporting. Further research on safe schools would be helpful for improving the evidence base. Experience from both low, middle and high-income country contexts shows that reported cases are likely to rise as confidence in the child protection system increases. There are areas where research evidence indicates that to end child sexual abuse and exploitation, a change in approach is needed. Efforts to confront child sexual abuse and exploitation and help children affected will not succeed unless founded on what children and young people themselves need, which requires continued effort to support children's meaningful participation. While every attempt has been made in this review to be as inclusive as possible in the search for evidence, there are many gaps in knowledge and challenges for practice to confront, including broadening the focus on perpetrators to reduce the demand for child sexual abuse and exploitation, including online facilitated abuse and the production of child sexual abuse materials. Recent research on social norms and sexual violence, Buller et al., 2020, and ongoing cross-regional work in Africa on creating baselines to measure and track changes in social norms is welcome. Too little is known about the social norms that fuel demand for different types of child sexual abuse and exploitation in different contexts and relationships. Too little is known about policies that may regulate demand, including the demand for child sexual abuse materials online. Prevention for young people with harmful sexual behavior. Research and practice on the prevention, primary and secondary, of harmful sexual behavior among children and adolescents living in the community is very limited, especially in the global South. There is a lack of robust data on recidivism for young offenders at the individual level, as well as a lack of context-relevant behavior changing contents. Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 9. Ending Child Sexual Abuse and Exploitation, a review of the evidence 190. And therapeutic responses. Strategies for earlier intervention in schools to prevent harmful sexual behaviors could be integrated with ongoing whole school programs to address gender-based violence and create safer schools. Effective responses to online abuse. There are many programs targeting children, parents and teachers, but research on their impact is still limited. The impact measures for education-based programs are not comprehensive, as they often focus on one specific type of violence: sexual, online, bullying, partner abuse. Tend to assess easily collected data such as knowledge gains with little data collected on behavioral change, child protection or child safety. Primary prevention programs on online child abuse might be better integrated with wider programs on preventing violence against children, as abuse offline frequently includes abuse online. Reaching all children. There are groups of children who have been neglected in research and practice on sexual abuse and exploitation. Research on what works to prevent and respond effectively to sexual abuse and exploitation is limited for boys, for children who identify as gay, lesbian, non-binary or transgender, for children with physical disabilities and learning difficulties, for children in marginalized and persecuted groups, for migrant, refugee, and stateless children. Existing global partnerships could take the lead in scoping what is known and in identifying priorities for future research. Building on strengths in the informal sector. Informal and community support from peers, family and community groups, including faith groups, are often the first or main source of help, but too little is known about what this involves. Contents. Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Section 9. Ending Child Sexual Abuse and Exploitation, a review of the evidence 191. References. Abbey, A. 2005, Lessons Learned and Unanswered Questions About Sexual Assault Perpetration, Journal of Interpersonal Violence, 21, 3942. Abbey, A. Clinton Sherrod, M. McCausland, P. Zawacki, T. Ando Buck, P. 2003, The Relationship Between the Quantity of Alcohol Consumed and the Severity of Sexual Assaults Committed by College Men, Journal of Interpersonal Violence, 1817, 81333. Adeli Ken, Adibimp W., Farin Loyi, and Oloa Korea. 2019, Rural and Urban Prevalence of Sexual Assault Against Women in an African Population, Bangladesh Journal of Medical Science, 18, the 3rd of July, 628 to 635. ACPF, 2014. The African Report on Violence Against Children. Addis Ababa, the African Child Policy Forum, ACPF. Afifi, T. and Macmillan, H. 2011, Resilience Following Child Maltreatment, a Review of Protective Factors, Canadian Journal of Psychiatry, 56, 5, 266 to 272. Agar, Adot and Metzler J. 2012, Child-Friendly Spaces, a Structured Review of the Current Evidence Base, Columbia University Mailman School of Public Health and World Vision, New York. Ainsa, M. and Loof MEDS. 2011, Online Behavior Related to Sexual Abuse, a Literature Report, Robert Project, Council of the Baltic Sea States, Stockholm. AJI, C. 2020, An Intersectional Analysis of the Role of Cultural Beliefs, Norms and Practices, Help Seeking and Support in Nigerian Women's Accounts of Sexual Abuse and Violence, PhD thesis, University of Central Lancashire, Preston. Ajdukovic, M. Suzak, M. and Rajta, M. 2013, Gender and Age. Differences in Child Sexual Abuse in Croatia, Croatian Medical Journal. 54, 5, 46979. Alexander, K. Stafford, A. and Lewis, R. 2011, The Experiences of Children Participating in Organised Sport, University of Edinburgh /NSPCC Child Protection Research Centre, Edinburgh. Alfaiz, Giaherai, J. and Gaddo, O. 2012, Prevalence of Physical, Psychological, and Sexual Abuse among a nationwide sample of Arab high school students, association with family characteristics, anxiety, depression, self-esteem, and quality of life, social psychiatry and psychiatric epidemiology, 47-1, 5366. Alikasafoglu, Emerginos, Erkan, O. et al., 2006, Sexual Abuse Among Female High School Students in Istanbul, Turkey, Child Abuse and Neglect, 33, 24755. Alagia, R. Colin Vazina, D. and Latif, R. 2019, Facilitators and Barriers to Child Sexual Abuse, CSAE, Disclosures, a Research Update, 2000-2016. Trauma, Violence, and Abuse, 22, 260-283. Ali Musa, M. and Mohammed, F. 2019, Challenges Facing Police Gender and Children's Desks in Reduction of Gender-Based Violence and Violence Against Children, a Case of Kinondoni District, Dar es Salaam Region, Tanzania, The International Journal of Humanities and Social Studies, 7-8, August, 1-11. Allen, B., and Tussie, C. 2012, Can Projective Drawings Detect if a child experienced sexual or physical abuse, a systematic review of the Controlled Research, Trauma, Violence and Abuse, 13, 2, 97-111. The Alliance for Child Protection in Humanitarian Emergencies, 2018, the Guidance Note on the Protection of Children During Infectious Disease Outbreak, the Alliance for Child Protection in Humanitarian Emergencies. Alnwick, D. Bunting, L. Price, A. Morgan Klein, Enid A. L. 2009, Sexual Abuse and Therapeutic Services for Children and Young People, The Gap Between Provision and Need, NSPCC, London. Alnwick, D. Radford, L. Bunting, L. Price, A. L. 2012 B. In Demand. Therapeutic Services for Children and Young People who have experienced sexual abuse, Child Abuse Review, 21, 5, 31834. Alnwick, D. and Hines, P. 2012 A. Therapeutic Services for Sexually Abused Children and Young People, Scoping the Evidence Base. NSPCC, London. Alnwick, D. Lloyd, J. and Pierce, J. 2018, Evidence-Based Models of Policing to Protect Children from Sexual Exploitation. Luton. The International Centre. Available at https://www.beds.ac.uk/ media/87267/ evidence-based models of policing.pdf. Alnwick, D. and Atkinson, R. 2019, Snitches Get Stitches, School-Specific Barriers to Victim Disclosure and Peer Reporting of Sexual Harm Committed by Young People in School Contexts, Child Abuse and Neglect, 89, 7-17. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 192. AAUW, American Association of University Women, 2001, Hostile Hallways, Bullying, Teasing and Sexual Harassment in School. Retrieved from New York, American Association of University Women. Anderson, G. and Gilgun, J. 2014, The Influence of Narrative Practice. Techniques on Child Behaviors in Forensic Interviews Journal of Child Sexual Abuse, 23:615634. Anderson, L. and Whiston, S. 2005, Sexual Assault Education Programs. A meta-analytic examination of their effectiveness, Psychology of Women Quarterly, 29, 37488. Anderson, L. 2010, Addressing Conflict-Related Sexual Violence, an Analytical Inventory of Peacekeeping Practice, UN Women, New York. Anderson, N. and Ho Foster, N. 2008, 13,915 Reasons for Equity in Sexual Offenses Legislation, a national school-based survey in South Africa, International Journal for Equity in Health, 7, 20. Andrews, G. Corey, J. Slade, T. Sakides, C. and Swanston, H. 2004, Child Sexual Abuse, in Comparative Quantification of Health Risks Global and Regional Burden of Disease Attributable to Selected Major Risk Factors. Volume 2, edited by Majidizati, Alan D. Lopez, Anthony Rogers, and Christopher J. L. Murray, World Health Organization, Geneva, pp. 1851-1940. Andrews, D. Bonta, J. and Wormith, J. 2006, The Recent Past and Near Future of Risk and / or Need Assessment, Crime and Delinquency, 52-1, 7-27. Antonowicz, L. 2010, Too Often in Silence, a report on school-based violence in West and Central Africa, United Nations Children's Fund. Plan West Africa, Save the Children Sweden West Africa and Action. 8, Senegal. Arata, C. 2002, Child Sexual Abuse and Sexual Revictimization. Clinical Psychology, Science and Practice, 92,13564. Armistead L. Forehand R. Long, N. Wyckoff S. and Miller K.S., 2006, The Parents Matter Program, PMP Effectiveness of a Family-Based Sexual Risk Prevention Program, poster presentation at the 16 International AIDS Conference, Toronto, Canada. Ascari, R., Emery, E. and Wong, M. 2013, Systematic Review of Prevention and Management Strategies for the Consequences of Gender-Based Violence in Refugee Settings, International Health, 5, 85-91. Asink, M. van der Put, Siemsen, M. de Joers, N. Ort, F. Stams, G. and Huive, M. 2019, Risk Factors for Child Sexual Abuse. Victimization, a Meta-Analytic Review, Psychological Bulletin. Advance. Online publication. http://dx.do.org/1037/BAL00000188. Urdu, B. Gadam, A. and Jama, H. 2009, Child Labor and Sexual Assault Among Girls in Maiduguri, Nigeria, International Journal of Gynecology and Obstetrics, 104:4, 64-67. Austrian, K. and Muthanjai, E. 2014, Can Economic Assets Increase Girls' Risk of Sexual Harassment? Evaluation Results from a Social, Health, and Economic Asset Building Intervention for Vulnerable Adolescent Girls in Uganda, Children and Youth Services Review, 47, 168-175. Australian Royal Commission into Institutional Abuse, 2017, Volume 6, 7 and 8 available at https://www.childabusroyalcommission.gov.or/ Child Safe Institutions. Averdijk, M. Mueller-Johnson, K. and Eisner, M. 2011, Sexual Victimization Among Adolescents in Switzerland, UBS Optimus Foundation, Geneva. *Bailhutch, M. Leroy, V. Pilot, P. and Salmi, L. 2013, Is Early Detection of Abused Children Possible? A systematic review of the diagnostic accuracy of the identification of abused children. BMC Pediatrics, 13, 1, p. 202. Bailey, C., Mace, G., Powell, M., and Benson, M. 2015. Evaluation of a collaborative operation to improve child sexual abuse reporting in Western Australian Indigenous communities, criminal justice and behaviour, 42, 12, 1303-1315. By Oki, Emamandi, B. Langat, N. Boothroyd, D. et al., 2016, a behavior-based intervention that prevents sexual assault, the results of a matched pairs, cluster randomized study in Nairobi, Kenya. Prevention Science, August, DOI 10.1007/11121-016-07001-0. Asterisk bed, S. Chirue, E. McIntosh, C. Andazala, B. 2010, The Short-Term Impacts of a Schooling Conditional Cash Transfer Program on the Sexual Behavior of Young Women Policy Research Paper, World Bank, Washington. Asterisk Baker, C.K., Gleason, K., Norrie, R., Mitchell, J., and Trecker, C. 2013. Increasing Knowledge of Sexual Abuse, a Study with Elementary School Children in Hawaii, Research on Social Work Practice, 23, 2, 167-178. Baker, A. 2005, Are Standards Becoming Standard Operating Procedures? An International Update, International Business Ethics Review, 8-1, Spring/Summer Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Ending Child Sexual Abuse and Exploitation, A Review of the Evidence 193. Bala, S. 2018, General Children's Participation Criteria, Save the Children, Albania. Ball, B. Kierig, P. and Rosenbluth, B. 2009, Like a Family But Better. Because you can actually trust each other, the Expect Respect. Dating Violence Prevention Program for At-Risk Youth, Health Promotion. Practice, 10-1, 4558. Bandira, O'Brien, N. Burgess, R. Goldstein, Emmett A.L. 2012. Empowering Adolescent Girls, Evidence from a Randomized Control Trial. In Uganda, Working Paper. London School of Economics and Political Science, Suntory and Toyota International Centres for Economics and Related Disciplines, London, UK. Asterisk Bandira, O'Brien, N. Burgess, R. Goldstein, M. Gulesi, S. Rajal. Suleimani, M. 2018, Women's Empowerment in Action, Evidence. From a Randomized Control Trial in Africa, English. Washington, D.C. World Bank Group. Banerjee, S.R., P. Bharati, T.S. Vajaluit A.L., 2008, Whole-Time Domestic Child Labor in Metropolitan City of Kolkata, Indian Pediatrics, 45, 57982. Barker, G., Contreras, J. Hellman, B. et al., 2011, Evolving Men. Initial results from the International Men and Gender Equality Survey. Images, International Center for Research on Women, ICRW. Washington, D.C. and Instituto Pro Mundo, Rio de Janeiro. Bernardos, 2011, Puppet on a String, The Urgent Need to Cut Children Free from Sexual Exploitation, Bernardos, Barkingside. Bernardos, 2012, Tackling Child Sexual Exploitation, Helping Local Authorities to Develop Effective Responses, Bernardos, Barkingside. Bath, J., Burmace, L. Hine, E. Trell, S. Antonia, T. 2012, The Current Prevalence of Child Sexual Abuse Worldwide, A Systematic Review and Meta-Analysis, International Journal of Public Health, 58, 3, 46983. Barr L., Knight L., Frana Jr. I., IT. A.L. 2017, Methods to Increase Reporting of childhood sexual abuse in surveys, the sensitivity and specificity of face-to-face interviews versus a sealed envelope method in Ugandan primary school children. BMC Int Health Hum Rights. February 23, 17, 14. Barter, C. McCarry, M. Berridge, D. and Evans, K. 2009, Partner Exploitation and Violence in Teenage Intimate Relationships, NSPCC, London. Barter, C. Stanley, N. Wood, M. et al., 2017, Young People's Online and Face-to-Face Experiences of Interpersonal Violence and Abuse and Their Subjective Impact Across 5 European Countries, Psychology of Violence, 7-3, 375-384. Basile, K. Hamburger, M. Swan, M. and Choi, C. 2013, Sexual Violence Perpetration by Adolescents in Dating versus Same-Sex Peer Relationships, Differences in Associated Risk and Protective Factors. Western Journal of Emergency Medicine, 14-4, 32940. Bastic, M. Grimm, K. and Kunz, R. 2010, Sexual Violence in Armed Conflict. Global Overview and Implications for the Security Sector, Geneva Center for the Democratic Control of Armed Forces, DCAF, Geneva. Bates, A. Saunders, R. Wilson, C. 2007, Doing Something About It, A. Follow-up study of sex offenders participating in Thames Valley Circles of Support and Accountability. British Journal of Community Justice 5, 19-42. Bebbington, P. Jonas, S. Kuipers, E. et al. 2011, Child Sexual Abuse. Reported by an English National Sample, Characteristics and Demography. Social Psychiatry and Psychiatric Epidemiology, 46:3,25562. Beckett, H. 2011, Not a World Away, The Sexual Exploitation of Children and Young People in Northern Ireland, Barbados, Northern Ireland, Belfast. Beckett, H. I. Brodie, F. Factor, M. Melrose et al., 2012, Research into Gang-Associated Sexual Exploitation and Sexual Violence, Interim Report, University of Bedfordshire, Luton, UK. Beach, A. and Ward, T. 2004, The Integration of Etiology and Risk in Sexual Offenders, A Theoretical Framework, Aggression and Violent Behavior, 10-1, 3163. Beach, A. Elliott, I. Bergden, A. and Find Later, D. 2008, The Internet and Child Sexual Offending, A Criminological Review, Aggression and Violent Behavior, 13-3, 21628. Asterisk Bayer, K. Grundman, D. Kuhl, Elskaner, G. Conrad, A. and Amalang, T. 2015, The German Dunkelfeld Project, a pilot study to prevent child sexual abuse and the use of child abusive images. Journal of Sexual Medicine, 12:2, 529-542. Bayer, K. U. Mutt, C. Isdemir, C. Schlinzig, E. Grohl, A. Hupp, E. Helens-Schmidt. T. 2016, Just Dreaming of Them, The Berlin Project for Primary Prevention of Child Sexual Abuse by Juveniles, PPJ, Child Abuse and Neglect, 52, 1-10. Bulski, J. 1980, Child Maltreatment, An Ecological Integration. American Psychologist, 35:4, 32035. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 194. Bulski, J. 1993, Etiology of Child Maltreatment, a Developmental Ecological Analysis, Psychological Bulletin, 114:3, 41334. Benya, L.R., Hawk-Filho, N., Dillenberg, M., and Stein, L.M. 2015, The NICD Investigative Interview Protocol, a Meta-Analytic Review, Journal of Child Sexual Abuse, 24, 3, pp. 259-279. Benelli, P. Fikiri, A. and Dumrai, Z. 2019, Voicing the Needs and Priorities of Children Living in Conflict in the Democratic Republic of Congo, Save the Children, DRC. Bennett, L. Ruger, P. Skew, A. Howard, S. and Wasco, S. 2004. Effectiveness of Hotline, Advocacy, Counseling, and Shelter Services for Victims of Domestic Violence, a Statewide Evaluation, Journal of Interpersonal Violence, 1907, 81529. Bentley, H. Burrows, A. Clark, L. Gilligan, A. et al., 2018, How Safe Are Our Children, NSPCC, London. Bentovim, A. Cox, A. Bingley Miller, L. and Pitsey, S. 2009. Safeguarding Children Living with Trauma and Family Violence. Evidence-Based Assessment, Analysis and Planning Interventions. Jessica Kingsley Publishers, London. Bentovim A. and Elliot I. 2014, Hope for Children and Families. Targeting Abusive Parenting and the Associated Impairment of Children. Journal of Clinical Child and Adolescent Psychology 43:2, 27285. Benito, L.T., and O'Donoghue, W. 2015, Treatment of the Sexually Abused Child, Review and Synthesis of Recent Meta-Analyses, Children and Youth Services Review, 56, 52-60. Birolowitz, S., C. Furman, G. Edwards and Esculatlu, 2012, I Thought I Was the only one in the world, the Office of the Children's Commissioner's Inquiry into Child Sexual Exploitation in Gangs and Groups Interim Report, Office of the Children's Commissioner, London. Bevington, D., Fuggle, P., Finnergy, P., Target, M., Anderson, E. 2013. Innovations in Practice, Adolescent Mentalization-Based Integrative Therapy, AMBIT, a new integrated approach to working with the most hard-to-reach adolescents with severe complex mental health needs, Child and Adolescent Mental Health, 18-1, 4651. Baba, J. 2013, Child Migration and Human Rights in a Global Age. Princeton University Press, Princeton, New Jersey. Bertisel, I. Floyd, S. Machingara, A. Gregson, S. and Glynn, J. 2008. From Affected to Infected. Orphanhood and HIV Risk Among Female Adolescents in Urban Zimbabwe, AIDS, 22:6,75966. Bisson, J. Roberts, N.P., Andrew, M., Cooper, R. and Lewis, C. 2013. Psychological therapies for chronic post-traumatic stress disorder. PTSD, in adults, Cochrane Database of Systematic Reviews, 1312. CD 003388. Do 10.1002/1465185.CD 003388.pub4. Seth, I. and Sabo, A. 2018, Sexual Violence Against Children in Sports and Exercise, a Systematic Literature Review, Journal of Child Sexual Abuse, 27:4, 365-385. Black, D. Smithslip, A. and Heyman, R. 2001, Risk Factors for Child Sexual Abuse, Aggression and Violent Behavior, 6.23,189,201. Blackley, R. and Bartels, L. 2018, Sentencing and Treatment of Juvenile Sex Offenders in Australia, Trends and Issues in Crime and Criminal Justice. Number 555, July, Australian Gift/Australian Institute of Criminology. * Blair, R. Chang, J. Putman, K. Jiguis, S. and Jun, O. 2017, A Review of Sexual Trauma Treatment in Cambodia, Journal of Behavioral and Social Sciences, 41-10. Blakemore, T. Herbert, J. Arney, F. and Parkinson, F. 2017, The Impacts of Institutional Child Sexual Abuse, A Rapid Review of the Evidence, Child Abuse and Neglect, 74, 35-48. Blackley, R. and Bartels, L. 2018, Sentencing and Treatment of Juvenile Sex Offenders in Australia, Trends and Issues in Crime and Criminal Justice. 555, July, Australian Government/Australian Institute of Criminology. * Bomb, B. Zollner, H., Fegert, J. M., and Liabat, H. 2014, Child Sexual Abuse in the Context of the Roman Catholic Church, A Review of Literature from 1981 to 2013 Journal of Child Sexual Abuse, 23:6, 635-656. Bolitho, J., and Freeman, K. 2016, Use and Effectiveness of Restorative Justice in Criminal Justice Systems Following Child Sexual Abuse or Comparable Harms, Royal Commission into Institutional Responses to Child Sexual Abuse, Sydney. Bolt, C. 1993, The Women's Movement in the United States and Britain from the 1790s to the 1920s, Harvester/Wheat Sheaf, London. Bornakid, K. 2010, Sexual Offender Laws and Prevention of Sexual Violence or Recidivism American Journal of Public Health 1, 3, 412-419. Baldwin, C.M., Schiefer, C.M., and Heiblum, N. 2009, A Randomized Clinical Trial of Multisystemic Therapy with Juvenile Sexual Offenders. Effects on Youth Social Ecology and Criminal Activity, Journal of Consulting and Clinical Psychology, 77, 2637. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Ending Child Sexual Abuse and Exploitation, A Review of the Evidence 195. Bott, S. Morrison, O. and Ellsberg, M. 2005, Preventing and Responding to Gender-Based Violence in Middle and Low-Income Countries, a Global Review and Analysis, World Bank Policy Research Paper WPS 3618, World Bank, Washington, D.C., June. Bott, S. Geeds, A. Claremont, C. and Gesms, A. 2010, Improving the Health Sector Response to Gender-Based Violence, a Resource Manual for Healthcare Professionals in Developing Countries, International Planned Parenthood Federation, New York. Bott, S. Geeds, A. Goodwin, M. and Adams Mendoza, J. 2012. Violence Against Women in Latin America and the Caribbean, A. Comparative Analysis of Population-Based Data from 12 Countries, Pan American Health Organization and the Centers for Disease Control and Prevention, Washington, D.C. * Bounds, L. Edinburgh, L. Fogg, L. and Sick, E. 2019, A Nurse Practitioner-Led Intervention for Runaway Adolescents Who Have Been Sexually Assaulted or Sexually Exploited, Effects on Trauma Symptoms, Suicidality and Self-Injury, Child Abuse and Neglect, 1999-107. Buch, M. and Hernandez, A. 2009, The Butner Study Redux, a report of the incidence of hands-on child victimization by child pornography. Offenders, Journal of Family Violence, 24,18391. Buch, M. Prestridge, D. and Maltera, M. 2016, Interdiction for the Protection of Children, Preventing Sexual Exploitation. 1 Traffic Stop at a Time, Aggression and Violent Behavior, 30, 68-75. Bovanik S., McNeish D., Pierce J. 2016, Outreach Work, Child Sexual Exploitation, A Rapid Evidence Assessment. Bernardo's Barkingside. Bovanik, S., Pierce, D., Warrington, C. and Pierce, J. 2018, Being Heard. Promoting Children and Young People's Involvement in Participatory Research on Sexual Violence. Luton, University of Bedfordshire. Brackenridge, C. Fasting, K. Kirby, S. and Lee, T. 2010, Protecting Children from Violence in Sport, a review with a focus on industrialized countries, Eunice Finneson T. Research Center, Florence. Braithwaite, J. 1989, Crime, Shame and Reintegration, Cambridge. University Press, Cambridge. Braithwaite, J. and Daly, K. 1994, Masculinities, Violence and Communitarian Control, in Just Boys Doing Business. Men, Masculinity and Crime, edited by Tim Newburn and Elizabeth Ostanko, Routledge, London, pp. 189213. Bratton, S. Ray, S. Rhine. T. and Jones, L. 2005, The Efficacy of Play Therapy with Children, a Meta-Analytic Review of Treatment Outcomes. Professional Psychology, Research and Practice, 36, 4, 37690. Brecklin, L. and Ford, D. 2001, A Meta-Analysis of Rape Education Programs, Violence and Victims, 16-3, 30321. Bredding, M. Reza, Agulade J. Blanton, C. Mercy, J. Dahlberg, L. Dlamini, N. and Bamra, S. 2011, Risk Factors Associated with Sexual Violence Towards Girls in Swaziland, Bulletin of the World Health Organization, 89:203-210. Brennick, it al. 2014, Empowering Children with Safety Skills, an evaluation of the Kid Power Everyday Safety Skills Program, Children and Youth Services Review 44, 152-162. Bress J. Kashmwaji, Amiz it al. 2019, Delivering Integrated Care After Sexual Violence in the Democratic Republic of the Congo. BMJ Glob Health 4E001120. Do 10.1136/BMJGH 2018-01120. Bry, J. and Elliott, D. 2003, Prevalence and Psychological Sequelae of Self-Reported Childhood Physical and Sexual Abuse in a General Population. Sample of Men and Women, Child Abuse and Neglect, 27 hours 10 minutes, 1205-22. Brilliance Evangelista, G. 2013, An Evaluation of Visual Arts and Poetry as Therapeutic Interventions with Abused Adolescents, The Arts in Psychotherapy, 41, February, 7184. Brody, I. and Pierce, J. 2017, Violence and Alternative Care, A Rapid Review of the Evidence, Psychology, Health and Medicine, 22 Sup 1, 254-265. Brody, I. Spring, D. Hines, P. Burland, P. Dew, J. Ghani L. Tran. H. T. Lenger, V. and Thurnham, A. 2018, Vulnerability to Human Trafficking. A Study of Vietnam, Albania and Nigeria Literature Review, IOM and University of Bedfordshire, London. Bronfenbrenner, U. 1977, Toward an Experimental Ecology of Human Development, American Psychologist, 32-7, July, 51351. Bronfenbrenner, U. 1986, Ecology of the Family as a Context for Human Development, Research Perspectives, Developmental Psychology, 22:6, 72342. Brown, A. Jago, N. K. J. McNaughton Nichols, C. Pascal, C. and Webster, S. 2014, Call to Keep Children Safe from Sexual Abuse, A Study of the Use and Effects of the Stop It Now! UK and Ireland Helpline. London, NAT Centre, available at http://www.natson.ac.uk/media/3388005/ Stop It Now UK Findings.pdf. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Ending Child Sexual Abuse and Exploitation, A Review of the Evidence 196. Branovskis, A. and Surtees, R. 2007, Leaving the Past Behind. When Victims of Trafficking Decline Assistance, FAFO AIS and Nexus Institute, Oslo and Vienna. Bryant, S. Peck, M. and Lufbach, J. 2015, Reoffending Analysis of MAPA. Eligible Offenders, Ministry of Justice, London. https://assets.publishing service.gov.uk/government/uploads/system/uploads/attachment_data/ file/40719/reoffending analysis of mapper eligible offenders.pdf. Bryant, K. and Lanman, T. 2020, Combating Human Trafficking Since Palermo, What Do We Know About What Works? Journal of Human Trafficking, 119-140, DOI 10.1024/233227005.2020.1690097. Budd, K. Mancini, C. and Brie, D. 2019, Parks, Playgrounds, and Incidents of Sexual Assault, Sexual Abuse, 31:5, 58606. Buller, A. Pichon, M. McAlpine, A. CSAE, B. Hayes, L. and Makesin, R. 2020, Systematic Review of Social Norms, Attitudes, and Factual Beliefs. Linked to the sexual exploitation of children and adolescents, child abuse and neglect. Buller, A. Peterman, A. Ranganathan, M. Blyle, A. Hidrobo, M. and Hayes, L. 2018, A Mixed Method Review of Cash Transfers and Intimate Partner Violence in Low and Middle Income Countries. Technical Report. LSHTM. Bunting, L. 2007, Dealing with a Problem That Doesn't Exist. Professional Responses to Female Perpetrated Child Sexual Abuse, Child Abuse Review, 16, 25267. Bureau of Population, 2006, Refugees and Migration, Life After Reintegration, The Situation of Child Trafficking Survivors Part 1 and 2. International Organization for Migration, Phnom Penh. Burton, D. Duty, K. and Leibowitz, G. 2011, Differences between sexually victimized and non-sexually victimized male adolescent sexual abusers. Developmental Antecedents and Behavioral Comparisons, Journal of Child Sexual Abuse, 20.1, 7793. Burton, P. Ward, C. Arts, L. and Leo Schutt, L. 2015, Research Bulletin. The Optimus Study on Child Abuse, Violence and Neglect in South Africa, UBS Optimus Foundation http://www.cjcp.org.za/ uploads/2/7/4/2/784/54614/cjcp_ubs_web.pdf. Bustamante, G. Soledad Andrade, M. Mikesell, C. Cullen, C. Endra, P. Bernio, V. Yepes, P. Saavedra, A. Ponce, P. Grunauer, M. 2019, I Have the Right to Feel Safe, Evaluation of a School-Based Child Sexual Abuse Prevention Program in Ecuador, Child Abuse and Neglect, 91, 31-40. Bouchard, Afini Harvey, Amian, M. and Furness, T. 2006. Preventing Child Maltreatment, A Guide to Taking Action and Generating Evidence, World Health Organization, Geneva. Butler, A. 2013, Child Sexual Assault, Risk Factors for Girls, Child Abuse and Neglect, 37, 9, 64353. Byrne, J. Cardifeltwinther, D. Livingston, S. Stoylova, M. 2016, Global Kids Online Research Synthesis 2015-2016. UNISF Office of Research. Innocenti and London School of Economics and Political Science. Cambodia, 2017, Action Plan on Violence Against Children, Phnom Penh, Cambodia. Campbell, J. and Leroux, C. 2002, Juvenile Sex Offenders in Diversion. Sexual Abuse, 14, 1-17. Kant, R. O'Donnell, M. Sims, S. and Harries, M. 2019, Overcrowded Housing, one of a constellation of vulnerabilities for child sexual abuse. Child Abuse and Neglect, 93, 239-248. Cantwell, N., Davidson, J., Elsley, S., Milligan, I. and Quinn, N. 2012. Moving Forward, Implementing the Guidelines for the Alternative Care of Children. UK, Centre for Excellence for Looked After Children in Scotland, Centre for Excellence for Looked After Children in Scotland. University of Strathclyde, Glasgow, Scotland. Carlson, C. Nami, S. Norsinai Palla, et al., 2020, Violence Against Children and Intimate Partner Violence Against Women, Overlap and Common Contributing Factors Among Caregiver Adolescent DIDS, BMC. Public Health, 21-4. Carpentier, M.Y., Silufsky, J.F., and Chaffin, M. 2006. Randomized Trial of Treatment for Children with Sexual Behavior Problems, 10-year. Follow-up, Journal of Consulting and Clinical Psychology, 74, 3, 482-488. Casey, L. 2015, Report of Inspection of Rotherham Metropolitan Borough Council, London, Department for Communities and Local Government. CCF, 2008, Starting Up Child-Centered Spaces in Emergencies, a Field Manual Christian Children's Fund, Richmond, VA. CDC, 2014, Violence Against Children in Haiti, Findings from a National Survey 2012 U.S. Centers for Disease Control and Prevention, Interuniversity Institute for Research and Development, Comité Coordination, Centers for Disease Control and Prevention, Port-au-Prince, Haiti. Cedarburg, A.C., and Lamb, M.E. 2006. How does the legal system respond when children with learning difficulties are victimized? Child Abuse and Neglect, 30, 5, pp. 537-547. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 197. Cepeda I. Lacalle Calderon, M. and Toralba, M. 2017, Microfinance and Violence Against Women in Rural Guatemala, Journal of Interpersonal Violence, 123. CERT, Center for Educational Research and Training, and DevTech Systems, Incorporated. 2008, The Safe Schools Program, a qualitative study to examine school-related gender-based violence in Malawi, UCED, January. Cicerone, C. 2001, Releasing Sex Offenders into the Community. through circles of support, a means of reintegrating the worst of the worst. Journal of Offender Rehabilitation, 34:2, 85-98. J. S. and NGO, T. 2017, The Global State of Evidence on Interventions to Prevent Child Marriage, Girl Center Research Brief, No. 1. Population Council, New York. Chan, E. McNeil, D. and Bunda, R. 2016, Sex Offenders in the Digital Age. Journal of the American Academy of Psychiatry and the Law, 44:3, 368-75. Kemtab, C. Nakashima, J. and Carlson, J. 2002, Brief Treatment for Elementary School Children with Disaster-Related Post-Traumatic Stress Disorder, a Field Study, Journal of Clinical Psychology, 58, 1, 99112. Chen, L., H. Murad, M. Paras, K. Kolbenser, et al. 2010, Sexual Abuse and Lifetime Diagnosis of Psychiatric Disorders, Systematic Review and Meta-Analysis, Mayo Clinic Proceedings, 85:7, 61829. Chengfang, Yan, Maisang Yang, Mingzhen Yang, Yiqing Su et al. 2008. Childhood Physical and Sexual Abuse, Prevalence and Correlates Among Adolescents Living in Rural Taiwan, Child Abuse and Neglect, 32:3, 42938. Child, J. Naker, D. Horton, J. Warlake-Ira, E. DeVries, K. 2014, Responding to Abuse, Children's Experiences of Child Protection in a Central District. Uganda, Child Abuse and Neglect 38, 1647-1658. Child Protection Working Group, 2012, Minimum Standards for Child Protection in Humanitarian Action, CPWG, New York. Childline India Foundation, 2011, Annual Report CIF, Mumbai. Children's Commissioner, 2015, Barnahus, Improving the Response to Child Sexual Abuse in England, Children's Commissioner, London. Chiodo, D. Wolf, D. Crooks, C. Hughes, R. and G. P. 2009. Impact of Sexual Harassment Victimization by Peers on Subsequent Adolescent Victimization and Adjustment, a Longitudinal Study. Journal of Adolescent Health, 45:3, 246252. Kpatar, B. and Daladin, E. 2009, Mapping Evidence-Based Treatments for Children and Adolescents, Application of the Distillation and Matching Model to 615 treatments from 322 randomized trials. Journal of Consulting and Clinical Psychology, 77:3, 566579. Chowdhury v. Satapathy S. Sagar R. 2016, Review of Randomized Controlled Trials on Psychological Interventions in Child Sexual Abuse. Current Status and Emerging Needs in the Indian Context. Indian Journal of Psychological Medicine 38:279-84. Chowdhury v. Dale R. Pillai D. Kalokars, Bayer K. Patel v. 2018, Child Sexual Abuse in India, a Systematic Review. PLOS 1-1310, E02050886. Chung, Kamfong M., Stevenson, K. and Lung, P. 1991, Competency. based evaluation of case management skills in child sexual abuse. Intervention, Child Welfare League of America, July-August, 42535. Christian Aid, CAFOD, Tear Fund, and Islamic Relief, 2015, Keeping the Faith, The Role of Faith Leaders in the Ebola Response, London. Christian Aid. http://learn.tearfund.org/tilde/media/tis/research/. Keeping_the_faith_July_2015.pdf. Christiane Zen, L. and Darling, A. 2019, Sexual Abuse by Educators. A comparison between male and female teachers who sexually abuse students. Journal of Sexual Aggression, DOI. 10.10852600.2019.1616119. CISP Comitato Internacional per lo Sviluppo dei Popoli, 2019, CISP. Approach to Child Protection, Models, Promising Practices and Success Stories from Kenya, CISP International Committee for the Development of People, Kenya. *Cisna, A. and Hassan Elaub, L. 2014, Building Healthy Teen Relationships, an evaluation of the fourth R curriculum with middle school students in the Bronx, U.S. Department of Justice, New York. Site Arctunk, G. It al. 2018, Preventing Child Sexual Abuse, Body Safety Training for Young Children in Turkey. Journal of Child Sexual Abuse, 27, 4p 347-364. Clausen, H. and Dutch, N. 2008, Case Management and the Victim of Human Trafficking, a Critical Service for Client Success, U.S. Department for Health and Human Services, Office of the Assistant Secretary for Planning and Evaluation, Washington, D.C. Clayton, E.W., Krugman, R. and Simon, P. eds. 2013. Confronting Commercial Child Sexual Exploitation and Sex Trafficking of Minors in the United States. Washington, D.C., Institute of Medicine, and National Research Council of the National Academies. Contents Section 1, Section 2, Section 3, Section 4, Section 5, Section 6, Section 7, Section 8, Section 9. References. Ending Child Sexual Abuse and Exploitation, a Review of the Evidence 198. Kluver, L. Boys, M. Orkin, M. Pantelic, M. Molwiner, T. Shea, L. 2013 A. Child-Focused State Cash Transfers and Adolescent Risk of HIV Infection in South Africa, a Propensity Score Matched Case Control Study, Lancet Global Health, 1, E. 362-70. Kluver, L. Orkin, M. Boys, M. Shea, L. et al. 2013 B. Pathways from Parental Aids to Child Psychological, Educational and Sexual Risk. Developing an empirical-based interactive theoretical model, Social Science and Medicine, 87, 18393. Cody, C. 2017, Connecting the Dots, Supporting the Recovery and Reintegration of Children Affected by Sexual Exploitation, Thematic Report, ECPAT International, Bangkok, Thailand. Co. 2009, Recommendation of the Committee of Ministers to Member States on Integrated National Strategies for the Protection of Children from Violence, Council of Europe, available from https://wcd.co.int/view.doc.jsp, ID equals 1539717. CSAE Command and British Embassy, Hanoi, 2011, The Trafficking of Women and Children from Vietnam, CSAE Command, London. Cohen J. Manarino AP, Deblinger E. 2001, Child and Parent Trauma. Focused Cognitive Behavioral Therapy Manual Philadelphia, Drexel University, College of Medicine. Cohen, J. Manarino, AP, and Knudsen, K. 2005, Treating Sexually Abused Children, 1-year follow-up of a randomized controlled trial, Child Abuse and Neglect, 29, to 135 to 145. Cohen, J. Manarino, AP, Perel, J. M., and Steron, V. 2007, a pilot randomized controlled trial of combined trauma-focused CBT and sertraline for childhood PSTD symptoms, Journal of the American Academy of Child and Adolescent Psychiatry, 46, 7, 811-819. Cohen, J. Deblinger, E. Manarino, A. and Stier, R. 2004, a multi-site, randomized controlled trial for children with sexual abuse related PTSD symptoms, Journal of the American Academy of Child and Adolescent Psychiatry, 43, 4, 393-402. Colin Vazina, D. Danio, I. and Herbert, M. 2013, Lessons Learned from Child Sexual Abuse Research, Prevalence, Outcomes, and Preventive Strategies, Child and Adolescent Psychiatry and Mental Health, 722. Colin Vazina, D. Sabloni, D. Palmer, A. and Milne, L. 2015, A Preliminary Mapping of Individual, Relational, and Social Factors that Impede Disclosure of Childhood Sexual Abuse, Child Abuse and Neglect, 43, 123134. Collings, S.J., Griffiths, S., and Kumalo, M. 2005. Patterns of Disclosure in Child Sexual Abuse, South African Journal of Psychology, 35, 272-85. Colombini M. Mayhew, S., and Watts, C. 2008, Health Sector Responses to Intimate Partner Violence in Low and Middle Income Settings, a Review of Current Models, Challenges and Opportunities, Bulletin of the World Health Organization, 86-8, 63542. Colombino, N., Mercado, C.C., Levinson, J., et al. 2011, Preventing Sexual Violence, Can Examination of Offense Location Inform Sex Crime Policy. International Journal of Law and Psychiatry 34, 3, 160-167. Colvin, C. 2009, Report on the Impact of SONC Gender Justice Networks. One Man Can Campaign in the Limpopo, Eastern Cape and KwaZulu Natal Provinces, South Africa, SONC Gender Justice Network, Cape Town. Conroy, L. Hobson, Z. Parks, R. and Reed, J. 2019, The Lighthouse. London's Child House Initial Evaluation Report, Moe Park Evidence and Insight, Mayor of London Office of Policing and Crime, London. Contreras, J. Bott, S. Geeds, A. and Dartnell, E. 2010, Sexual Violence in Latin America and the Caribbean, a desk review, Sexual Violence Research Initiative, SVI, Pretoria. Cordis Bright, 2016, Effectiveness of Anti-Slavery Training and Survivor Care Pathway, Final Evaluation Report. Welsh Government. http://www. cordisbright.co.uk/admin/resources/160808 Anti-Slavery Training Survivor Care Pathway en.pdf. *Cordisco, Teetsai, L. Von Theory, L. and Chantha, N. 2018, Experiences in Shelter Care, Perspectives from Participants in the Butterfly Longitudinal Study, Shabdai/Shaban Miles Memorial Library and Resource Center. Core, C. and Milagros Santos, R. 2017, Abuse and Young Children with Disabilities, a Review of the Literature, Journal of Early Intervention. 39 317. Karsar, J., Brandon, M., Bailey, S., Belderson, P. and Bigart, P. 2013. It takes a lot to build trust, recognition and telling, developing earlier routes to help for children and young people. London. The Children's Commissioner. Available at http://www.uea.ac.uk/ documents/3437903/0/OCC plus recognition and telling and report. PDF/923AEC11022214D548C77F83189E9E02D. Council of Europe, 2007a, Council of Europe Convention on the Protection of Children Against Sexual Exploitation and Sexual Abuse. Lanzarote Convention, Council of Europe Treaty Series, Sets, No. 201, the 25th of October, 2007. Contents Section 1 Section 2 Section 3 Section 4 Section 5 Section 6 Section 7 Section 8 Section 9 References